We are on live in this another exciting session at the SOLACI-CACI this year. We have a session together from Nanjing with the CBS and the people from the Nanjing First Hospital. Xiaolian Chen is probably one of the most important experts in bifurcation techniques, mainly in complex bifurcation techniques in left main. He do a great job in randomized trials in this subset of lesions. Complex bifurcation are not so frequent, but it's clear that in complex bifurcation we should need a bifurcation technique, either decay crash or culotte. The recent published definition 2 study, who we have the honor to be part of this study together with Ricardo Costa here at the panel and Imad Shaiban, clearly demonstrate that in complex bifurcation, if you use only provisional stent technique, you have more spontaneous myocardial infarction in comparison if we use either decay crash or culotte. So we are in this session, we have a great people in the panel. In the first part of the session, we are a live case from Nanjing. The panelists will be Ricardo Costa from Brazil, very well known, 3 great people from Argentina, Fernando Cura, Hugo Londero, and Gustavo Samaja, and Imad Shaiban from Italy, Arzon Tamber from USA, another 2 great experts in left main bifurcation. Tamber published a very well-known paper in JACC. I love the revision paper he published. I read every month. I read again the paper because I agree with all the things that he explained about left main technique. So we are, Xiaolian, are you at the CAT lab? We can start.
Well, thank you, friend. First of all, congratulations to the successful opening of SOLACI and CACI. I appreciate much more about the cooperation of CBS. It's so excellent to a well-known conference. Thank you, all friends from different regions, Imad, Tanvir. I also appreciate our Chinese team, Professor Ningguo, Professor Shen Xiantu, also Professor Zheng Ge. They will present some updates about complex PCI, particularly coming from China. So here I'd like to introduce my team. On my right side, Professor Junjie Zhang. I think you are very familiar with this guy. I also have 2 secondary assistants. So the IOS interpreter will be Mr. Chao Pan. So let's go through the case. So please, Dr. Zhang, to introduce the patient.
Okay, it's my great honor to introduce the case. So slide, please. Next.
Can you see the slides?
Can you see the slides, gentlemen?
Yes.
Okay. This was a 77 gentleman presented with a recurrent chest pain for 4 months and worsened for 20 days. His risk factor including essential hypertension and chronic smoking. After admitted, cardio biomarker show is negative, and also this patient has elevated NT-proBNP with a value more than 3,000. Echocardiography show impressed LVEF with a value of 32%, with a reduced moving of inferior wall. ECG also showed Q-Weaver in 2, 3, and AVF leaders. So clinical diagnosis for this patient was unstable angina and old inferior MI with poor AV function. Let me show you the angiogram for this patient. Actually, 5 days ago, we performed angiogram for this patient. CAG show is a typical triple vessel disease. You can notice for the RCA, at the middle part of RCA total occluded. So the first PCI I performed for the RCA lesions with a Gaia 2i across the middle RCA CTO lesion. Finally, we treated this lesion with a DCB 30 by 40 DCB for this particular lesion successfully. You can notice the TIMI flow is okay and the radius stenosis less than 30%. And this is left corner angiogram. You also can notice that it's a triple vessel disease, ostimal LAD, and also involve the middle and the distal LAD, and also involve two very big diagonal. The first and the second diagonal, it's truly complex bifurcation lesions. And also in terms of circumflex, you also notice the proximal total occluded. However, it's a non-dominant circumflex. So for the first PCI, considering there is a severe narrowing at the ostimal LAD, considering the safety issue, I performed the PTC for the ostimal LAD with a scoring balloon 2.75 to dilate the ostimal LAD. So this is the final result after predilation of the ostimal LAD. So today's target lesion is LAD diagonal 1 true bifurcation lesions and the LAD diagonal 2 true bifurcation lesions. And today, we also perform the QFR functional test for these particular lesions. You can notice that in terms of the distal LD, QFR was 0.46, and also for the distal diagonal, only 0.1. And also the second diagonal, the QFR was 0.26. Next. Following the suggestion of Professor Chen, we performed the predilation for the middle LAD with a 20 by 15 NC balloon. We inflate the balloon up to 24 atmosphere. Then we do the angio again. You can see the narrowing reduced, and we recheck the QFR for these lesions. And at this time, you can notice that in terms of diagonal 1, also severe impaired with 0.1. However, in terms of diagonal 2, the QFR, now we recovered to 0.82. And also for distal LD, it's okay, 0.74. So in terms of the definition of the complex diagonal 1 bifurcation lesions, according to the definition criteria proposed by Professor Chen, for LAD and the diagonal 1 bifurcation, I think it's a typical complex bifurcation lesions. So next. So today is our strategy for the LD diagonal 1 lesions. So provisional standing or two-stand technique. If we choose two-stand technique, DK crush or culotte. In terms of the procedure, what's your intracoronary imaging guidance you will choose, IVUS or OCT? That's all. Thanks for your attention.
Great case, my God. What would be your strategy, your plans?
Very extremely complicated cases.
Yeah.
Patient is old, reduced left ventricular function, increased level of NT-proBNP, angiography showed very tight stenosis as a proximal AD with 2 bifurcation lesion involving a first and second diagonal. After successful a PCI for right coronary artery, because the proximal AD is very, very critically diseased, so we perform balloon angioplasty using 3O scoring balloon. So can you see the angiography?
Yeah, very well.
Yeah, this is today's angiography show the model stenosis at the proximal AD. Actually, 3 days ago, we performed angioplasty for right coronary artery and proximal AD. So this is the epicranial. I think this is the best view to clearly separate the bifurcation lesion from AD and diagnose. So here you can see very, very severely diseased first diagonal with an aneurysm as the proximal segment of first diagonal. 2 lesion in first diagonal is very diffused So as Dr. Zhang introduced, they perform angioplasty ballooning predilation for RAD. And I think the very important point is the use of QFR. It's a quantitative flow ratio. It's innovated by Professor Shenzhen Tu. I think he will present something about this. This is a lattice software, so we can calculate QFR from single projection. This will be very convenient in CAS level to guide the standing decision. So after the predilation using 2O balloon for RAD, we repeated measure the QFR for second and first diagonal. So finally, the QFR of second diagonal was larger than 0.8. So even basically, we use a 3-wire RAD first and second diagonal. So I think we only need to protect the second diagonal with a gelled wire. But the key issues is for RAD and the first diagonal. It's also a complex coronary bifocal lesion according to definition criteria. So I think now is the time to open our discussion. Before that, immediately after predilation, I'd like to invite Ms. Topan to show you the IVUS for both RAD and the first diagonal. So this is the image. Switch to IVUS.
Yeah, okay. Hello, everyone. Let me.
Can you see IVUS image? Good. Okay.
Okay. Let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. Here we can see that the distal vessel is normal, and the vessel diameter is about 2.5 millimeter. And go on, we show the IVUS. We can see eccentric plaque. And go back. And here we can see the second diagonal joining LAD. And go back, we can see the calcified plaque in the middle LAD. And the vessel diameter is about 3.8 millimeter. And then go back, we draw the IVUS here. We can see the first diagonal joining LAD. And then go back. Here we can see the vessel is ectasa. The vessel diameter is more than 6 millimeter. Then go back. Here at the proximal LAD, the vessel diameter is about 4.5 millimeter. Then go back. Here we can see the circumflex joining the left main, and here is POC, and here is the distal left main. Then the left main vessel diameter is about 5.5 millimeter. After the predilation, let me show the minimum lumen area is just 1.9 square millimeter, and the plaque burden is more than 75%. At the distal left main, the area is 8.3 square millimeter, but the plaque burden is more than 68%. And the left main nest is just 7 millimeter, and the whole netness is about 49 millimeter from the distal reference to ostium left main. The netness from the distal reference to first diagonal and LAD bifurcation is about 27 millimeter. This is a result of LAD IVUS imaging. And then the second one, we check IVUS from the first diagonal to LAD. And here we can see that the distal reference is normal, and the vessel diameter is about 2.5. And then go back, we can see the calcified plaque in first diagonal. And then go back, this is the proximal first diagonal. You can see the vessel is ectasa. The mean vessel diameter is about 5.1 millimeter. Then go back, here is the ostium first diagonal. Here the area is 1.3 square millimeter, and the plaque burden is 76%. The netness is 43 millimeter from the distal landing node to ostium first diagonal. The netness is too long, and here we can find the proximal diagonal we can see find the landing rule. The plaque burden is not more than 50%, and the netness is just 15 millimeter. Okay, this is a baseline IVC imaging. Thank you.
Shaolin, couple of questions. How are you going to size based on the ectatic portion of the vessels, or both in diagonal and the LAD? And secondly, what's the experience with drug-coated balloons? Do you ever use it in ectatic segments? Because use of drug-coated balloons may actually make the aneurysm worse. So those are two questions I have for you.
Yeah, I think these are very, very challenging questions. You know, even DCB is popularly used in the mainland of China. Probably not only China but also Asian countries. But the selection and the indication of routine use of DCB is still challenging. So for the right coronary artery, because it's a total coded and also EKG confirmed the pathological Q levels. So from the history, EKG and also echo suggest the previous myocardial infarction in inferior wall. So I don't think we need to spend much more cost in coronary artery, even we did not measure the amount of a viable myocardium. This is the first thing. Secondly, you know, for this case, actually we also checked the IVOS for first diagonal. So from the IVOS images, the distal reference vessel diameter of RAD is around 2.5 millimeters. Because this is a very diffuse lesion starting from proximal to very distal segment of RAD. So I think first scan we have to start from distal part to the proximal landing zone just between first and second diagonal. The second scan for RAD should be 3.5. A little bit distal from distal to the first diagonal to the ostium of left main, because the left main is very huge. The vessel diameter is around 6 millimeters. So I think firehole scan is the best one to accommodate from 3.5 to 6. So here, because you know we have repeatedly measured QFR for second diagonal, it was negative. So we just protected the second wire. We started to use DK-Quash technique for RAD in the first diagonal. Another thing is that 35 minutes, I think, is not patient enough to show a real process of DK-Quash. So I try to shorten the discussion. So during your discussion, I started to deploy a 2.5 18 scan in first diagonal with almost 2 millimeter protrusion. And this is the three balloon to do first balloon quash. According to the IVOS, so the LAD diameter just distal to first diagonal is around 3.5. So after this balloon quash, I will shift to use 3.5 balloon to do one more balloon quash. Thank you.
Do you think, Shaolian, stent selection is crucial in this complex bifurcation? Because you need an open cells, easy access to the side branch?
Yeah, exactly. You know, a stent platform is very important for bifurcating lesion. Firehole stent, I think firehole stent is the #1 stent in China. So it has very large cell. A 3.5 is accommodating for a 2.5 to 4 side branch. So I think this is very good. Also, you know, we are doing DK-Quash. Also, we have tested the safety and efficacy of firehole stent in our DK-Quash 2 trial and also in Definition 2 trial. So thanks, Alfred joined us together. So I think we share the same experience about the feasibility of firehawk stent. So
Yeah,
after balloon quash, now I change it to use 3.5 balloon.
I
And
see.
also, you know, yeah, before balloon quash, I did not remove the diagonal wire. I think the previously wire is very important to guide the rewiring. This is the 3.5 balloon 10, 12. Okay.
Julian, can I make
Hi.
a question? Yeah, it's Ricardo Costa. from
Yes,
Brazil.
Ricardo Costa.
Okay. Thank you.
Great case. So I have a question. In the definition 2 trial, this was very well detailed, the technique and
Thank you.
some other recent studies. Do you recommend the first pot in the first crush after deploy the stent in the side branch? So you do have like a smaller balloon size to the proximal vessel instead of having, you know, a balloon across the bifurcation. And then you ended up with a second pot after deploying the stent in the main vessel and then recrossing, prior to recrossing, and then to finalize with a third pot. Is that what you do in your practice now? Do you recommend that?
Yeah, exactly. I think it's not your question, it's your recommendation. It's very, very important. You know, first quash is the balloon, is the undersize for the proximal main vessel. So after balloon quash, we need to use a second large balloon to do one more balloon quash. That's very important. So all these steps are to maintain, to conform the complete quash by the balloon. So this is a angiography immediately after second quash. From angiography, you can see there was no any sign of dissection just due to the first diagonal. So after second balloon quash, also, you know, Ricardo, for small side branch, if there is no any branch taken from side branch, so we can use the stent balloon to optimize the side stent. Otherwise, if there is another larger side branch taken from side branch, we have to use a new non-compliant balloon to reshape the side stent. So,
and I think your point regarding the pot here, it's very important in, you know, in the type of anatomy you're dealing now with a very long diffuse lesion. So we start downstream like 2.5 and then you ended up with 6, you know, at the proximal segment. So I think that's a very important teaching point here you're making.
Yeah, here you can see I have successfully rewired the side branch. But I can feel very strong resistance from the wire tip. So I need to double check if the rewiring from the proximal part.
Which wire are you using?
Yeah, what's the wire?
BMW.
Oh, this is a BMW wire, a very traditional wire.
Yeah.
So I have to remove the wire from first diagonal and try to rewire again. Because the bifurcation angle is not too difficult to rewire, but we have to make sure the rewire from the proximal test.
Yeah.
Proximal UI.
Yeah. Also, you can see there is an aneurysm at the proximal part of first diagonal, so that will be a little bit challenging.
Yeah. Well, Xiaoliang, this is
Hi.
Hi.
Good morning.
I wonder how you will manage the malposition of the stent within the ectasia and diagonal. Would you go with a larger balloon in order to oppose the stent better in the proximal diagonal, or you will leave it like this?
Yeah, a very good point. Exactly, you know, after standing side branch, we have to make sure the optimal expansion of side stent. So after standing, you see we have two options. One is to use stent balloon, and the second one is to use another non-compliant balloon. The only goal is to maintain the optimal expansion. Same question to Ricardo's
Fernando
comments.
Cura?
Yes.
Yeah, this is a great case. Congratulations. It's a very challenging case. I have a couple of comments. First of all, my view in front of a bifurcation is that I might start with a strategy, but the strategy might change along with the case. In the case, I may change from a DK to another kind of strategy. So this is approach that I want to discuss with the panel. If you decide the strategy on front before starting, or you may change the strategy. The second is a question for the operators. I see how you're using QFR to assess. We are not familiar with QFR here in Argentina. Probably in Latin America also it's not very common. So if you can talk and explain you need to do QFR, if you need a special hardware.
Go ahead. Yeah, let me start from your second question. You know, FFR penetration rate in China is pretty low. I think less than 5%. I think there are two reasons for this. One is the cost. Second is the reshape of our company. So almost no staff frequently visit the hospital. As I said, QFR is pretty convenient. You know, we only need to rely on single projection from angiography. We don't need to use adenosine. Also, you know, pressure-wise is very costly. So I don't think the sensitivity and the specificity of QFR could be reached by 100%. But I think larger than 80% will be strong enough to guide our decision. So in this case, after repeated predilation, so the QFR in first diagnosis still less than 0.8. So I think this is another very strong reason for the selection of two-stent technique. For your first question, as Ricardo said, this is a very complex coronary bifurcation lesion. We have provided several randomized clinical studies to provide the very strong evidence to show the superiority of systematic two-stent to provenous stenting technique. Of course, every guy has their own personal favorite of two-stent technique. For me, I think DCAC CACI is much better. As we have studied in our DCAC CACI 3 study to compare DCAC and Coulomb stenting technique.
Yeah, in this case, in this particular case, you have a quite different size of the side branch to the main branch, no? So that is more favorable to use DK crash than Coulomb, for instance.
Yeah, from angiography, you can see I reused the 2.5 non-compliant balloon to recross to the side branch very smoothly. This is the inflation of 2.5 non-compliant balloon with another 3.0 balloon in the LAD. So now I think it's time to gently remove the LAD balloon and also the balloon from LAD. So I think this is one of the beauties of DCAC CACI for complex bifurcation lesion. So now we are going to do kissing balloon inflation. 210. So you can see the third line, second diagonal was not removed before kissing balloon inflation because no stent strut in the LAD, no worry about the stock of second diagonal wire. So I think we have finished the first kissing balloon inflation. By the way, Alfred, how many time left for the live case?
We have time, yes.
We have time?
We are. Let me check. Exactly.
Oh, thank you. I think we can finish the case.
We have 5 minutes left. We have 5 minutes left. Ezequiel, is that right? 5 minutes left?
I think 5 minutes.
I'd like to ask for your, if possible, to have your comments on the EBC main study recently published and presented at the EuroPCR.
Yeah, actually, Ricardo, I have many comments. This year we have done several sub-sessions about the comments for EBC main study. Basically, the study was defined as a superiority trial. So it means the initiative of the EBC main study is to confirm the superiority of provisional over two-stent technique. But finally, they got the negative result. It means no difference between provisional and the two-stent technique. So from the standpoint of trial design, it's a failure of clinical trial. Even they got the negative result, but they could not say provisional is non-inferior to two-stent technique. This is a tip of clinical trial. Second thing is that almost more than 50% of two-stent technique are culotte stent technique, because we have tested the efficacy of DK quality over culotte. So I don't think the EBC main study has got a lot of evidence. But on the other hand, I think the general finding from EBC main trial is very similar to our DK quality 5 study. That's the culotte stent technique is inferior to DK quality, I think. What's your comment about EBC main, Ricardo?
Actually, I would add also to your comment that the EBC trial included a patient with not long lesion. If you compare the length of lesion on side branch, then side branch lesion in EBC trial is shorter than definition 2 trial or any.
Actually.
So this again, I support the Xiaoliang what he said. That means the failure of ABC to prove that provisional stenting is superior to two stents.
In complex bifurcation, no question about. I think it's true complex. Like we believe in the definition 2, you must perform a bifurcation technique. For me, it's real clear. If you look the data of myocardial infarction in definition 2, it was significantly lower compared to a single stent technique. If you look the data of the Excel trial, maybe the high incidence of spontaneous myocardial infarction in such trial was because the operator selected in most of cases single stent technique. So I think in complex left main on complex bifurcation, no question, you need a bifurcation technique. What do you think? Any comments for the panel about this?
I would just reinforce what Dr. Chapman said. I think most of the difference we have seen perhaps are related to the different degree of complexity. There are complexities and complexities. We all know that. Or Medina 111 can be extremely complex and can be extremely non-complex. So by what we saw in terms of the angiographic results and some of the descriptions, it looks like the EBC main has less complexity as compared to the DK Crash series in the definition 2. That's my
simple. That means EBC trial included simple stenosis, not complex.
Yeah, exactly. I fully agree. The average side branch lesion length was only 7 millimeters from EBC main. I think the result is very similar to the subgroup analysis from our DK quality 5 study. For the simple bifurcation subgroup, we also did not get the positive difference between provisional and two-stent technique. I think this is a true. Although no, our LAD stent was stuck in the middle part. So I tried to use balloon anchoring technique. So I removed the wire from the first diagonal. And I think there was no very strong, very severe calcification. But I think the guiding catheter not good. So I will I will change it to use another new guide wire. So I think the remaining steps are very simple.
Dr. Alvarez the digital moderator have some questions from the audience.
Yes.
Jose?
Arsan. Too long.
Can you hear me? Jose?
Yes, I can hear you, Alfredo. No, there are no questions from the audience at the moment.
Okay.
Just many greetings and congratulations for the case from the audience.
Okay. Yes, it's very tough case. I would like to ask the panelists, how many of you will reopen the right CTO previous to treat the left?
Okay. Test.
Alfredo, I think it is important to be sure that you can achieve complete revascularization in these cases. So I would start with the right coronary artery. If I will fail the right coronary artery, then the second option could be surgery in this case.
Okay. Great. Londero, Dr. Londero is...
Yes. First, the answer, yes, it is difficult to establish if I reanalyze the right coronary artery not having a more complete view of the artery. But in general, yes. But if it is simple, it is possible, but not all the right coronary artery. But I have another comment. Yesterday we were discussing in the protocol session the bifurcation technique at left main, and we agreed that in generally a busy cath lab done 20-30 cases a year, and not very busy, less than that, 20-10 a year. Then it's impossible to have experience in so many techniques that you can use. Then, in general, my recommendation is use two or three techniques and have experience with this technique. Probably provisional and tap stent is the first in which you must have experience. And in cases like this with a complex bifurcation, DICA technique is probably the best, but it's difficult to have experience in this technique to learn how to do it. Then probably take into account culotte for these complex lesions.
Yes, I fully agree with you. It's a learning curve. It's not easy to find this sort of cases in the daily practice. In fact, if we look our data in definition 2, most of our complex bifurcation have met the exclusion criteria of the study. It's not easy. It's not easy, and I agree the culotte is more easy. But you need. I love the culotte technique, but you need a similar size in the side branch, quite similar in the side branch to the main branch, and that is not the case. The side branch are smaller.
Thank you. You can see I have successfully deployed 2 5-hole stent. The first one is 2.5 by 23. Second one is 3.5 by 29. So a cosy stent has completely covered the ostium of left main. So I keep the guiding catheter semi-large to avoid to damage the stent. So after the second stent, I need to step by step to post-dilate the second stent. I will start from 3.0 non-compliant balloon to epicranial. Test, small test. Okay, inflation. I think this is the, here is the overlapping site, 3, 12, 14, 16, done.
Another comment regarding this case with a bifurcation stenting is the dual antiplatelet therapy. Even though some patients are not unstable, we for all bifurcations we work to a stronger regimen, ticagrelor or prasugrel for a year. I'm not sure if this is the experience of the operators, or if you are happy to keep clopidogrel on stable patients.
Yeah, actually, you know, so far there is no universal consensus about the DAPT duration after two-stent technique. But recently, Ricardo knows that we just published the one consortium about the DAPT duration for bifocal lesion published in Euro Intervention. But so far, there is no strong data. According to the pool of data, I strongly recommend to use 1 year DAPT after two-stent technique. So any comments from our panelists about the DAPT duration? Yes.
Well, I think it's reasonable.
In this case, I go with prasugrel, not ticagrelor. I prefer prasugrel because I think in patients in complex lesion subset, if the patient is candidate, in our experience, we use 100% prasugrel, not ticagrelor. I would like to listen the opinion of Aymat, Londero, and the other panelists about the APT.
Actually, it's reasonable. I mean, we are doing complex stenting with 2 stents to keep DAPT at least for 1 year after procedure. I would prefer, again, as you, prasugrel than ticagrelor. I think it is much more safe for the patient and much more under control. So I totally agree with prasugrel and aspirin for 1 year.
Yeah, but in China, you know, we don't have prasugrel. We only have clopidogrel and ticagrelor. So usually we prescribe aspirin plus ticagrelor for patient.
Well, actually, I mean, we do not have enough data showing that prasugrel is better than clopidogrel in this specific subset. Based on data coming from other studies, you might have some more advantage, a small advantage with prasugrel over clopidogrel, but the clopidogrel is still good enough to be used.
Yeah. If you look the data from large registries, at least in patients with acute coronary syndrome, prasugrel is better option than ticagrelor and clopidogrel. I would like to see the opinion, to hear the opinion of Tambert about this.
Sure.
So I think long-term powerful antiplatelet therapy is very important, particularly in patients with low bleeding risk. Certainly in the US, we are trying to move to just one agent after a year in complex PCI, such as ticagrelor generally, and as a single agent, as more data is available on the monotherapy with ticagrelor. 2 other comments. I think people who do left mains routinely are really the experts. I think this is not a game for somebody who does left main procedures. It's really somebody who's dedicated left main operators should be doing this, because I've seen people doing it different kind of ways. But if you follow the technique as Charlene and others have taught us, you will have good results. So it really is a dedicated left main operator who should be doing this. And the third thing I want to say is I don't think the EBC main really changed the way we approach complex left main lesions. I think our approach still remains the same with dedicated two-stent techniques, pretty decay crush for the complex left main bifurcation. So those are the three comments I have for you.
Shaolian, if you agree, I think we are on time. We have 3 speakers.
Okay.
Left. If you agree, we move for the Professor Xiang to give his speech, because we have 45 minutes left right now.
Okay, I see. Go ahead. I think this is the last step of final kissing. So go ahead for the lecture.
Great case. And very difficult. Okay. I invite Professor Xiang to give this. Okay. Here we are.
Thank you, Chairman. Can you see my slide?
Yes, perfectly.
Dear Chairman, dear colleague, thanks for inviting me to this interesting section. I have the privilege to present this topic, physiology assessment and bifurcation stenting. I come from Shanghai Jiaotong University. So this is my disclosure. We know that the EBC guideline recommend provisional sidebrain stenting is considered the standard approach for treatment of most bifurcation lesion. However, the recent data meta-analysis shows that decay cross was associated with fewer mass, mainly driven by low rate of repeat revascularization. To correct the choose the stent strategy, it's important to have a correct assessment. However, there are several studies showing that the in sidebrains, gel sidebrains lesion anatomical functional assessment frequently have mismatch, and seems that angiographic criteria overestimate the physiologic severity of the gel sidebrains lesion. And Professor Chen has shown us that FR-guided sidebrains intervention reduce unnecessary complex coronary intervention and instance of main vessel restenosis compared to angiographic guided strategy. On the other hand, the sidebrains obstacle lesion most time can also involve the bifurcation core. So we define this bifurcation core here. So in order to correctly assess the bifurcation, it's important to have a model to assess the bifurcation core together with the sidebrains obstacle. So we propose this model to quantify the bifurcation core more reliably. So we put the instead of measure the diameter in the same flat plane, so we have 2 diameters, actually combine them together, one in the main vessel and one in the sidebrains, and put them together. The same for the reference diameter, so we can more reliably quantify the bifurcation core. And these are 2 examples that we demonstrate. So this case, as you can see, this is true bifurcation lesion, and the model correctly identified the most severe position is at the bifurcation core here. And the red case, as you can see, is the diffuse proximal LAD lesion. So if you use the mid LAD or left main as the reference diameter, then you will either overestimate or underestimate the severity of the proximal LAD. However, in this model, we can use the bifurcation fractal law, and based on the size of the mid LAD and diagonal to get a more accurate estimation of the reference diameter at the proximal LAD, and you can clearly identify the most severe lesion is happening here instead. On the other hand, it's instead here. So by this model, we analyzed more than 70 bifurcation lesions, and we saw that even with the dedicated 3D bifurcation model, it can still and cannot reduce the discordance between anatomy and physiology. So no matter how dedicated of your anatomical assessment model, the discordance between anatomy and physiology will be there. So the image guideline consensus, not guideline, sorry, recommended physical assessment should be considered routinely prior to bifurcation intervention. However, there's some limitation using the wear-based FFR, especially the cost in the breast wear and also side breast wear access is technically challenging, as reported by two study. So over the last years, we proposed the angiographic-based FFR called 2FR as alternative to FR. So this solution has been integrated in the angioplasty system by Postmedical in Shanghai and also Angio accessibility by Medis. So both systems has the same algorithm, and we saw that in a couple of studies that using wear-based FFR as reference standard has a good diagnostic accuracy. However, this version has also some limitation. So first, especially for bifurcation, to get a second angiographic view with exposure the lesion is not easy. They will always have vessel overlap at the bifurcation there. So vessel overlap in the second angiographic can reduce the visibility. And second, the manual frame counting will increase the analysis time and analysis visibility. And lumen contouring might need manual correction and increase analysis time. And last, is important for bifurcation lesion assessment, because in the first version, we're using the stretch reference diameter, which would decrease the accuracy in analysis bifurcation lesion. I'm going to show is the figure. So it is the first generation QFR. So we assume the linear tapering reference diameter from proximal to distal. Then you can see at the bifurcation here, proximal to bifurcation, your underestimate severity, and distal to bifurcation core, your overestimate severity. So the second generation that I'm going to present, and the one technology just using by Professor Chen in his live case, is the second generation QFR. So it has the step down across the bifurcation, reference to the low lumen with step down function. So this one we call it second generation QFR, or we call it MIL QFR. It's powered by AI. So this is the solution we present the validation result this year in the journal of CCI. It's distributed by Postmedical in Shanghai. The software name is the Angio+ Core. So the new generation, the MIL QFR, is based only on a single projection. So this will improve the feasibility, so make the analysis easier. And second, it includes the side branch into analysis, so it will improve the diagnostic accuracy. And third, using automatic frame counting, using the AI to do the automatic frame counting, so improve the efficiency. So overall, the analysis time to get this analysis done at the moment when you receive the angio until you get the result done is about 1 minute. And you have the step down reference diameter, as I demonstrated before. So we validated this technology using the favor 2 China study population, in total 332 vessels in 308 patients. So we're able to compute the MIL QFR in 330 vessels in 306 patients and compare with wear-based FFR. So these are the correlation. So we obtain an excellent correlation between FFR and the MIL QFR. And overall, the mean difference is also very small. And MIL QFR could be obtained in all the cases. Absolute analysis time is 67 seconds. The diagnostic accuracy using FFR as a reference standard is 93%, which is significantly better than the diameter stenosis, as you are also seeing in the ROC curve here. Indeed, using another view, which is suboptimal angiographic view, could decrease the diagnostic accuracy of MIL QFR. However, it's still higher than diameter stenosis. So when the analysis was done by the same analyst 1 month later, or by the second analyst, we get a repeat measurement here with a standard deviation of 0.03. So this case we also did recently. So before standing is a bifurcation lesion, and the LAD and diagonal is all physiologically significant. So after standing, we measure the MIL QFR and also measure the wear-based FFR. In the LAD, the FFR is 0.89, the MIL QFR is 0.87, and the diagonal is the FFR is 0.85 and MIL QFR 0.86. So we saw good correlation. So together with the Dr. Ling Hong Shen from Shanghai Chest Hospital, we analyzed 315 lesions in 200 patients. The manuscript is currently under review, and we also assess the angiographic follow-up for about 1 year and define the primary endpoint as the target lesion failure. And these are the results. So we saw that post-procedure mu QFR at the side branch was correlated with the diameter stenosis at the side branch, and the mu QFR side branch assessed at angiographic follow-up. And the post-procedure mu QFR less than 0.80 was associated with 138-fold increase in target lesion failure gel side branch compared to the vessel with the mu QFR more than 0.80. So, ladies and gentlemen, computation of mu QFR from a single angiographic view has a high feasibility and excellent diagnostic accuracy in identifying hemodynamically significant coronary stenosis. The short analysis time and good reproducibility of mu QFR has the potential for wider adoption of physiology assessment in the test lab. And mu QFR can be a useful alternative for simultaneously anatomical and physiological evaluation of both the main vessel and side branch. And thank you for your attention.
Thank you, Professor. We have 5 minutes to discussion. Any comments from the panel? There is any comment, any questions from the panel about the presentation? I would like to ask, this device is a device coming with the RX machine, or is an additional device? Is it Chinese made, or is coming with the normal, the more well-known brands of X-ray?
Thanks for your question.
Because I didn't see, I just bought a new equipment here in Argentina but they don't give me the chance to select this sort of machine, because it's very interesting. It's quite nice. Looks very nice.
Thanks. Yeah, indeed, it has not been integrated with the external vendor yet. Currently, it's available only in China, and so in the coming years, it could be outside China. This is a new generation of mu QFR. Currently, it's only available in China.
Okay, because intermediate stenosis sometimes is very difficult to assess, no? Intermediate stenosis, and the FFR and IFR is expensive. I think the rate of use in Argentina, at least, is very, very low. Any comments about this presentation, Dr. Cigalini, Dr. Migliaro, Hayashi?
I'd like to ask if you have a comparative data with FFR, IFR. Do you have any?
Yeah, thanks for your comment. I think I saw in the slide in the presentation that we for this new generation we compare with the FFR data in 330 vessel. So there was good correlation and agreement there. But this 330 vessel are mainly all the bifurcation population is not dominant. So we still need to do more validation in the bifurcation lesion for the compared with the wire-based FFR.
What about multiple stenosis in the same vessel? I mean, how much good could be reliable this?
So in our previous study, we did not exclude the tandem lesion, so series lesion. I think it's okay. So if you have a very or if you have a couple of very severe lesion, then the QFR could be lower than the FR, but the FR is already very low. So clinically, there's not much difference. Well, there's less flow interaction between the lesion from QFR compared to the wire-based FR.
what is your cutoff value for your ischemic?
It's the same as the FFR. It's also 0.80.
0.80. And how does your QFR compare with CT FFR?
A good question. So actually, we have also developed
that's a very good question.
CT QFR and the OCT-based FFR. We call it OFR, and IVUS-based FFR called UFR. So in general, I think when you have a higher image resolution, then you will have a better result. For the CT QFR, our data shows that indeed the angio-based QFR would be better than the CT QFR because the resolution is better, especially in patients with calcified lesion. Because in calcified lesion, then the CT has difficulty to do the lumen contouring. Then the accuracy could decrease. If you don't have a if you don't have an extensive calcified lesion and you have a good CT acquisition, I think it's okay here.
You know, in the US, we'll have more of the CTA as a screening tool, chest pain coming to the emergency room, and I'm quite sure CTFR will follow. So just a screening tool, you will see a lot of patients coming to our emergency rooms. People are already investing in it because the radiation is low, the cost is low, and there's much less radiation than spectrothallium imaging, you know. So I think that will take a lot of prominence in the United States, at least.
Thanks. Yes, indeed. I think these two are actually not like replacing each other, but sometimes in some specific situation, then you need the CT. And in some case, for example, you have a ACS patient where the covered lesion will be treated anyway. You have also intermediate lesion in the non-covered vessel. Then in this case, maybe angio-based FFR would be more suitable.
I think we need more data to understand which is better and in which patient should be done.
Yeah.
I mean, maybe some subset will do better than IFR or FFR, but in other patients, IFR will be preferred on.
Could be, yeah.
Yeah, but we have to take in account that FFR also have limitations. Limitation in patients with aortic stenosis, multiple lesions, intermediate lesion is very hard to measure. So limitation with this kind of the devices is always present. No, it's not only here. It's with FFR and IFFR. Is also a limitation. I think that's is a very nice approach. Could be very nice approach. Of course, we will need much more experience. I have a comment from the audience here about at 1 year about the complex bifurcation lesions like Xiaolian is doing in the cath lab. How long did you keep the prasugrel, ticagrelor, or clopidogrel after 1 year? You stop single only monotherapy, DAPT lasts life forever. What is your approach?
Are you asking me?
Yes.
Go ahead, you ask.
No, go ahead, you. He asked you.
Actually, to be honest, after 1 year, we have no data to recommend the selection of DAPT or monotherapy. Basically, I prefer to use a ticagrelor after 1 year. But another point is that after 3 years, how to prescribe antiplatelet therapy for patients with bifurcation lesion. Alfred, could you give us 2 minutes to review the final results of the live test? Yeah, I think my team. Yeah, my team has finished the final testing. So can we switch to the cath lab?
Yeah, please. Go ahead.
Okay. Go to cath lab.
So before the coming of final angiography, regarding the QFR, I have two comments. I think both the angiography derived and the CT derived FR works well for most of patients, equally works well for patients. But in class level, only one choice of angiography derived QFR. For our bifurcation guys, I think the QFR is much better than any other kind of FFR or CTFR. Particularly, for bifurcation, for provisional standing technique, after standing main vessel, we had to immediate know the side branch QFR to guide our next step. Okay, I think the image is coming from CAS level.
I've done now. Next. So after 3.5 main vessel standing, Prof. Chen used 4.0 and 4.5 to do the post dilation of the proximal LAD and 4.5 for the left main port. Next. Okay, previous one. Then we secondary wind the side branch. Next. So you can see with the ankle balloon technique, we successfully advance the 2.5 NC balloon to the first diagonal and do the final kissing. Next. This is a sequential post dilation before we do the final kissing. So finally, we use a 3.5 and the 2.5 in LAD and the diagonal, do the final kissing with medial pressure. And finally, we do the 4.0 balloon for the proximal port and the 4.5 balloon for the left main port. Next. So this is the final result. From the angiography, you can see there is a waist at the middle LAD.
Oh my God.
So I decided to use a 3.5 balloon to do the post dilate. Next. 3.5 balloon up to 16 atmosphere. Next. And we also noticed there is an aneurysm at the proximal diagonal. So we decided to use a 3.0 short balloon to do the post dilation. Next. So before we finish the case, we still use a 4.0 balloon to do the post dilation. Let me show you the final angiogram. Yeah, this is the final angiogram. So this is what we have done. And we also checked the iris from the LAD.
Amazing results, Shaolian. Amazing.
Thank you. Thank you. Could you
Amazing.
show us?
Yeah.
Could you show us the iris image?
Sure.
Go ahead.
Xiaopan show the LAD iris image.
Yeah, at last we check iris from the distal LAD to left main. And the minimal stand area is 5 square millimeter. And the ostium of main vessel area is 8.3 square millimeter. And the distal main vessel area is 10.5 square millimeter. And then the ostium diagonal area is 5.3 square millimeter. Okay, this is the final result of iris imaging. Thank you.
How much was the minimal stent area in the left main?
Left main. Can you check the left main?
Okay, this is the left main.
How much?
MSA, yeah.
Wait a moment.
So I think it's quite large, more than 10.
12.
Perfect.
12.5, yeah.
So thank you, Dr. Zhang and whole team. Alfred, I think this is the final image, final iris for this live case.
Oh, great case. We have some questions from panelists, but we have. I believe that we don't have enough time because we have to move to the another two speakers. Shaolian, if you agree, we move to the next speaker.
Yeah, absolutely. Go ahead.
Next speaker is is Professor
矫正一下。
Senge, who is and the lecture is Importance of IBUS in Stenting Bifurcation Lesion.
Okay, can you see my slides?
Yes, perfect.
Oh, thank you. Ladies and gentlemen, I'm honored to here introduce my presentation. My topic is importance of IVUS in standing bifurcation lesions. I have nothing to disclose. Firstly, I would like to introduce the evidence that IVUS guiding PCI reduce the risk of MACE, and then talk about the application of IVUS in the bifurcation lesion standing. As we know, the IVUS will be used the guided PCI to the pre-procedure and the post-procedure and the follow-up. At the pre-procedure, we use the IVUS to assess the plaque, the characterization, and the reference segment and the stent size, and to confirm the landing zone. And the post-procedure, we can use IVUS to assess the stent expansion and the edge dilatation and the molar position and so on. And follow-up, we can use the IVUS to find the mechanism of stent failure. Our ultimate study showed that IVUS guided PCI associated with the reduction of the target vessel hernia and compared with the angioguided PCI in all common patients. Most importantly, ultimate study, we presented the 3 IVUS defined criteria for optimal stent deployment. That is MSA in stent segment greater than 5 millimeters square, and stent expansion greater than 9%, and the plaque burden at the stent edge less than 50%, and then low dissecting wall media with the length greater than 3 millimeters. This is the meta-analysis and included 9 randomized trials, and showed that IVUS guided PCI and reduced the risk of the MACE and the cardiac death and the stent thrombosis. So let's talk about the application of the IVUS in the bifurcation lesion and standing. Because the angiography is the limitation for the especially for the bifurcation lesions, you can use the IVUS to assess the plaque, the characterization, and the elective remodeling at the ostium of sun branch, and the plan in PCI strategy. So there's a controversy about the clinical outcomes IVUS guided PCI for bifurcation lesions. This is the post-hoc analysis from the data from the Columbia University Medical Center and our center and the Excel trial, and to explore the IVUS predictor for bailout circumflex standing after provisional standing for treatment of the distal left bifurcation lesions. As well as the bailout circumflex standing after provisional standing is common, 22% in Excel trial and 47% in the DK Crusher 5 trial. One previous study showed that bailout circumflex standing will lead to higher target lesion revascularization rates in circumflex. So this study aimed to develop the IVUS predicts to for the bailout standing for the circumflex. This is the follow chart and the inclusion criteria and exclusion criteria. Finally, the 12.6% patient bailout circumflex standing. And the multivariable regression and showed the austere circumflex MLA less than 4.5 millimeters square. And the austere circumflex calcified nodule and all distal lumen layer plaque is a 3 predictors to predict the bailout circumflex standing. So for if the 3 predictors will be defined by IFs, maybe planning the 2-stand strategy may be considered initially. So this data from our center, the change of the tension standing strategy after the guidance. 310 patients was classified the true bifurcation within a 111 or 0111 by the angiography estimation. By IF's estimation, we find that 59 patients were reclassified into false bifurcation lesions, and 110 patients were changed to the intention standing strategy by the IF's estimation. The 94 patients were changed from an intention 2-stand strategy to the single-stand strategy, and 16 patients were changed from the intention single-stand strategy to 2-stand strategy. So then talking about the controversial and the clinical outcomes, I've got the PCI for bifurcation lesions. This data from the Korea Multi-Center Bifurcation Registry and showed I've got the PCI for bifurcation lesions may helpful to improve long-term clinical outcomes. But from this study and by the Bandi and the Professor Shaban, and showed that no clinical benefits IV's usage during the PCR for coronary bifurcation lesions. Why these 2 studies have the different results? Maybe probably the patient with the side branch diameter greater than 2 millimeters were included, and the 4th bifurcation lesions was studied. And most importantly, the IV's criteria for optimal standing result were not described in these 2 studies. So this data from our center to show the IV's guided the PCI for the complex bifurcation. In this study, a patient with the complex bifurcation lesions, 111 and 0111, and the side branch diameter greater than 2.5 millimeters. And we pre-specified IV's optimal criteria for stent deployment and good position and stent expansion index greater than 0.9, and stent symmetry index greater than 0.7, and no greater than type B dissection. So this study flow chart, and we use the percentage score matching according to 1:2 ratio to 2 groups, IV's guidance and the angiographic guidance. And a primary endpoint is at the mass at the 1 year and the end of the follow-up, and the study of follow-up. The clinical outcomes shows that IV's guidance complex bifurcation lesions is associated with the reduction of mass and the cardiac death and myocardial infarction and any revascularization. So for complex bifurcation, met the pre-specified IV's optimal criteria, IV's guiding the PCR may improve clinical outcomes. So, however, today, no randomized trials to determine the IV's guiding the PCI for complex bifurcation lesions, and no specific IV's optimal criteria for complex bifurcation lesions. So Professor Chen and the designers TK Crash A trial to compare IV's guidance complex bifurcation lesions with the angiography bifurcation lesions with the TK Crash technique. This is the study flow chart, and 556 patients with complex bifurcation cases according to definition criteria, and the randomized IV's guidance guidance. The primary endpoint is the 1 year target basal failure. For the angiographic guided PCI and the stent size selected by the visual estimation and routine post-dilation, angiographic assess defined as TIMI flow grade 3 and residual status is less than 20%, and then low greater than 30 B dissection. And for the IVUS guided PCI, IVUS will be used pre-procedure and during procedure and the post-procedure. The pre-procedure, IVUS will be used to assess the plaque characterization and the lenticle and the stent size. During the PCI, IVUS will be used to assess the crashing the performance and rewind the sign branch at the ostium, the sign branch. And the post procedure, we use IVUS to assess the whether the specific pre-specific IVUS ostium criteria are met. This is IVUS optimal criteria for this study. For left main bifurcation, left main MSA 10 mm square, LID 7 and circumflex 6 mm square, and for long left main bifurcation, main vessel MSA more greater than 6 mm square, and main branch greater than 5, side branch and greater than 5 mm square. At the same time, and meet the plaque burden less than 55% at the stent age, and the expansion ratio greater than 0.9, symmetry index greater than 0.8, and no dissection and involved media and with the 2 millimeters in length. A take-home message: IVUS guidance for the treatment of bifurcations may change the PCI strategy. Achieve the pre-specified IVUS optimal criteria in IVUS guidance bifurcation standing associated with improved clinical outcomes. For the RCT is randomized trial is warranted to determine optimal criteria for IVUS guided bifurcation lesion standing. Thank you for your attention.
Thank you. Very nice talk. We have some minutes for comments or questions to the panel. Any comments from the panel? Any comments?
I have some questions from the audience.
Okay, great.
From Dr. Cesar Vigo, he asks in left main angioplasty, left main LID angioplasty, is it better to cover the whole trunk to the ostium and minimize POTS complications, or cover only to the plaque due to the mismatch between the stent diameter and left main?
That is a question to Shaolian or to the panel?
I think this is to everybody.
To everybody, yeah, but especially for Shaolian.
Oh, thank you. I think this is a very challenging question. So basically, if left main is long enough, more than 8 millimeters, and with free of disease, so basically we don't want to cover the left main. Otherwise, if this left main is severe diseased and the left main length is less than 8 millimeters, so personally, I prefer to cover the whole length of left main. Is that correct for your question?
I think the answer is okay, yeah. Yeah. Any other comments?
This talk emphasizes the role of IVUS. I think this was a great lesson from the case today, that these kind of cases should be done by IVUS. I know in Latin America it might be some difficulties in some cath labs, but these kind of cases, I mean the main message is understand the anatomy by IVUS and see the results, check the results by IVUS.
Absolutely,
yeah,
yes.
Absolutely, yes. I think in left main is absolutely right. you need IBUs to define optimal results post the stent deployment. Yes, in complex cases like this is absolutely right. Any other comments? If there is not further comments, we will go for the last talk of today. That is from Dr. Mingao, who will give the talk how to deal with complications in bifurcation stentings.
Okay, thank you, dear Chairman and panel, and thank you for Dr. Chen giving me a chance to talk about the complications of bifurcation stenting. And I have nothing to disclose. As we all know, the treatment of bifurcation lesions is still associated with a higher complication rate as compared to non-bifurcation lesions. Talking about the complications of bifurcation stenting, mostly we saw set branch occlusion. It might caused by plaque shift, coronary shift, and sometimes it caused by dissection or hematoma of the either main branch or ostium of set branch. And the second complications usually caused by the wire, especially the set branch wire. It can be wire entrapment, and sometimes it can cause stent distort. And for the Leifman bifurcation, like the case just Dr. Chen showed, if you don't very careful about the getting catheter, it also can cause the stent distort of ostium of Leifman. And also, if you don't do very well stent expansion and malposition, and you will got TLR and a stent failure. It either can be stent thrombosis or stent restenosis. And the most common complication of procedure is set branch occlusion, for example, like a previous study shows, like a COPIS 2 registry, cardiac death or myocardial infarction occurred more frequently in patients with set branch occlusion than in those without set branch occlusion. So the first thing is we should know what kind of bifurcation is, what kind of set branch is highly possibility to be occluded after the stenting of main branch. So you need to know what kind of bifurcation is complex bifurcation. So now we all know definition criteria from Dr. Chen's team, and also like EBC consensus of this year, and overall a series of clinical, anatomic, and procedure factors might combine to determine the technical difficulties and complication risk in an individual patient and bifurcation. Usually, we use jailed wire to protect the set branch. Like this case, there were two big diagonal. So wire goes to the first diagonal, but after stenting, the second diagonal without jailed wire and got total occlusion. So usually the basic technique is jailed wire technique, and like this case, and this LED and diagonal bifurcation. So after stenting from main branch and big diagonal got total occluded. And this case was very lucky. The doctor very quickly goes to the another wire and goes to the diagonal, but some cases a patient not very lucky. And for this case, then the blown ostium of diagonal, then kissing, and then finally got a very good TIMI flow of SAC branch and rescued the blood flow. And but for the diagonal, SAC branch is very huge, and sometimes it's the dissection of hemoma is very obvious after main branch, and only balloon casing is not enough at this point. Probably provisional T, like a technique, should be used to rescue the SAC branch occlusion. Like this case, after the standing from LD to left main, and the blood flow of huge diagonal is not very good. And at this time, very quickly revise the diagonal, did IVUS, then use the tap technique to rescue this huge diagonal. So for this provisional technique, you can either do provisional T standing, or you can use the tap technique or Kuhler technique to rescue this kind of very huge SAC branch. So this is a final result of this case. We got very good TIMI flow for the both LAD and the huge diagonal. And so for rescue SAC branch occlusion, obviously the geode wire is very important. You have the geode wire, that means you can do whatever you want to do, like balloon dilatation under the stand. You can open the diagonal, or you can do tap or inverted crash technique to rescue this SAC branch. So geode wire is very important. This is a case example. This is a trifurcation of distal left main, and where both LAD and the circ and LAD pre-dilatation and standing from LD to left main. So after that, the big circ is totally occlusion, but the geode wire is in the place. So at this time, balloon very quickly through the geode wire to the circ and open the circumflex. Then the doctor did use another balloon to crash the stand of LAD. Then another stand from circ to the left main. So they changed the technique from one stand crossover to the crash. Use the circ to left main stand, crash the LD. Then we did the final casing, got very good TB flow and rescue the circ. So this is use the stand. And sometimes if the SAC branch is not very big, for like this case is huge. Also, this is a diagonal LAD bifurcation and one standing crossover. After that, the SAC diagonal totally occluded. And at this time, if you don't have the time, the wire cannot go to the diagonal, then you can use a very small balloon through the geode wire, goes to the ostium of SAC branch and open it. So after that, when you got the very good TB flow of the branch, and you can use another wire to revise the diagonal and do the final casing, then got a good result of this case. So geode wire is very important. It's the key part of the provisional bifurcation strategy. But for the geode wire, what type of wire we should use, and when you do the crossover technique, how to remove it very safely. And so usually we have polyhydric wires and non-hydrophilic wires. We have both two kind of wires. There is an interesting study compared the two different kinds of wire after the one stand crossover to see what kind of wire is easily to be damaged. And the result is interesting. Even the consensus does not recommend the polymer coated wire, but still, polymer coated wire is not easy to get damaged. And the geode length of the wire is a predictor of the wire damage. And if you use the hydrophilic wire and the time for rewiring is very short than non-hydrophilic coating the wire. And there is another interesting trial talking about for the bifurcation. If you use the non-polymer jacket wire, it could inevitably cause a severe defect in stent coatings like this way. But usually, if you use the full polymer jacketed wire, it can cause less coating damage like this way. So this is another interesting thing. How to remove the wire safely? Usually don't gel the radio or optic tip because it's soft and removable. Or one loops on the gelled wire. Advancement of low-profile balloons or microcatheter over the entrapped wire is very, very helpful. And withdraw guiding catheter to prevent the coronary damage and stent distortion. This is some tips. And like this case, this is a long stent from crossover to the in the LD, and gelled the wire is the length is very long. So when the doctor wants to take off the wire, it cannot be taken out. So even they use the balloon, the wire are already damaged, and you can see finally the result is very small part of the wire left in the diagonal. This is we need to aware of gelled wire entrapment. And so how to prevent this kind of complications? I think nowadays gelled balloon technique is very useful and common to use. And as previous studies showed, we used if you use the gel wire technique, it can postpone optic side branch flow very effectively. And use the gelled balloon technique like this case. You can either put the balloon here, and after that, if the blood flow is not good, so use the balloon dilatation, the ostium of side branch, and then rewire and open the ostium of the side branch again, and finally got a very good TME flow of both main branch and the side branch. So this is one thing. And sometimes when doctors do Kuhler technique and also gel balloon technique is very useful. For example, if you put stent from side branch to the main branch, if you it might cause the occlusion of the main vessel. So at this point, Dr. Chen Lianglong from China, they used a modified culotte stenting. When you use the put stent from diagonal to side branch to the main branch, you can put a balloon in the main branch just in case the blood flow of the main branch is not very good. Then you can rescue the main vessel occlusion. And finally, be aware of stent distortion, like this case from LAD to the ostium of Leifman stent crossover, and after that do the final casing, and you can notice that guiding catheter is engaged very deeply. And after that, when we check IVUS, we found a distortion, stent distortion here and here, and use the full balloon to the port, and this is a final result. So how to prevent the stent distortion? Withdraw guiding catheter to prevent the coronary damage or the stent distortion, and gently pull back the stent balloon or either NC balloon very gently. Then you can prevent. And finally, how to prevent SRL stent thrombosis. I think there are a lot of data. Everyone familiar with this data to prevent stent failure. And thank you for your attention.
Thank you. Great presentation. Yes, it's true that side branch closure is a potential problem with incomplex and simple bifurcation cases. For this reason, I don't think that DES design is very important to select before to stent deployment. The stent should have easy side branch access for this sort of complication. We have to go like the DS design used by Shaolian, the Firehawk stent used in the complex case that we enjoy today, performed by Shaolian and his staff. Shaolian, we have to close. If you want to give the final words. For here, many thanks, great cases, great lectures. It was a very nice teaching session.
Thank you very much.
Thank you, Alfred. I appreciate our Solaci staff to work together with my team and our Chinese colleagues. First of all, I appreciate Professor Guo, Professor Ge, and Professor Tu to present 3 very nice talks almost in the midnight in China. Particularly, I'm very, very excited to see all my friends on the screen. So I think he might just finish his vacation and return to hospital. This could be our first day to work with us. In the last 1.5 hours, I think we have learned much more from each other. So we started from a very, very challenging case, live from Nanjing, and also we changed our opinion strategy and studying technique for different kinds of bifocal lesions. So final talk by Professor Guo summarized the challenging technique for restoration of the side branch balloon. I think this is a nightmare in the case we have encountered during our daily practice. With this very strong tools, I think our routine PCI case, particularly for the complex case and the complex bifocal lesion, will become more and more strong and confident. So once again, I have no more words to share with you, Alfred. Once again, thank you so much. See you next time. See you. Thank you.
Thank you very much. Thank you very much. Bye-bye.
Bye.
Thank you.
Bye-bye.
Bye to everybody.
All the panelists. Bye-bye.
Bom dia, and welcome to CCI at SOLACI-CACI. I'm Stephen Bailey on behalf of Catheterization and Cardiovascular Interventions. It's great to have this opportunity for this collaborative session. It's unfortunate that we're not there live with you in Argentina, but we look forward to that opportunity hopefully next year. I have the great fortune to be joined by a great friend and colleague, Dr. Alexandra Lansky. Alexandria is the inaugural editor-in-chief of the new journal of SCAI. And we're so excited to have her part of this session today, along with a wonderful series of speakers and panelists. We do have a digital moderator, Dr. Martin Cisneros-Soria, and this session is available in both Spanish and English. Alexandra, welcome. We're so excited to have you join us.
Thanks. It's really a pleasure to be here and to be part of this session. So I guess I'll kick this off. Just in terms of the format, we've got 5 outstanding presentations. Each presentation is going to be about 12 minutes. We have about 5 to 6 minutes for a good discussion after each one of the talks. And I'll kick this off and introduce our first speaker, who's going to be Hector Escutia. And he's going to be discussing the hybrid algorithm in complex chronic total occlusion interventions, a Latin American center experience. So without further ado, let me pass it on to Hector.
Well, thank you. We're going to start with the presentation. Thank you very much to SOLACI, and thank you very much to CCI for the invitation. The title of the work you have already said. It's a retrospective registry, only taking in the time all the patients with submitted to percutaneous coronary intervention for a chronic total occlusion. So the authors, well, we're from a high center of concentration center of PCI, of complex PCI in Mexico. So all the patients are coming from this hospital. Since 2012, we know about the hybrid algorithm. The hybrid algorithm has been so much used in all countries, and Latin America is in this kind of countries that are adopting in the time the hybrid algorithm. So there are 4 steps following these techniques, which are the necessity of a dual coronary angiography. In second place, the systematic review of 4 characteristics of the lesions: the proximal cap, the length of the lesion, the quality of the distal vessel, and the presence of interventional collaterals. The third point could be the selection of an initial crossover strategy. All the patients, or the great amount of patients, were treated only with a anterograde wire escalation, and then a anterograde dissection re-entry. And in a 4th point, the change, or the early change of initial selected crossover strategy, with the goal of achieving on a crossover of the lesion with a reasonable period of time. So we know that there are a lot of registries worldwide, but not only a registry in Latin America. So that's the strength of our work. In the recent years, general descriptions in Latin America have generated. We have 4 years ago our first CTO registry, multinational CTO registry. And for this reason, we decided to carry out this comparative study to specifically evaluate the hybrid algorithm between another non-hybrid techniques. So in the methods, all patients were treated between November 2016 and December 2019. The inclusion criteria only people above 18 years and the presence of a CTO with a previous PCI attempt. The definition of CTO is a general definition as a 100% lesion in a major coronary artery with estimated to be or at least 3 months of diagnosis. The patients in the hybrid group were previously selected, and 2 operators treated these patients, compared with a second group of non-hybrid group, which was selected and treated by 4 operators not associated with the hybrid techniques. So this is the diagram or the algorithm that we used in all the interventions. The definitions are the universal definitions between ischemia, between tortuosity, calcification, and we calculated the JCTO, progress, CL score, and OTA score in all our patients, and the Werner score in case of the patient had interventional collaterals. The outcomes of this study were: the primary outcome was the success of the procedure. The success was a TIMI final flow equal or more than 2 points, residual stenosis less than 30%, and all this based on a JCTO angiographic score. The secondary outcomes included individual characteristics of the procedures, associated complications, and clinical outcomes at 30 days post-procedure. Another outcomes were in hospital MACE, procedural complications such as major bleeding, coronary perforation, cardiac tamponade, and urgent revascularization, or the need of a new PCI or CABG. In the analysis, well, the analysis was a standard analysis with a continuous variables analyzed with frequencies, t-test and t-square, and a Mann-Whitney test for non-parametric data. There, we performed a multivariate analysis with logistic regressions of the primary outcome, including JCTO scores, bifurcation PCI, intrastent CTO, and vascular access, all analyzed with GraphPad Prism. The ethics, well, there's no problem with this study because there is a observational and retrospective study. We plotted 171 CTO PCIs performed in our center. 80 patients were in the non-hybrid group, and 91 patients were in the hybrid group. The characteristics of these patients, well, the main differences, we can see it in myocardial ischemia, and the clinical status were such different because there was a really important selection bias. The patient was previously selected. There was no randomized control of these patients. So there could be, we can see all this selection bias in the study, in the indications, and in other characteristics. The most treated artery in both groups was the right coronary artery. In second place, the anterior descending artery, and in third place, the circumflex. The JCTO score was really different between two groups. The hybrid group had the greatest, or the most important, or the most complex JCTO scores seen in the study. And even though the score castle was greater in the hybrid group, so the progress score was the same, and the CL score was had a similar interpretation. So the reference diameter was equally different, the occlusion length, the calcification, and these all are characteristics of the lesions that were affected by the bias or the selection bias of the patients. In the characteristics of the procedure characteristics, we can see the successful procedure in 92% of patients. So 87 in total in all patients, 87% of successful, and 92% in the non-hybrid group, and 83% in the hybrid group. In the hybrid group, with a non-significant P. So the most used strategy was the anterior wire escalation, then the dissection re-entry, retrograde wire escalation. The wire crossing was more important in the time in the hybrid group. The contralateral injection was more used in the hybrid group, and the retrograde approach was more used in the hybrid group. So there's a lot of differences in the materials used microcatheters, intravascular imaging, plaque modification, guiding catheter extensor. The procedure length was biggest in the hybrid group, and there was much more use of contrast volume in the hybrid group. The conventional ultraradial was more used in the non-hybrid group, and another vascular accesses had no difference, only the distal transradial. The guiding catheter was more used a 6 French in the non-hybrid group, and wider catheters were used by the hybrid group. So the difference between the materials and the techniques was really important between the two groups. Talking about complications, there was no difference or significant differences in the complications between the two groups. Talking about coronary perforation, dissection, slow flow, thrombosis of the donor vessel, lateral branch occlusion, tamponade, and all the complications had no difference between the two groups. Even the all-cause death, the need of an urgent PCI, and new myocardial infarction. So in the multivariate analysis, we observed a dependence in the primary outcome with the other characteristics. So we can conclude with this that the CTO PCI with the hybrid algorithm was not associated with lower success in low complexity lesions. This effect was observed to be dependent on high complexity lesions requiring longer procedure time and materials, although no differences in procedure complications and clinical outcomes. So the CTO PCI with the hybrid algorithm is feasible to be performed in high concentration centers in Latin America with high rates of success, in this case 87% of success, and safety in the short term. The limitations of this study is the inclusion of the patient was not consecutive, which could have introduced a selection bias that we have already talked. Angiographic and procedural characteristics were not independently evaluated, so there's a limitation. The assessment of scoring systems depends on whether dual angiography was performed, and this was an observational and retrospective analysis. Thank you very much.
Thank you, Hector. I think that was a tremendous experience, great presentation. I think a lot to talk about here. And before I pass this on to the panel and get a good discussion going, I just wondered whether you consider doing like a propensity matched analysis. I know your numbers were relatively small, but there were so many differences between, you know, your entry criteria between the two groups. And I wonder whether trying to match these patients and some of the characteristics would have been helpful to try and compare the two strategies.
Yes, as you have already told, we didn't make the propensity selection because the number of the patients is not a huge, so it could be really difficult to make some conclusions of the propensity match. So we only made a multivariate analysis of retrospective analysis.
So let me turn it over to the panel and see if there are any comments or questions.
Yeah, may I make a question?
Yes, please.
Okay. Okay. You show us success rate, stunning success rate on about up 80s. But that is similar to the largest registry published up to date, that is the PROGRESS registry. But same as the PROGRESS registry, you have a MACE rate and death rate that exceeded at large the rates we have with the regular procedure in our cath lab. In the PROGRESS registry, for example, they have a 3% of miss rate. In LATAM context, our countries, we have always limited resources. So what is your reflection about indications? So you prefer to follow regular indications in the guidelines, or do you prefer to be more restrictive doing these procedures, CTO procedures, only in patients that you think they will obtain more benefits? Question is, what do you think about indications in our countries, in our context?
All this work was done together with the LATAM CTO registry. So our data is the data that we have reported in such registry. And in the first years that we started the CTO PCI, we had no we have no information of the characteristics of the patients, and really we were trying to do some procedures and gain experience. And in the next years, we started to limitate these procedures to elective patients and really selected patients. So actually, the times are others that we had a few years ago, where we just observing the characteristics and the outcomes of such patients in those years. So the differences could be observed in the years, could be observed in mortality, could be observed in onasis, and all that you have already told or talked about. So it's very important to make to talk about to speak about it. Yeah, there's a lot of difference between the CTO PCI 5 years ago that the CTO PCI in Latin America from 5 years to the actual days. So to current days. So there could be the difference and the observation that you have already told.
I think we have a question from Dr. Duran.
Okay.
Ariel?
Dr. Studio is a very interesting study in populations. One of the characteristics of the chronic treatment of the treatment of chronic is the radiation dose. You compare the fluoroscopy time. I always figure in this kind of treatment, but I think it should be more interesting to compare the dose area product on the effective dose, as in this kind of patient you can see in lesions.
Yes,
in the chronic total occlusion, you can see more skin lesions. So it should be easy to compare effective dose and dose area product should be comparing the field. These two characteristics. So when you have a bigger dose, you have to
so the
see
question
the patient
here,
again to see the back of the patient to see if there are some skin lesions. I think it should be something interesting for your study in the future.
In the original manuscript, we made such differences. There's a lot of radiation for the operator and for the patient, and we made the difference. And the patient has more radiation, and the operator too. So we have already registered it.
Yeah. So thank you. For time purposes, I think we'll move on to our next presentation, but there will be time hopefully at the end if there are other questions that arise. I know that you have influenced other operators in wanting to pursue this, and we appreciate your sharing your center's experience and expertise in becoming CTO centers of expertise as well. Thank you so much,
Thank you,
Hector, for that. Our next presentation will be from Dr. Fernando Gomez on syntax score 2 application compared to GRACE score for prediction of heart failure. Dr. Gomez Peña, thank you so much for joining us, and we look forward to learning more about your work. Thank you, sir.
Hola, buenos días. Gracias, Dr. Lansky, Dr. Bailey, por dirigir y presidir.
Thank you, Dr. Lansky, Dr. Bailey, for giving me the chance to share this research with you. The work is that I'm going to present is the syntax score 2 application compared to GRACE score for prediction of heart failure development in patients with STEMI undergoing primer PCI, and that are going to sorry, I'm trying to move forward. Okay. The co-authors, great teachers and now friends of mine from the Clinical Hospital of Santiago de Compostela in Spain. We have no disclosures. All right, so a little bit of the background behind this paper. Heart failure is a major cause of late morbidity and mortality after STEMI. We identify also as a big prognosis determinant after MI risk stratification at hospital discharge, and an early treatment optimization is mandatory with the aim of reducing the heart failure incidence after STEMI. We already know that, but of course it's important to get to know which patients have a risk for heart failure. The GRACE risk score is very well known and has proven to predict accurately the congestive heart failure following acute coronary syndrome. And most recently, syntax score 2 showed or proved to have a prognosis impact and improve the predictability of anatomical syntax score and the residual syntax score, and it was compared to the GRACE risk score to predict MACE and all-cause mortality in patients with STEMI. And the relationship between syntax score 2 and the development of heart failure in patients with STEMI undergoing PCI has not been yet defined. And parts of these studies, we were wondering whether we could prove the ability of syntax 2 score in patients with ST elevation in a database that is pretty powerful that we had in Spain, in Santiago de Compostela. We compared it with syntax residual and with the GRACE score, and here we see the blue line, that's for MACE, GRACE, and mortality, all-cause mortality. The blue line is syntax 2, and the yellow is GRACE. We see how they compare among themselves, and the predictability improves a little bit more in syntax 2 score. We found that within the MACE that we were studying, we included, of course, mortality, all-cause mortality, myocardial infarction, heart failure. But we found that for heart failure particularly, it gives us a very important prediction factor. Here it was as an independent predictor of diagnosis. So we concluded that we wanted to study the situation a little bit further. And that's how this study was born. We wanted to analyze the ability of syntax score 2 to predict the development of heart failure in STEMI patients after PCI, and to assess its performance compared with GRACE and syntax scores. Of course, this is about all the patients with STEMI. This study is a retrospective study. The cohort is made up by 1,689 patients with STEMI who underwent PCI between 2008 and 2016. We decided to divide the population in 3 groups, in tertiles, depending on the value of the syntax score 2. So we have a group of a low risk group, an intermediate risk group, and a high risk group. And this follow-up was a median follow-up. 8 years was the total, but the average is 2.35 years. The definitions that we used for STEMI diagnosis according to the 4th UD of myocardial infarction, the European definition. The ischemia time, well, is the time between the symptom onset and the reperfusion guide wire passage in culprit artery during PCI. The multiple vessel disease was defined as at least one lesion in a non-infarct related artery, more than 50% luminal narrow in diameter. And geographically, this was done. We didn't use any other evaluations to see if there was a more significant lesion. The heart failure was defined by a KILLIP 2 to 4 class on admission and or new hospitalization due to the heart failure symptoms during the follow-up. Since we wanted to make sure that we were using the right definitions. The population characteristics, well, the groups were very easy to compare, but in the high-risk profile, the patients were older, prevalence of hypertension, diabetes, more ischemic cardiopathy. In other words, they were patients with more comorbidities. And the ischemia time before the catheter, it was 175 minutes. There were no differences here in the groups that could impact in the generation of heart failure. The artery related to the infarction was more frequent in the LAD and the left main. So syntax score with a higher syntax score, and the KILLIP class were more present in class 4 in the high risk profile. This is the Kaplan-Meier curve for heart failure during a follow-up. We see here the 4-year period and how the curve goes up in the first days, actually, the first months. We see an abrupt peak of the high-risk profile, which is the line in green. The one in red is moderate, the blue one is low risk. And so we see how this peaks here with high risk in the first days or months, and then the curve flattens. What really got our attention is that, and we should analyze the first year most particularly. So we divided it here, the graphs in the first 30 days, then 90 days, and then after 90 days, we went directly to 1 year. So I can see how here, after 30 days, that's when we have the peak of cases in heart failure within the green light, which is the green curve, which is the high risk. After 90 days, it's like in the middle of the curve, it's already stabilizing, and the same thing happens in the 1 year curve. So that gives us an idea. That tells us that most of the cases, 86% of the cases, happen during the first 30 days, and from these 86% of the cases, 74% of those are cases that happened in the terstile of high risk, as we saw in the graph. So depending on the function fraction that the patients had, or in the admission event, we have here A less than 40%, from 40 to 50, and in C more than 50%. So regardless of the LEE fraction, with the syntax 2 score high, they have more incidence of heart failure throughout the follow-up. Reduced, moderate, and preserved. This is the ROC curve in red, syntax 2 blue, grays, and syntax, normal syntax, the green line. So the capacity to predict the ROC curve is very similar in grays and syntax 2. So the additional value of syntax 2 over grays has to do with the ROC curve support, and it gave us a chance to reclassify the patients much better after we added syntax 2 to grays. The anatomic syntax, well, is quite below. We already saw that from the previous study, and we were also interested to include it. The main findings, the first one is that syntax score 2, the high syntax score 2, was associated with more heart failure events in STEMI patients after PCI. And that's, that's regardless of the LVEF on admission. Syntax 2 score was shown to be a strong independent predictor for midterm heart failure in this acute ischemic scenario. This is also important to know. Most of the heart failure events occurred in the first 30 days after STEMI, PCI, and 4, syntax 2 score is comparable to gray score to predict heart failure events in patients with STEMI undergoing PCI. So our conclusions are that, well, syntax 2 is a good predictor of heart failure development in STEMI patients undergoing primary PCI, and it's superior to the GRACE score. And this also has some limitations. We have to remember that syntax 2 has an angiographic part, and we need the angiographic part. We need to have people that knows how to assess and characterize this score. In the case of this study, we didn't hire a core lab that could measure everything, but we did everything with all interventional cardiologists, and if there was any questions, then we consulted among ourselves and we defined the number of the score in syntax. Other limitations, this is just one center study, and another important limitation that I see in our trial is that we did not use pressure wires in all the cases to define the multivessel lesion. That could have maybe brought out some changes, some differences. I'd like to thank, this is the University Hospital in Santiago de Compostela, and now we can go to the questions, if any.
Thought-provoking in terms of the information you've provided. While we're waiting for the panel or other attendees for questions, I think that you anticipated my question. Were you able to look at completeness of revascularization in your population and whether there was an impact on subsequent heart failure based upon completeness of revascularization?
Yes, I know that is a very good question, and it would have been wonderful to assess that in this study. First of all, assess it with the FFR or RFR or IFR. That would have been marvelous, but even though we didn't do those meditions, maybe the next step of this study is to assess the complete revascularization, even if we don't do it in the same hospitalization or the follow-up 1 year or 4 years.
Yeah. Well, perhaps now with the advent of QFR and the availability to use angiographic estimates, it might be something for you to consider as another piece of your investigation to add additional information.
Yeah, that could be very useful because with QFR, you don't have to get the patient again in the cath lab, no? That would be nice observation. Thank you very much.
I have a question for Dr. Gomez.
Yes.
Of course, we consider the SYNTAX score previous the primary PCI, but do you have any conclusion after to perform the PCI with the residual SYNTAX score? Do you have any comments about that, or did you analyze that results?
Could you repeat the second part of the question, please?
The second part of the question is if you have any result with the residual SYNTAX score after the PCI.
Okay, we did the comparison with residual score in the first study that we assessed MACE and all-cause mortality. We did assess residual SYNTAX score. The ability of residual SYNTAX score was not better than SYNTAX 2. So we decided not to include it in this study, just include the angiographic SYNTAX, just to have like a control.
Mm-hmm.
So
that was the reason.
I have a quick question. So thank you very much. That was a really fantastic presentation. 2 questions. So question and maybe some comments from you. First question is, when do you, so the SYNTAX 2 score includes the LVEF, and you show that the results are actually independent of LVEF, although there is clearly an effect of LVEF with worse outcomes, the worse the LVEF. So my question is, when do you assess the LVEF? Is that prior to STEMI? Is it at the time of admission, or is it after the primary PCI? So that's question number 1. Question number 2 is, how do you incorporate, now that you've done this, how do you incorporate this in your management of patients?
Okay, thank you, Dr. Lansky. Very interesting questions. The LVEF, not in every patient you can assess it before the PCI because of the emergency of the cases and the severity of the cases. So there are some cases that we assess it before and other cases that we assess it immediately after the PCI. So that would be another limitation. I know that it is included in the definition or in the variables of the SYNTAX score 2, but we decided to analyze it separately because we wanted to see if the other variables were as potent or as strong as the LVEF. We saw that even though the curves of the high tertile was like a little bit flatter in the moderate and normal LVEF, the cases were more prevalent, more incident in the high SYNTAX score tertile. So the second question that maybe is the more difficult, because it is not easy to perform this scores. We have seen like reluctance of the cardiologists, interventional cardiologists or clinical cardiologists, to perform any of these scores before, during, or after. No, you just want to see the result, the clinical result. The patient is fine, and that's it. But maybe this is okay in terms of investigation, but it should be, and it could be useful if we could perform it in our daily basis. That is our thoughts.
So I think a great presentation, good discussion, but I think, Alexandra, we probably need to move to the next one. So.
All right. Well, thank you very much, Dr. Gomez. That was
Thank you very much.
Great. Yeah. All right. So we'll move on to the next one, and this is going to be Dr. Pavlovsky is going to be talking about the 5-year follow-up of ERASI-4, the modified syntax score for the treatment of multivessel disease and left main disease.
Good morning. You can listen to me?
Yep, we can hear you.
Okay. Thank you. Thank you very much. Thank you, SOLACI-CACI. Thank you, CCI, for the invitation and this opportunity. I will, in this presentation, report the 5-year follow-up of the ERASI-4 registry, a modified syntax score for the treatment of multivessel and left main coronary artery disease. Personally, I have no relevant financial relationships to disclose. The study was sponsored by Microport for the first 3 years of follow-up. And the objective was compare a long-term outcome generation second-generation DS to first-generation DS in a patient population with multivessel disease using an initial conservative strategy during PCI. The study fulfills all the regulatory steps accorded. Here you can observe the clinical events committee, the project management, the SBS medical department, the study sites, and the principal investigator. Well, the study designs. Patients were candidates for inclusion if they had multivessel disease, including left main stenosis, an indication for myocardial revascularization with clinical evidence of myocardial ischemia and angiographic evidence of severe coronary obstruction. Stenosis greater than 70% by visual estimation in the target vessel. After 11 months, from 4,630 patients we evaluated to be chosen, 1,917 were selected. 1,684 patients were discarded because they met exclusion criteria. 233 patients with multivessel CAD or left main were included, but 8 were excluded because they did not meet angiographic inclusion criteria. So 225 patients were the final population treated with second-generation DES. The primary endpoint was the incidence of MACE in this stand, and subsequently an indirect comparison with the ERASI-3 group that was treated with third-generation DES. The clinical follow-up at 5 years, at 6 months, was 81.2%. This number is very important finally. Well, primary endpoint, as I said, the incidence of major cardiovascular event defined as any cause of death, myocardial infarction, stroke, and unplanned neurosclerization in patients with multivessel disease, including unprotected left main, using a second-generation DS, and compare versus ERASI-3 population. These were recorded at 30 days, 6, 12, 24, 36, and 70 months of follow-up. The secondary endpoints were target lesion failure, defined as cardiac death, acute myocardial infarction, and target lesion revascularization, target vessel revascularization, and overall stem thrombosis, in agreement with academic research consortium definition. Well, the PCI strategy was planned prior to the procedure, and the aim was to achieve a complete functional revascularization. First, we calculate the syntax score, the vessel syntax score, and modify the method
scoring only lesions with stenosis greater than 70% of obstruction in vessels greater than 2 millimeters of diameter. We didn't include neither intermediate lesions nor vessels less than 2 millimeters. With this scoring, this approach, we named ERASI risk score, and with this, you can see that here with this scoring in ERASI score or with ERASI score, 82.7% had lower intermediate risk score, and only 17.2% were included as high, practically the half of the high basal syntax score. As post hoc analysis, we also assess a predictive value of completeness realization using a residual and geographic risk score, defined with a cutoff less than 6 or 8 after PCI. A functional revascularization was defined when a residual and geographic risk score was 6 or 8 and was classified as reasonable in complete revascularization. Here you can see the statistical analysis. The sample size was estimated according to similar population, including SAC. If we included 225 patients, the power of the study would be 80% to detect differences between both kinds of stents. The freedom from survival and endpoint follow-up were obtained using Kaplan-Meier curves and compared by log-rank test. We use multivariate statistical methods to adjust for possible confounding factors, and we perform a propensity score to analyze results in a matched population of these patients. We constructed a logistic model, included independent predictors such as gender, hypertension, diabetes, dyslipidemia, free vessel, etc. Well, the results. Here you can see the baseline clinical, demographic, and geographic procedural characteristics. ERASI-4 population had more diabetics, previous revascularization, unstable angina, and more through vessel plus left main. All other variables were not significantly different. Such as I said previously, the low or intermediate syntax score, basal syntax score, was 66%, and high syntax almost 34%. And with our score, the low and intermediate ERASI score was 82.7% and high 17.2%. The results were the 1, 2, and 3 years outcomes were previously reported and published shortly. At first 2 and 3 years, we have a very low incidence of death. The composite of death, myocardial infarction, stroke, repeat revascularization, and MACE. At second year, the lower incidence of the composite and repeat revascularization and MACE. And at the third year, the lower incidence of myocardial infarction, the composite, repeat revascularization, and MACE. Stent thrombosis was not significantly different between the both groups, and very late stent thrombosis was not observed in ERASI-4 patients. At the latest follow-up, 6 months, the report of these 5 years, you can see the endpoints and each of their components all in favor of the ERASI-4 group. The curves, the Kaplan-Meier curves, you can see the freedom from MACE and the freedom from death, myocardial infarction, or stroke. Shows very clearly the differences between second generation DS versus first generation DS. And here you can see the propensity score. We analyze this any cause of death, myocardial infarction, non-fatal CVA, myocardial infarction, and planned revascularization, and MACE. We are able to match 108 patients who received second generation DS versus first generation DS. And when we perform the propensity score of the pair population, these were significantly lower in the ERASI-4 group. Well, this is a very loaded slide, but it shows clearly the event progression at 5 years.
And the multivariate analysis. We analyze independent predictors of the primary endpoint using a multivariate Cox regression analysis. At 5 years, we univariate analysis different variables, and the first DS treatment group was associated with MACE and were entered into a Cox regression model. At 5 years of follow-up, ERASI 3 and the diabetic populations were independent predictors of poor outcome. And the 3-vessel disease shows a trend towards a worse outcome. These results are consistent with the real world. Finally, the completeness of vascularization, the residual syntax and residual ERASI score were significantly different. The mean residual syntax was 8.7 plus minus 5.9, and the residual ERASI 3.5 plus minus 4.6. And in only 34.4% of patients have an agreement. In addition, 30% of the patients in the study had residual syntax less than 6, compared to 80% of our residual ERASI score, or 48% and 93.5% if the cutoff was 8 finally. Well, the numbers of the residual syntax score are agreed to the degree of angiographic complete revascularization obtained after the PCI, and the residual ERASI score are in correlation to completeness of functional revascularization. Of course, the study has had the limitations. It's a non-randomized nature of the study. The significant improvement in DAPT therapies in ERASI 3, all patients received clopidogrel, and in ERASI 4, the mostly P2Y was prasugrel anticardelor. The sample size was small, and the propensity group even smaller. And at 5 years, the ERASI 3 had more patients who completed the follow-up, 93.3 versus 81.2%, with significant differences. In conclusion, we have a remarkable low incidence of MACE rate as well as components of the primary endpoint. Maybe the newer DS, the newer designs with a conservative strategy and more active DAPT were the cause. The late outcomes of this study strongly validate our lesion PCI scoring and assessment. And the large proportion of patients achieving a reasonable incomplete revascularization determined by residual ERASI score is in such direction. Thank you very much.
So thank you so much for that great presentation, great study. So again, I'll turn it over to the panel, but my question is, you did a multivariable analysis. Did you put the stent type in your multivariate model? I didn't see that. Did the file?
Yes, of course, yes.
So yes. Stent didn't come out.
Yes.
So the stent did not contribute to the improved results.
Maybe the stent contribute to these results, but the PCI strategy and the different DAPT was in such a direction.
With stronger.
It's a.
Okay.
Yes,
I would like to ask congratulations for your presentation, excellent as usual. But as your own criteria, which is the principal factor of the difference between ERASI 3 and 4? The difference is about the DES stent that you use, the difference is about the antiplatelet anti-aggregation, the difference is about some technique that you change, the difference is about the total revascularization. What do you think about is the principal difference? The stents, the DAP, the anti-aggregation, the total revascularization. What do you consider about that?
Well, hi everyone, how are you? Thank you for your question. I think that it's not only the stent design, the newer DS, the drug, the polymer. I think is the PCI strategy, then less stents implanted, less metal, and more strongly DAPT treatment. Yes.
Do you think that it's a combination of all those factors? It's a combination of all those factors. That is your...
Yes, of course. I think it's multi-causal.
Okay.
So
any other questions from the panel? I'm sorry. So another question I might have would be, you know, as the techniques improve over time, how about the use of intravascular ultrasound or CT to guide the procedures? Did you track that?
Were you able to hear the question?
No. Yes, I can hear you. No, we don't do OCT or EVOS in those patients.
Okay.
Great. Well, thank you for an excellent presentation, and you clearly illustrated advances in technique as well as stents and our ongoing therapy and the impact they're having. So we appreciate that. But we're going to move to our next presentation from Alejandro Kim, is dual axis rotational coronary angiography radiation dose reduction achievable in a population with suspected coronary artery disease. Dr. Kim, we look forward to your presentation.
I'm sorry, I'm having some technical issues with sharing the screen.
Okay. Do you want us to go to the next presenter and come back as you resolve the technical issues?
Please.
Okay, we certainly can do that. Alexandra, you want to?
Sure. Let me introduce. So the next presentation is Dr. Lasave, who's going to be talking about the long-term outcomes of transfemoral TAVR. Comparing a minimalist versus a conventional strategy. Thanks.
Thanks. My name is Leandro Lasave. Let me see here. Sorry.
We can see your screen. It's perfect.
Yeah. You can see my screen, yeah? Okay.
Yes, see.
Okay, thank you. Okay, the title is on the long-term outcome of transfemoral transcatheter aortic valve replacement, comparing minimalist versus conventional strategy. I am from Instituto Cardiovascular de Rosario and Sanatorio Parque Rosario. Okay, the TAVR is an effective therapeutic strategy in patients with severe symptomatic aortic stenosis, not only in operable or at high surgical risk, but also as an alternative in patients at intermediate and low surgical risk. At the beginning, we performed this procedure under general anesthesia using a transesophageal echocardiography guidance and using a surgical vascular access and closure. But nowadays, we move forward to a less invasive or minimalistic strategy using a local anesthesia and conscious sedation without TE guidance, using a transthoracic echocardiography guidance, and of course, with a fully percutaneous femoral access and closure.
But the most of the evidence and reported experience of this minimalistic strategy for tariffs comes from high volume setting in Europe and in the States and Canada, and is slightly limited in other regions, including our Latin America, and also in centers with less procedural volume as ours. So we performed this analysis to compare the outcome of the hospital and at a medium term follow-up of TAVR with a minimalistic strategy versus conventional strategy in a consecutive set of patients with severe symptomatic aortic stenosis in our single center with low volume TAVR program as ours. So we included 180 consecutive patients between 2020 and 2020 with symptomatic severe aortic stenosis underwent transfemoral TAVR, and then we split it in two groups according to the use of conventional or minimalistic strategy. So the conventional group was, we included 89 patients, and as we say, these patients were undergoing general anesthesia, urinary catheter, TE guidance, and surgical cut down by a vascular surgeon. The minimal invasive technique, in this technique, we included 91 patients. And these were undergoing conscious sedation, as we say, local anesthesia, transthoracic guidance, and we use a fully percutaneous access using a device as glide or prostate in all patients. We assessed in hospital outcome as a stroke, major vascular complication require acute intervention or blood transfusion, conduction abnormality requiring permanent pacemaker, acute renal failure, of course, procedural success and mortality rates, and also we assessed outcome at 30 days, 6 months, 1, 2, and up to 5 years of follow-up. This the SFS package, statistical package. The continuous variables are showing as mean and standard deviation or median and interquartile range. Categorical variables count and percentage. The student test and these tests, statistical tests, were performed for comparison. And we performed a couple of major curves and used the Logan test to compare both groups. As you can see here, this table shows the baseline characteristics. In general, there are similar characteristics between both groups. The mean age was 89 years old. And as you can see here, the previous coronary artery disease and pericarditis was more frequent in the conventional strategy. The syncope as a symptom of aortic stenosis was more frequent in the minimalistic, as you can see here. Regarding the procedural variables and hospital outcome, we use the more frequent valve system used in both groups was the core valve and evolute of MEDTRONIC valve. The predilatation and post-dilatation were similar. Predilatation in a half of patients and 1/4 of post-dilatation. The paravalvular leak was lower in both groups and similar. And as you can see here, the blood transfusion, mainly due to the vascular complication, was more frequent in the conventional strategy, and also the acute renal failure was more frequent in this conventional group. Let me check out this. The stay in a hospital was higher in the conventional strategy, 6 days versus 4 days. And the hospital mortality was higher in this conventional group, 9% versus 1.1%. Here, let me check out this. Okay, the mortality rate, as I say, the in-hospital mortality was higher in conventional strategy, 9% versus 1.1%. After 30 days, mortality was quite similar. 3 patients versus 1 patient, and at 1 year the mortality was higher, but not statistically significant in the conventional strategy. 10 patients, 100% versus 4 patients, 4.4%. Here we can see the Kaplan-Meier mortality-free survival curve. And as we can see here, in the conventional strategy, the mortality-free survival was 47% in blue, 47%, and compared with 58% in the minimalistic strategy. The low-rank p-test was significant. So, in conclusion, I can conclude that this analysis of TAVI procedure performing in a single low-volume center showed, comparing with a conventional strategy, the minimalistic intervention was associated with a reduction in the hospital outcome, as acute renal failure, need of blood transfusion, reduction in the stay in the hospital, and of course mortality. And also the minimalistic strategy had a lower mortality rate at a medium term of follow-up. So we observed that TAVI with a minimalistic strategy can be performed safely and effectively, even in the setting of a low volume center. Of course, we know that we are several caveats. This is a single center observational retrospective study. The sample size of the two groups is low. We couldn't perform a propensity score matching as we wanted. And the mortality rate, we know that could be related with the higher risk score in conventional group, and of course with the learning curve of operator. Thank you for your attention.
Thank you, Dr. Lasave. I wonder if there are any comments from the panel in terms of your practice and you know, what percentage of your patients you're actually doing with the minimalist approach as opposed to a conventional approach. Dr. Lasave, has your study actually changed how you've done your own practice?
Yes, nowadays we are practicing all patients with a minimalist strategy, or almost all patients. Maybe only in patients we can do a femoral access via percutaneous one.
Pacientes en que podemos hacer un acceso, no podemos hacer un acceso femoral percutáneo.
Sorry.
I think we
I am hearing.
Yes.
Please continue.
Okay. I am saying that we use in almost all patients the minimalist strategy, but in this patient that we can use the femoral access to perform by percutaneous one, we need the surgical. In almost patients we use the minimalist strategy. I am hearing the translation here. I don't know why.
Another observation is in many centers, the minimalist approach has also decreased the time in hospital. And I know in your initial experience, it was still relatively long. Have you also seen the ability for these patients, as we have, to ambulate and often be discharged either aggressively that day, but certainly the next day? Have you seen that decrease in length of stay come about because of this approach?
Yeah, the mainstay day in hospital in minimalistic strategy was 3 days, 3 to 4 days is long. We are moving forward to perform an earlier discharge, of course.
I would like to remember for his great job, but not only for the result between the two techniques, conventional technique and minimalist technique. The other important thing that I would like to highlight is that this study was done in local city in Argentina and with very good result. And this is very important for us to show to the social security that sometimes they don't rely in our, don't trust in our results of our job, and they have a very good result, and I would like to congratulate you that job. That's very nice, Leandro. Congratulations.
Thank you. Thank you.
Well, I think we're going to return to Dr. Kim. I think his technical difficulties have been resolved, and we'll look forward again to his presentation on dual axis rotational coronary angiography. Dr. Kim, welcome again.
Dr. Kim, I think you're on mute.
Hi, I'm sorry about these difficulties. I'm presenting myself. I'm Alejandro Kim. I'm a first-year fellow in Argerich Hospital in Buenos Aires, Argentina. Previous studies have shown a reduction in radiation dose and contrast volume using dual-axis rotational coronary angiography, from now on called DARCA. But this has not been replicated in a population with 100% coronary artery disease. We aim to find if DARCA dose reduction is achievable in this population. We sought to compare the radiation dose, contrast volume, and procedure time between DARCA and conventional coronary artery angiography. Techniques in settings characterized by a prevalence of 100% suspect coronary artery disease. So, an all-corner prospective randomized open-label trial was conducted. Dose error product, cumulative error kerma, effective dose, fluoroscopic time, contrast volume, scene acquisition depth, fluoroscopic depth, and total depth were compared between DARCA and CCA groups. Categorical variables as number or percentage. Quantitative variables as expressed as a mean and standard deviation for normal variables, or median and interquartile range for non-parametric variables. So some definitions: we define dose error product as a surrogate measurement for the entire amount of energy as grays per centimeter square delivered to a patient by the X-ray beam. And error kerma is an acronym for kinetic energy releasing material, that is the energy in milligrays extracted from the X-ray beam per unit of mass of air in a small irradiated air volume. So our primary endpoint were the radiation dose measured by scene acquisition, depth, and cumulative error kerma, comparing DARCA and CCA on elective diagnostic on coronary angiography and coronary angiography plus left ventriculography. The secondary endpoints were the effective dose in Siever units, fluoroscopic time in minutes, contrast volume in milliliters, error kerma, scene acquisition depth, fluoroscopic depth, and total depth between groups. According to previous studies, radiation dose reduction in 55% and contrast volume reducing DARCA in 57%, and the possible effect of acquisition beside DARCA in them, we estimated that 250 subjects per group would be necessary to detect 25% reduction in radiation dose with DARCA, with a power of 90%, level of significance of 5%, and 5% of loss in information. A p-value of less than 0.05 two-sided was considered statistically significant. So, from March of 2016 to April 2017, a total of 1,227 consecutive patients were referred to our cath lab. Of these, 503 patients with clinical suspected CAD were included. All these patients were stable coronary artery disease and non-ST elevation coronary syndrome. All these patients had a positive ischemia evocative test positive by stress echocardiography or simple stress single photon emission CT scan. Well, as you can see of this patient, as you can see of these groups, show similar prevalence of CAD and history of cardiovascular factors. The mean age was 61 plus and minus 11 years, and 70% of these were male. There were no difference between groups here in baseline characteristics on the axis side. We found no difference in angiographic disease extension between groups all DARCA patients require at least one additional acquisition to reach a diagnostic procedure. Total additional acquisitions were about 2.4. As expected, that was higher in patients who underwent a coronary angiography plus ventriculography due to higher acquisition DAP exposure. No difference was found in air camera regarding the type of procedures. When compared DARCA against CCA, total fluoroscopic time was similar. Patients randomized to DARCA arm had lower total and effective delivered dose. Total DAP was also lower as a consequence of a lower acquisition DAP. In the same way, air camera was lower in the DARCA group. A reduction of contrast median volume was also achieved in the DARCA group, as you can see. Well, our studies show some limitations. To our knowledge, there are no currently randomized reports with this sample size of radiation dose reduction comparing DARCA against CCA in this particular population with 100% suspect coronary artery disease. Our study has some limitations that should be acknowledged. We did not directly measure the radiation exposure to the operator. There is no direct comparison of the diagnostic accuracy between methods. Nevertheless, previous studies have demonstrated that there is an adequate correlation and agreement between DARCA and IBUS in coronary lesion assessment. The present analysis has limited external validity since it applies only to diagnostic coronary angiography and not for percutaneous coronary intervention, which is responsible for the higher radiation exposure during the contemporary interventional approach. The ALARA principle that is as low as reasonably achievable states that medical radiation exposure should be employed judiciously, and healthcare professionals are responsible for minimizing radiation exposure, both to patients and the healthcare personnel. Applying DARCA in this particular population will contribute to the reduction of radiation exposure and accomplishment of the ALARA principle. Further studies testing dose reduction using DARCA in percutaneous coronary intervention should be carried out to check this acquisition technique in therapeutic procedures. As a conclusion, dual-axis rotational coronary angiography has shown a reduction in radiation dose and contrast volume in populations not requiring several acquisitions additional to DARCA projections to achieve the accurate diagnosis of the disease extension. In this population with 100% suspect coronary artery disease, the dual-axis rotational coronary angiography provides accurate information required in coronary artery disease. It's safe, and it results in a significant decrease in contrast material volume and radiation dose compared with conventional coronary angiography. The required extra projections did not neutralize the DARCA radiation dose and contrast volume reduction achievements. Thank you.
Thank you, Dr. Kim. Clearly, limitation of radiation for our patients and ourselves is incredibly important, and appreciate your contribution to this. Are there questions from the panel about this presentation? Alexandra, I know this is an area that you have a interest in.
Yeah, I guess my question is, have you, Dr. Kim, have you adopted this approach in all your diagnostic caths since you've done this study?
Yeah, well, we saw that since the decade of the 1980s, the radiation exposure was increased by 6 times. We think it's very important to implement every precaution necessary in order to reduce the radiation exposure for the patients and ourselves. So we started doing this dual-axis rotational angiography to patients who had another diseases, such as valvular disease, that they're going to be replaced, heart valve replaced, or I don't know, some other studies that are required. but with the patients with coronary artery disease, we are starting implementing, but little by little. We are not doing this systematically, but hopefully we can do it in the future with all the operators that are in our team.
Yeah.
I would wonder, as we heard earlier today in our first presentation about the application in chronic total occlusions, where we have angiography using 2 vessels, more contrast, often more dose in that, if that's an area that you've specifically considered and begun investigation, or whether that's an area you would advocate for this technology to be investigated in.
Yeah, we didn't start with the percutaneous interventional procedures. We first want to practice with this diagnostic procedure first, and once we implement this and we can evidence that the radiation exposures start to decrease, then we would like to try with this kind of other kind of patients.
Are there questions from other members of the panel? Well, we are approaching the limit of our time. I certainly want to thank all the presenters. I know I learned a lot from their presentations, and it truly represents, you know, the high level of experience, and the high level of research is ongoing. I do want to recognize each of these presenters. Their manuscripts will be published in CCI as part of our collaborative between catheterization, cardiovascular interventions, and SOLACI-CACI. I specifically want to thank Alfredo Rodriguez and the organizing committee of SOLACI-CACI for this opportunity, and also point out that there was a selection committee, that the manuscripts that were presented were identified as best of SOLACI-CACI for the CCI meeting. We look forward to this as an ongoing opportunity, not only for CCI, but in the future for the Journal of SCAI as well. And thank you all for being part of this session today.
Thank you.
Thank you, Steve. Really outstanding session. It was really a pleasure to be a part of this. And I'll make a final pitch for JSCAI. We'll be launching in January. So we're going to be in touch with every one of you for your contributions. So more to come on that. Thanks, Steve.
Absolutely, and we look forward to a very successful tenure that you're going to have, and I know it's going to take the support of each of us for that as well. So thank you, Alexandra.
Thank you, Dr. Bailey, Dr. Lacy. Thank you very much.
All
Bye-bye.
right.
Bye.
Ciao. Bye-bye.
Ciao.
Ciao. Thank you. Bye-bye.
Buenas tardes. Muchísimas gracias.
Good afternoon. Thanks so much, everybody, for your time, for being here in SOLACI-CACI 2021 virtual mode. We are going to start with the oral presentation of important cases with great presenters. These are recorded cases. All the speakers are here in the panel, so we can discuss afterwards. We're going to start with one case, Dr. Rafael Menegus Moreno from Brazil, and then we'll discuss with Dr. Alderete de la Vega, Elorio Cosat, Seropian, and Saderenko, and we're going to ask questions about this specific case. Thank you very much, and without further ado, let's roll the tape. The tape is in Portuguese. There is no translation from Portuguese into English.
SOLACI 2021 da Argentina, e eu gostaria de me apresentar. Meu nome é Rafael, eu sou médico formado pela Universidade Federal de Sergipe, fiz residência de cardiologia e hemodinâmica no Instituto Dante Pazanese de Cardiologia, assim onde eu concluí meu doutorado. E o trabalho está ligado ao meu doutorado. O nome da minha apresentação hoje é segmento de muito longo prazo em pacientes com estenose mitral reumática, hipertensão arterial pulmonar grave, que foram submetidos à valvuloplastia mitral percutânea por balão. Esses são meus colaboradores no projeto. Nós sabemos que a valvuloplastia mitral percutânea por balão é um tratamento de escolha para os pacientes com estenose mitral grave de origem reumática. E a hipertensão arterial pulmonar, apesar de ser um fator de gravidade, não é uma contraindicação à realização do procedimento. O objetivo desse estudo foi avaliar os resultados imediatos e de longo prazo nos pacientes com hipertensão arterial pulmonar que foram submetidas à valvuloplastia mitral percutânea por balão devido à estenose mitral de origem reumática grave. Um total de 1.794 pacientes consecutivos que foram realizados de 1987 a 2011 num único centro, o Instituto Dante Pazzanese de Cardiologia, a valvuloplastia mitral percutânea por balão foi realizada em 147 pacientes que tinham hipertensão arterial pulmonar significativa, que foi definida no nosso estudo como pressão arterial média, pressão arterial sistólica maior do que 75 milímetros de mercúrio. A mortalidade por todas as causas, a necessidade de substituição, troca de válvula mitral ou de nova valvuloplastia e a restenose valvar foram avaliados durante um acompanhamento anual até um segmento de quase 24 anos. As características basais desse paciente, na nossa população é jovem, uma média de idade de 33 anos, mais de 90% sexo feminino, mais de 70% com classe da New York Heart Association 3 ou 4, o ritmo era sinusal na maioria dos pacientes, o score de block não foi dos menores, só 44% era menor do que 8, uma média de 8,68 do score de Wilkins Block. A fração da ejeção era preservada, na grande maioria dos pacientes, com a fração da ejeção acima de 50%, e um valor de átrio esquerdo maior do que 50, um átrio esquerdo bem elevado. Com relação às características hemodinâmicas antes e após o procedimento, a pressão sistólica de artéria pulmonar pré entre 147 pacientes foi de 87 milímetros de mercúrio e após 60 milímetros de mercúrio, ou seja, houve uma redução significativa após o procedimento, que era esperado. A pressão média arterial pulmonar era de 50, também elevada, uma vez que, por definição, a pressão média, a hipertensão pulmonar é maior do que 25 milímetros de mercúrio, e após foi de 35. Com relação às medidas ecocardiográficas antes e após a valvuloplastia mitral percutânea por balão, nós temos uma fração de ejeção que ficou preservada, não houve diferença. O átrio esquerdo, que era de 52 milímetros, foi para 49 milímetros, uma diferença significativa. A área valvar mitral era de 0,83 em média, foi para 2,03, e o gradiente transmitral médio, que era de 16, foi para 6, assim como o gradiente máximo, que era de 27, foi para 12. Todos com diferença significativa, uma vez que foi realizado o procedimento, e há aquele ecocardiograma que é realizado antes da alta, em torno de 24 a 48 horas após o procedimento. Com relação ao segmento clínico e ecocardiográfico, nós temos que antes da valvuloplastia, desses 147, 72%, um total de 100 pacientes, tinha uma classe funcional 3 para 4, após a valvuloplastia apenas 2, e com 10 anos, 20 anos, nenhum paciente com New York Heart Association 3 ou 4. A classe funcional prévia era mais ou menos 2,87 em média e foi reduzindo ao longo dos anos. A área valvar mitral era de 0,83 após procedimento de 2 e nos 10 anos de 1,46. O gradiente médio, que era de 16, foi para 6 e ao longo dos anos não teve uma queda significativa. Assim como o aumento do átrio esquerdo, que era de 52 milímetros e foi para 4,95, mantendo-se ao longo dos 20 anos. Com relação aos resultados, a mortalidade por todas as causas foi de 0,67 ao longo dos 24 anos, uma incidência de troca valvar mitral de 20%, de nova valvuloplastia de 8,78% e restenose em torno de 30,4%. Concluindo, observou-se que houve uma diminuição significativa da pressão sistólica arterial pulmonar após o procedimento, e a valvuloplastia mitral percutânea por balão é considerada segura e eficaz em pacientes com estenose mitral de origem reumática e hipertensão arterial pulmonar. Embora tenha havido uma diminuição gradual da área valvar mitral a longo prazo, a maioria dos pacientes permaneceu com melhora dos sintomas e sem grandes eventos adversos. Obrigado.
Bueno, bárbaro. Impresionante serie.
Great series. I don't know if Rafael is here to answer questions. If not, we can make some comments with the panelists. I don't see Rafael connected. Rodrigo, any comments? You're on mute. First, I'd like to congratulate the authors because it's a very important series. And what's interesting to me is the etiology. Well, we should ask them later to see what are the features, the main features. The results were very conclusive, and it validates international results too. Completely agree. It's a pity that they're not here. Not ask them questions because there were 24 years of data collection, which I think is a very interesting number. Anybody wants to make any comments? Yeah, for me, it's interesting to see that 20% needed mitral valve replacement. They, of course, they treated patients with a high Wilkins score. And it's really important to treat these kind of patients because pulmonary hypertension drops enormously. Maybe in Latin America, the rheumatic fever is considered because we're developing countries. It also happens in north of Africa. In many of these patients, that's what they go and they get treated in Europe. But the practice is really valuable, and congratulations, because having collected data from all those patients throughout the 24 years, it's really impressive. Ignacio, yes. I wanted to add that less than half of the patients had a Wilkins score lower than 8, so that maybe says a lot about the experience of the center. They dare to do this, to treat these patients that do not have a classic score. So less than half had a low Wilkins score. It's not something we see every day.
¿Algún otro comentario? Si no, pasamos a Fernanda, que sí está acá con...
Comments? If not, we'll go with Fernanda. All right. No more comments about this work. Fernanda will show your presentation and then we'll discuss. Okay? Totally, I agree. Again, this presentation is in Portuguese.
Eu vou apresentar para vocês um caso sobre implante de válvula aórtica transcatéter numa paciente que tinha um aneurisma de septo interventricular da proporção membranosa que se estendia até o anular aórtico, que tornou o caso bastante interessante e desafiador. É uma paciente, esses são os nossos disclosures. Uma paciente de 89 anos, do sexo feminino, com doença renal crônica, hipertensão, um câncer de mama tratada e tinha uma história de um implante de marca-passo devido a uma bradicardia, que recentemente tinha sido feito um upgrade para um ressincronizador. As medicações que ela usava estão listadas aqui abaixo. E a história dela foi que ela, então, tinha esse marca-passo e que, recentemente, há 3 meses antes da apresentação, ela tinha feito um upgrade para um ressincronizador devido a uma piora importante dos sintomas e a uma piora da função ventricular e uma dissincronia septal. Ela tinha sido hospitalizada recentemente por uma descompensação da insuficiência cardíaca e sido liberada 1 mês antes dessa apresentação do caso, e veio com uma dispneia progressiva até classe funcional 13, então ela estava bastante limitada, não conseguia fazer nenhum tipo de esforço. Na internação foi repetido o ecocardiograma, que antigamente já tinha uma insuficiência aórtica moderada, a fração de ejeção caiu bastante, o eco prévio tinha uma fração de ejeção de 47%, caiu para 31%, com o aumento do volume diastólico final, e uma insuficiência aórtica importante, como vocês podem observar aqui pelo ecocardiograma, e sem estenose, né, então a abertura era preservada. Já que essa paciente, ela era bastante frágil, ela era uma senhorinha bem magrinha, quase 90 anos, muito limitada funcionalmente, uma fragilidade bem importante, então foi considerado, por mais que fosse uma insuficiência aórtica, a gente fazer uma TAV para ela. E pedimos uma angiotomografia para avaliação, se o caso era um caso bom para TAV. E os outros comemorativos, via de acesso, altura de coronária, tudo bom, mas o que chamou muita atenção, nossa, foi a presença desse aneurisma do septo interventricular, da porção membranosa, e aqui vocês podem observar que ele se comunica com o anel valvar aórtico. Então, era um aneurisma bastante importante, que media 2,5 por 1,8 por 1,3. E pode ver também que praticamente não tem nada de cálcio na válvula. Então, uma insuficiência aórtica pura, válvula sem cálcio, além desse aneurisma aí do septo membranoso. Então, a gente ficou super em dúvida o que fazia, mas a paciente muito limitada, o cirurgião tinha contraindicado a cirurgia devido a essa fragilidade, ela estava bem descompensada da insuficiência cardíaca, então nós optamos por tentar fazer o procedimento dela, um implante de TAV. E aqui, só para entender um pouquinho sobre o aneurisma do septo membranoso, é uma condição muito rara, e principalmente esses que se estendem até o ânulo aórtico, associado bem frequentemente com arritmias, por conta do sistema de condução, né, que passa bem ali atrás do septo membranoso. E as arritmias mais frequentes são taquicardias ventriculares, bloqueios de ramo e bloqueio atrioventricular, que foi o que ela tinha no implante do marcapasso lá. E outra complicação bastante frequente é a insuficiência aórtica por conta do septo membranoso ter essa continuidade com o anel aórtico, e às vezes ele repuxa as cúspides, principalmente direita e não coronariana, causando o desabamento aí dos folhetos com insuficiência aórtica. Então, bem clássico, bem característico de tudo que essa paciente tinha. Então, aqui, o procedimento, a gente vê na ortografia que a insuficiência era bastante importante. Nós, como ela já tinha esse marcapasso, esse ressincronizador, a gente optou, por segurança, em colocar essa prótese numa posição mais profunda, e aqui na ortografia é bem interessante que a gente consegue observar o aneurisma corando aqui embaixo. Não sei se vocês conseguem ver. Aqui, durante a liberação da prótese, a gente vê que ficou uma posição bastante interessante, né, não tanto profunda, e praticamente sem insuficiência. E aqui o resultado final. A ortografia mostra a ausência completa de insuficiência aórtica, não tem nada de insuficiência aórtica. Aqui ela ficou um pouco mais profunda, uns 10, 12 milímetros de profundidade. A gente fez isso intencionalmente, né, para evitar embolização da prótese, porque tinha muito pouco cálcio mesmo essa válvula. E aqui, depois que a gente terminou o procedimento, a gente fez também essa ventriculografia, a gente pode ver que parece que a prótese, ela selou o aneurisma e ele nem está mais corando, então ficou um resultado final muito interessante. O eco pós-procedimento mostra praticamente a ausência de qualquer leak, insuficiência aqui através da válvula, então a gente zerou a insuficiência aórtica. Essa paciente, ela evoluiu super bem, ela foi se compensando muito rapidamente. 3 dias depois do procedimento, ela teve alta para casa, e após 3 meses a gente reviu essa paciente, e ela estava completamente assintomática, o eco mostrando apenas uma insuficiência aórtica muito discreta, com gradiente valvar aórtico de 7, então foi uma evolução muito boa, e um caso bastante interessante. Pela nossa busca na literatura, o nosso foi o único caso, né, nesse contexto. Já tiveram relatos de caso com estenose aórtica associada, de TAV em pacientes com esse tipo de aneurisma, mas com insuficiência aórtica pura, o nosso foi o primeiro, a gente vai buscar publicar também. Gostaria de agradecer a minha equipe querida, que sem eles Eu, com certeza, não teria essa coragem de encarar casos tão desafiadores. A experiência, principalmente do Dr. Salvador, do Dr. Mangione, motivam a gente sempre a fazer casos mais complexos e, graças a Deus, sempre com sucesso. Obrigada.
Muchas gracias, Fernanda.
Thank you, Fernanda. Very interesting case, very well resolved. And there is more data, more evidence about PCI in aortic dysfunction. And now we had the arrhythmia in the septum. So we can start with the debate. Fernando, Dr. Cossack.
Bueno, muchas gracias.
Well, thank you very much. Congratulations. Very interesting case. As Diego said, first for the type of, for treating the aortic dysfunction, it's not a technical disclusion, but I think the sinuses were not that dilated as the tomograph, as the CT scan showed. The finding of a solution to continue in the membrane septum would help us think about a conduction issue that was solved beforehand by the pacemaker implanted before. The valve implantation, it was on purpose, it was deep on purpose. And the question that I ask you now is about the etiology. Do you think this is a congenital case, or this patient, for example, maybe had an infectious endocarditis or something similar? An infectious, it's an excellent question. Endocarditis could be an etiology, but for what we have seen, in fact, that happens due to the flow, very high flow and pressure on the atrium wall, and that's how most of these aneurysms, atrium aneurysms, take place. This patient did not have endocarditis, no history of endocarditis, so we think it's something that she developed over time and due to the pressure that she had in the atrium wall. Can I make another question? Congratulations, Fernanda. A little bit, they contacted me for a similar patient, and I want to ask you the question: if you had chosen another valve in an in a patient with aneurysm, or if you had recommended the core valve. Go ahead, Fernanda. That's an excellent question too. What I think we would do differently is to put an Evolute Pro, but at the time we didn't have that in Brazil. The balloon valves, expandable like Edwards, I don't think they would be that good because they cannot be placed as deep as we needed it to place it. So what we tried to do was to cover the aneurysm, and the landing zone was at the end of the aneurysm. And I think that couldn't be done very well with the expansible balloons. And since it was a pure aortic dysfunction, I think we can recapture this valve. What we do is the implantation with rep pacing and with extra support strings like Underquest to give more stability and more support. And then after releasing, to keep the pacing. Before the final release, we need to know how we place, how the valve behaves. If it's going to move, I don't think we can do that with the expandable balloon valves. I would love to hear the opinion of the others. The balloon valve, expandable balloon valve, if you don't have calcium, they may anchor, and what Fernanda said, you don't have a control. It's a one shot that you have, it's a single shot. And with this type of pathology, the ones we have done in aortic dysfunction, you have to have a lot of, you have to be very careful, you have to be sure that there is no tension in the system so it doesn't remove it. We have to understand that the valve will have a tendency to be placed where there is less pressure, the easiest one. So if you put it too deep, then it can go to the ventricle. If you put it too high, then it may get let loose. So maybe deeper than an aortic stenosis. And with a pacemaker and a systolic that is pretty low in order to avoid the pop-up.
Thank you for this. So I have two comments. The first one, so I think that the implantation was quite low in that case. So just in order to seal this pseudoaneurysm. So is it true? And the second comment is sometimes the risk of using like a percutaneous valve in aortic regurgitation is the risk of embolization. So do you have any cutoff for the accent score, the calcification degree, when you will see that you will do TAVR or it's impossible for TAVR and now you will take the risk of surgical intervention?
Perfect. Both questions are very good. We actually decided to implant the valve deeper, as you said, to cover the aneurysm, and the landing zone being in the LVOT, where there was not an aneurysm anymore. So that was a choice to implant the valve deeper to cover the aneurysm and to prevent pop-up. And the second question, what was it? Sorry for that.
Yeah, about the degree of calcification.
Yeah, so we don't have many data about pure aortic regurgitation and calcium, so it's an off-label procedure. So in this case, we only did it because there was no other option. Because if the surgeon decided to operate this patient, now it went well and everything was fine, but the possibility of a valve embolization and other complications are not low. So I think it's a very off-label indication, and we should not perform in cases where surgery is a good option, you know? So it was just because the patient didn't have any other choices.
Thank you.
¿Algún otro comentario del panel? Sí, Ignacio, por favor.
Bueno, felicitaciones.
Any other comments from the panel? Congratulations, a very interesting, complete case, and the presentation was impeccable. I would have liked to see maybe a little bit more, I don't know, maybe I missed it, about the size of the annulus, the oversize that you were looking for with the valve, and if it was released in the first try, or if you had to recapture it and if you had any pop-up. I should have put all this other information, but the annulus had an area of 430, a perimeter of 70 something, 78, I don't remember exactly, but it was 29, if I remember correctly. And it was right in the diameter of 29, so there was an oversizing. It was the lower border, the lower edge. So we did a little bit of oversizing, and what was a good thing about this valve was that there was no aortic dilation of the sinuses. The aortic artery had good normal dimensions, so that helped, because with aortic dilation, these cases are even more complex and with greater pop-up rates. Okay, we are on time. Congratulations, Fernanda, excellent case. What I would say to close is that these off-label cases and so challenging are for only talented groups. Very important to measure. If Juan Ramon Nieres just told us that he was going into a surgery, we're going to put him at the end so he can be in the debate, in the discussion. So next case, please, it's armpit access in a tavern.
Doctor Tomás Jesús Martínez Jaimes, ha escrito aquí al Hospital de Cardiología del Centro Médico.
Hi, I'm Dr. Tomás Jaimes. I'm going to present a tavern through axillary access. Oscar Millán Iturbe is TAVI proctor for Edwards. And now going to the case itself, it's a woman, 81 years old, and her background, she is hypertense, systemic hypertension. About 50 years ago, they did a coarctation, and that because she had aortic correction, and at that time we already detected that she had issues in the valve, but without gradients. About 2 years ago, before the event, there were 2 complete events, mainly detected with an ECG, baseline ECG, and I think it was about 5 or... And currently, she presents angina and the case that we had to study here, we are now assessing her. She had a FEBI of 60%, and she is being assessed to receive a pacemaker, a definite pacemaker. So clinically, we found that she had severe aortic dysfunction, an AVA of 0.32, bivalve, very unstructured, very calcified, and the mean gradient was 98 millimeters. The gradient in the aortic was 16. Not much different between both and with both sides. We need to highlight that the patient in these moments, after diagnosis and after telling her what the options were in terms of treatment, they didn't want to have an open heart surgery, so we did a CT scan, and we found a lot of calcification in there was a coarctation without an aortic gradient that was that important. So there was a dissociation between the PCMs of the upper limbs and the lower limbs, and at aortic level, the calcification was about 3,000 UH. So the extreme torsion, as we mentioned, it was at the aortic, the LAD. We have to mention this because she has a bivalve aortic. The aortic arc was not in danger. The area that we reported right here.
El área reportada, el perímetro fue
The perimeter was about 389 millimeters, and the coronary height, it was in the ostium that was quite adequate from the right, 24 millimeters, and the left main, 17.8 millimeters. So both femoral accesses were adequate, 5.8 millimeters. However, when we approached the one that submitted the CT, says that this protuberance was going to make it difficult for us to access from the LAD to the aortic arc. The diameters of the left axillary was 5.8 and the right axillary was 6.3. All these are the anatomic characteristics. So the fact that the patient did not want to undergo surgery, we decided to implant with a transaxillary access with a SAPIEN 3 number 23. We chose 23 because we took into account the annulus systole distance. We did not decide to do a lot of oversizing. Despite the reports, there is a registry that is PAVART that tells you what we would normally use as a valve, and we use it only in the case when the landing, the valve landing area zone is directly in the is tubular. Hers was that the case, so we decided to go with the diameter very similar to the one we would normally use. In this presentation, we can see that we had the right femoral axis. We see the guide, the wire to approach the right axillary axis, the punction point. We tried to make it as proximal to the circumflex, humeral circumflex, an area 2. This is 1, 2, and then we did a pre-closing with ProGlide. Here we can see the head, the French of the valve was 14 French. And we first moved with the Safari wire for the system to the VI in the aortic root. We didn't need to place a pacemaker because she already had a definite pacemaker, and of course this is a predilation with a maxi balloon, and we chose a balloon with the size that we were going to use to take the use for the aortic valve without having to do a predilation again. The only additional thing here is that the left main helped us to do the pacing. And as you can see, we freed the valve. We used one that was 80-20, more or less, so that it was inside the tract, the outlet tract, as much as possible. And as we can see in this angiography, we see a little bit of insufficiency in the left ventricle, and the control measures were valve gradient 12 millimeters, no leaks after the procedure. And in the control angiography in the right thoracic area, it looks a good coronary pathway, and we had planned to place a wire all the way in case she presented some complications, and also to control the bleeding. in this part of the axis. So as far as we know, this is the first report of totally percutaneous transaxillary access TAVR in Latin America. And this, once again, states that this is the second, after the transfemoral access, this is the second safest. And instead of thinking about a direct aortic access or a transapical aspect, for these type of patients, I would recommend this patient has a weird aortic arc. Then it's better to do it on the right. For example, in this case, the axial that we used was the right one, since you compromise the perfusion, the femoral perfusion, you only need to go through the vertebra on this side. In this case, the right one is vertebra and the left one is cardi. So we had to make the access as the easiest as possible. In the LAD, we reported 18 minutes, but in case we consider that a new intervention is needed, we would try for it to be a percutaneous intervention regarding the aortic cortection. And the treatment was only with aspirin afterwards.
Again, unfortunately, the speaker is not here. Any comments from the panel members or other speakers? Marcos, go ahead. The axillary access, we wouldn't use it. I believe that tortuosity, I believe we should be with the patient. Maybe we could, use a device femorally, and using the right axis, as the presenter explained, is also complicated. And he showed the reason why. We should have used maybe a self-expandable, because it's a bicuspid valve. And because of some recommendations, we use sizing balloon, because the trend is to use maybe larger valves, and when you do balloon sizing, you end up placing smaller valves, and these are recommended basically by the CT recommendations. But it's an interesting case anyway. And I believe that you, having vast experience in Brazil, Diego, and the other participants, I wouldn't use this access, as I know you. I'd like to say something, and in agreement with what Marcos said. I don't know if this was presented before, the size of the aortic, whether it was narrow or not. And I heard there was no gradient, or significant gradient. And so questions to the panel members, because yesterday in one of the protocard talks, one of the speakers, I asked them the second axis, or the second most used axis after femoral axis, and he said the transcarotid axis. And I just was quite interested in having your opinion, since you have more experience. The second axis, not in a case like this, because it's quite complex, but regarding the complexity of the patient, self-expandable before an expandable valve. I believe, Diego, that we could use femoral access, but it's my personal opinion, and I agree with the fact that we shouldn't be afraid of the other axis you mentioned, the transcarotid axis. And we did very well in some cases in Argentina, and patients did well. So I believe we have to consider it. We need to have some measurements in place, for this access, but it's an option, and I think that it is increasingly being an indication for this kind of cases. Generally, what is used is the left access, but we've used the right access and we hadn't had any issues. With self-expandable, I don't have much experience. I do have experience with self-expandable balloons. The second axis I would choose is a subclavian approach. I feel very comfortable. We've done very complex cases and homographs, via subclavian approach. And the thing is that there's a lot of tension.
So because of the angle, however, from the left, it's straighter. So it's simpler from the left side. You should, the only thing you have to be careful about, with the self-expandable valve is that the introducer has to be quite outside, because otherwise you can't pull it back, or it's hard to pull it back. So the introducer is actually prepared for more of a femoral access, and so this is how I think you can actually work with no restrictions in terms of moving, and then you just do it as a femoral. In this particular case, as far as I could see on the image, it was not so much about the stenosis, but the double angles, the double angulation. Despite, when you have a prior surgery, there's a lot of fibrosis, and it's really hard. So in patients, when there is a bicuspid, and you have to be very confident about the release of the valve, because you basically have a pop-up, so you need to have a lot of control. And if you have extensions because of this angulation, then you have to actually pull back the tip of the valve. I think you're adding new problems. The access from the carotid, it's difficult. I don't have experience on that. I don't know if there are any other comments from the panel on this. Both self-expandable and expandable balloons are good for bicuspids, depending on the operator experience, but both of them have good data and evidence. I like self-expandable because I use them more often. I have just done one case with Boston subclavian, but with core we've done many without any symptoms, and the measurements, Marcos, in the bicuspid, you have to measure it 4 millimeters above the annulus, and generally it's larger than what you measure at the level of the annulus. And the oversizing should be a little larger based on the deformation that the valve undergoes in the bicuspid. In our case, the experience was with accurate, and we didn't have much, many problems with that. We can move on to the next presentation then. Maran. Maran Bukris. let's have a look at the recorded video, and then we'll have some time for questions and answers and comments.
I'm really glad to contribute the SOLACI-CACI 21. And without further delay, let's start with this presentation. My name is Dr. Marwan Boukris. I'm an interventional cardiologist working in Limoges in France, but this presentation is on behalf of my previous center when I was following in Canada. So the title is Trends in Practice in Transcatheter Aortic Valve Replacement, Insights from the 10-Year Experience of an Intermediate Volume Canadian Center. So since the first TAVR performed in 2002 by Alain Cribier, so TAVR technology has tremendously developed, and 100,000 of patients were implanted with transcatheter heart valves. And the indication has also widely and widened with now TAVR becoming the standard of care, not only for high-risk patients, but also for intermediate and low-risk patients. So importantly, real-world outcome data are important to evaluate procedural risk-benefit trade-off in continuously changing population undergoing TAVR. While some data suggests that there is an inverse association between hospital volume and worse outcome, most reported data through literature emanated from high-volume centers. So conversely, little is known about the practice in medium and low volume. So in the current study, we sought to analyze the 10-year experience of our medium TAVR volume center, reporting the temporal trend in patient and procedural characteristic, as well as identifying the predictors of one-year outcome. So from October 2009 and December 2019, 412 consecutive patients were enrolled for aortic stenosis and underwent TAVR. So we divided the historical cohort to 3 cohorts. So first, the historical cohort from October 2009 to December 2014, including 124 patients. The transitional cohort from January 1st, 2015 to November 13th, 2017, and included 126, and the contemporary cohort till December 31st, 2019, including 162 patients. So the division date were according to the evolution of transcatheter heart valve platforms, the adherence of new implantation technique, the generalization, of conscious sedation, TAVR performance in hybrid room since 2017, and the uniformization of post-procedural care by cardiologist and nurse, in addition to TAVR performance in hybrid room already said. So after discharge, patients were followed up at 1 month and 1 year. In a special consultation, the main endpoint was mortality at 30 days and at 1 year. Secondary endpoint were assessed according to the VAR consensus, and futility, which is the original outcome, was defined as the occurrence of the composite endpoint of mortality, stroke, hospitalization for cardiovascular reason, and or the lack of functional improvement after 1 year. So yeah, this is the statistical analysis. So the result, so the case volume has increased from around 30 cases per year during the first period in historical cohort to almost 45 in the transitional cohort. Then it reached almost 100 cases in the contemporary cohort. So regarding baseline clinical characteristic, the age of patient continuously decreased, with a significant difference between contemporary and historical cohorts, and also the STS score decreased over time, and with the more low-risk patient performed recently in contemporary cohort. So regarding other baseline clinical characteristic, less CKD patients were performed in contemporary cohort in comparison with historical one, while the highest rate of prior PCI was in patient included in transitional cohort. Almost echocardiographic characteristics were the same between the 3 cohorts, except for aortic regurgitation, which was higher in the historical cohort. Regarding the procedural details, so more femoral access has been performed during transitional and contemporary cohorts. Overall, 83% of patients were performed transfemorally, while in contemporary cohort, more than 9 patients of 10 underwent TAVR through the femoral artery. And regarding conscious sedation, in a patient who underwent transfemoral TAVR, so almost 90% were performed during the last period with an increase over time. Yeah, so the direct transaortic and the transapical were abandoned for non-TF cases and replaced by other less invasive like transaxillary, suprasternal, and the transcarotid. So this is, so our center was mainly implanting balloon expandable valve, and less valvuloplasty were performed. What about the outcomes? Regarding outcomes, so there was an incredible decrease in the length of stay, and now for transfemoral, the contemporary record just 1 day of median loss, while for non-transfemoral, the median was 2. And this decreased over time. So what about mortality? Mortality was higher in historical cohort in comparison with the others, as well as major vascular complication and life-threatening bleeding. So this also was the same for 30-day outcome, while for and also for 1-year outcome, where the highest was noted during historical cohort. This is the Kaplan-Meier curve, and also the improvement was important and of symptoms, with 88 out of 10 patients who improved their symptoms of at least 1 NIHA class. So for fetal outcome, female gender, prior stroke, and NIHA class at baseline less than 2 were the independent predictor of fetal outcome. So to summarize, so TAVR case volume has increased over time with a significant, albeit small, decrease in patient age and estimated surgical risk. 90% of patients underwent transfemoral unconscious sedation as default procedure, and transapical and direct access declined significantly in favor of less invasive alternative access. So length of stay decreased over time to reach a median of 1 day and 2 days for TF and non-TF procedure, respectively, according to the 3M concept. And the outcome data of our intermediate center were in accordance with that reported in randomized and large multinational registries. So for conclusion, I would say that advances in TAVR indication, patient selection, care pathway, and the transcatheter platform and TAVR technique gradually resulted in better outcomes, mainly driven by the reduction in mortality, major vascular complication, and bleeding in this single center experience. And despite the limited volume of our intermediate center, our results compare well with the larger registry and national registry. So this means that an organized program can achieve results similar to high volume center and manage volume growth without compromising result. Thank you very much for your attention.
Thank you very much. Great data, great presentation. Thank you very much. Amazing numbers that you have there. Y si algún comentario, alguna pregunta para el doctor respecto a la presentación.
Any questions or comments?
Sí, Ignacio, por favor. No sé si español o inglés. La pregunta. Mute.
English or Spanish?
Felicitaciones por el trabajo.
So congratulations. So many results that it's really hard to follow them in real time, even though in the conclusions you didn't put them into hierarchies. There was an STS score, so you treated younger patients. I don't know whether that was significant between the cohorts. The question is if this part of this improvement, the improvement in length of stay and improvement in terms of mortality is because you treated healthier patients.
I totally agree with you. So there is, of course, an incredible improvement in the technology of TAVR, and the growing expertise has also contributed to improve the results. But treating 95-year-old patients with a lot of comorbidities and problems, so the outcome would be worse than treating 75 patients with low risk. So I think the continuous change in the cohort and the characteristic of this patient treated with TAVR also contributed to the outcome.
Un comentario.
First, congratulations, Marwan. Excellent results. I'd like to remember something, sort of a takeaway message, take-home message. The experience has to do with the results. What it actually improves the results is planning and multidisciplinary teamwork, how these patients are addressed, because a lot of centers, particularly in Latin America, we should close our TAVR programs. And I believe that a lot of low volume centers in Latin America, so I believe that that is the main concept, the experience of the operator, but particularly proper planning that go hand in hand with experience, of course, right? I mean, a treatment plan and case planning.
Role of the heart team to select the patient and also to collaborate with other specialists that are working in the different stakeholders into the TAVR program and into structural program in general is very important. And collaboration between interventionalist and surgeon is the, I think, the key point to improve the program and to reach such satisfactory result and good long-term outcome.
¿Algún otro comentario?
Any other comments? A question?
Congratulations on your operation, Marwan. It's excellent. Can I have a question for you? Do you usually make 3D print before performing TAVI in your center?
So during all this study period, no. So now when I left Canada, because now I'm working in France, so when I left Canada, we just started to use the 3D technology, but just for valve-in-valve cases, or when we have some anatomic features that can be problematic during the procedure. So, but it just started now.
Okay, thank you.
Great. Thank you very much, Marwan. Ya lo veo, acá está el doctor Juan Mieres. Espero que haya ido bien, Juan, al paciente.
So here is Juan Ramón Mieres. How was the patient? Fine. Patient was 87 years old. So we'll now listen to Juan Ramón Mieres' presentation.
Thank you for the invitation. Our center has dedicated itself to the structural pathology from day one. In this case, we wanted to share what became in a real nightmare when doing a TAVI implant in a high-risk octogenarian patient. These are my disclosures. The cardiovascular complications such as femoral dissection and cardiac arrest in a patient with severe aortic stenosis of high risk has a very poor evolution, as Leros wrote in a previous communication. The purpose of this presentation is to tell you about this female patient, 80 years old, that during the procedure, she has triple complication. First in the access, then she has a CAP, and she does a cardiac arrest, and we decide in seconds to do a TAVI implantation. She evolves pretty well, and she can go home after 5 days. As I said, she's 86 with an severe aortic stenosis, asymptomatic with recurrent frequency, and We usually approach TAVI surgically and femoral, with the femoral axis. Usually we use the in the punction due to a severe calcification. We have an extensive calcification of all the femoral artery. We try to go through that dissection with different types of wires, and we are unable to do it. So when we go back and using a 0.0014 run through wire, we are finally able to go to the actual pathway and to access the aortic artery. When we cross the aortic valve with a Safari ring and an amplex catheter, we put a Safari string, rather small because it was a very hypertrophic ventricle, and retrospectively we see that the tip of that string, Safari string, is out of place. We do the valvuloplasty with a Zealous balloon, and the patient then presents or performs a cardiac collapse. We do cardiac massage, intubation, ventilation, and in a few seconds we decide that, okay, what are we going to do with this procedure? And we decided to implant TAVI, to do a TAVI implantation. We had prepared a 25 valve Portico Abbott a self-expandable aortic valve. At the end, we withdraw the string and we are able to see that the valve starts working correctly. We do an ECG, transthoracic ECG. We puncture her, we put a drainage, and in seconds, the patient starts improving and stabilize herself. We were able to bring down the synotropic symptoms. This image shows that the insufficiency due to angiography is very mild, and the same thing is shown by the ECG. The patient she gets discharged after 5 days. We do a follow-up with Tramadol and a rehabilitation plan. We do a follow-up after 6 months. The patient shows a moderate IOA. The ECG that we see there has a sinusal rhythm and an AV of first grade. The control holsters did not have any important pauses, so she is not going to use a pacemaker. So 1 year and 3 months of follow-up, and we can see that the patient is now 87 years old, having a normal life. And she's completely independent. What can we say? That the aortic valve implantation has become, honestly nowadays, in the standard practice for symptomatic aortic stenosis in patients with high risk. These patients that are around 80 years old and women are a fragile group, and any complication could be very quickly become fatal and extends. We see that the teamwork with the echocardiograph operators, anesthesiologists, cardiologists, interventionists, can really overcome situations that are very complex in this type of events. And fast decisions can perhaps be decisive when resolving these type of cases. Thank you very much. Thank you, Juan. Very interesting case. What a horrible moment, huh? Yes. At the moment, we had to decide what to do. This patient with a severe aortic stenosis, and we didn't know where that came from, because then the analysis of the string, we did it there, right on the spot. So the echocardiogram told us that was the cause for the collapse. Any comments from the panel? Questions? Ignacio, please. Yeah, congratulations. Really very interesting case. I wanted to ask you if in this specific case they used a hydrophilic string because it was difficult to put a spiral one, or if it's the one that used by default. If you think the valvuloplasty itself had anything to do with the obstruction, or whether the perforation was already done with the string, since it happened so far away from the valvuloplasty. You have to think about the rupture of the annulus, so it would have been weird to seal that just with the valve. If maybe that could have happened with the manipulation with the string, I don't know. What did you get from that? We usually use the hydrophilic string, and I think it's a very small ventricle. We did not assess that. And we passed the valve, and immediately we tried to place the Safari. In this particular case, it would have been more convenient to add a pigtail, to put a standard wire, and then the Safari with the pigtail. We think that hydrophilic is the one that perforated and very quickly produced this obstruction. Okay, Rodrigo, you had a comment. Yes. In that case, I'm obsessed, and as Juan said, every time I exchange with pigtail and I come down with a wire, and every time I didn't do it, I had bad experiences, so I always located with the pigtail. I exchanged it. I have a lot of more work to do, but I'd rather do it that way. Yes, especially that in this case that the ventricle is so small, I think it's mandatory. Looking back, I think we should have done that. I agree with Juan. It's a step, it's an extra step, and it's not that you put the wire, the hydrophilic or the spiral, the pigtail. I think the perforation is when you cross the valve. If you are not careful enough as to how the tip of that wire continues or advances, if you see that it's too closer to the base of the heart, or if it's very close to a muscle, then that is going to occur. The perforation is inevitable. But what you avoid using the pigtail is perforation through the Amplax catheter when you pass the Safari or the hydrophilic. But the pigtail, the simple tail.
El momento de cruzar la válvula es la posición de la cuerda. Y si ves una posición que no te convence, no la podés cambiar, no permitas que avance esa cuerda. Tenerla firme para que no avance y perfore. Sí, Nicolás.
Sí, yo, bueno, primero felicitaciones, sobre todo por no tirar la toalla después de haber venido con tantas piedras en el camino, porque por ahí muchas veces en un paciente como ese que ya encima lo están reanimando, de tomar la decisión de implantar la válvula, la verdad, y encima tuvieron un resultado excelente.
I wanted to ask you if you can make any comment about the prosthesis selections. Why did you choose the Portico prosthesis? And the portico has that trend, you know, to go a little deeper. It looks pretty deep, pretty well, according to the situation that you had, but if you can let us know why you chose the portico. The selection is always done based on the analysis, on the features that the patient has, and also to the pair, the one who participates very actively. We usually try to ask for more sapiens, but the cost compared to this one is always much more expensive. So we have obtained a good curve. It's a repositionable valve that does not have a radial strength so much, a very big strength, but it's being easy for us to do the implantation, and we can do it even up to 4 or 5 times. So we have the experience here in the country. We have implanted more than 40, so we know the mechanism pretty well. But, of course, sometimes in the decision-making process, we have other aspects into consideration. Okay, thank you so much, Juan. And now we'll continue with the last case, Sara Marquez from Brazil. Sara, is she here? She's going to talk about percutaneous mitral valvuloplasty with a single vault balloon. Is Dr. Marquez here? Okay, we'll hear her presentation and we'll see if she's here to have a discussion. The presentation is in Portuguese.
Trabalho, a autora desse estudo foi a doutora Ivana Piccone. Ele foi estudo de 25 anos, um acompanhamento de pacientes que realizaram a valvuloplastia mitral percutânea por balão com o balão Vault e o balão de Noé. Esse trabalho não há conflito de interesses, e o balão Vault, ele é uma técnica muito utilizada devido à possibilidade da sua reutilização, constituindo uma forma mais barata dos serviços de hemodinâmica realizarem esses procedimentos. E usa-se também o balão de Noé, mas devido a ele ser de uso único, ele acaba sendo menos utilizado, e aqui no Brasil, os pacientes que vêm encaminhados pelo Serviço Único de Saúde, é usado o balão único de Vault devido a essa questão do custo. O nosso estudo teve como objetivo avaliar se a valvuloplastia mitral percutânea por balão, com o balão único Vault, apresenta resultados de desfecho e acompanhamento semelhantes ao de Noé. A nossa metodologia incluiu 526 procedimentos, com 312 que tiveram um follow-up durante 25 anos, em que 56 desses 312 foram pacientes que usaram balão de Noé, enquanto 256 foram do balão Vault. Isso se explica pela questão do custo. O serviço que realizou esses procedimentos recebia muita demanda do SUS, do Serviço Único de Saúde, e por isso, muitos pacientes, dos pacientes que usaram balão de Noé, eram pacientes encaminhados do serviço privado. Então, entraram pelo particular. Foi utilizada a análise univariada e multivariada de Koch para a determinação de variáveis independentes de sobrevida e sobrevida livre de eventos. Nós encontramos que no balão de Vault, que teve o maior número de pacientes estudados, 222 eram mulheres, e a idade ficou em média de 38 anos, com 12 a mais, variando entre 12 anos para mais ou menos. 215 tinham um ritmo sinusal. O score ecocardiográfico era de 7,2, também podendo variar entre 1,5. A área valvar mitral ao eco, antes da valvuloplastia, ficou em 0,93, também variando entre 21. E a dilatação, pós a valvuloplastia, ficou entre 7,02, variando também entre 0,30. Para medir a área valvar mitral, foi usado o método de Gordon. E no final, depois do procedimento, durante esse acompanhamento, o eco, que avaliou a área valvar mitral, ficou em 1,54, também variando entre 0,51 para mais ou menos. E apareceu uma regurgitação mitral nova em 17 pacientes. Comparado com o GINUE, foram 5 no GINUE. E uma nova valvoplastia foi necessitada em 13 pacientes desse grupo. A área valvar, os pacientes que precisaram de cirurgia dentro do grupo que utilizou o balão Balt foi de 25, tivemos 11 mortes, e na análise univariada e multivariada, tanto para os dois tipos de balão, a técnica não predisse a sobrevida ou sobrevida livre de eventos. Estatisticamente, analisando, os fatores independentes de risco para a sobrevida foi a idade, menor que 50 anos, o score ecocardiográfico menor que 8, a dilatação durante o procedimento e quem não precisou fazer a cirurgia valvar mitral durante o tempo de acompanhamento. Já os fatores de risco independentes para a sobrevida livre de eventos foi não precisar fazer a comissurotomia cirúrgica e aqueles que tiveram a área valvar mitral pós-procedimento de 1,50 centímetros quadrados. Nessas tabelas, a gente coloca esses dados que estão nos resultados para mais detalhadamente. E aqui nós utilizamos os gráficos de Kaplan-Meier para as variáveis que predisseram óbito ou eventos maiores. E de sobrevida livre de eventos. Aqui também, nesse primeiro, nós utilizamos a idade, o score ecocardiográfico. E aqui também são os dados que foram apresentados anteriormente, de forma mais simplificada na tabela. No final do estudo, a gente pode concluir que durante 25 anos, a sobrevida e a sobrevida livre de eventos no balão único de Balt e o do balão de Noé foram similares, e que os fatores independentes de risco foi a idade, menor do que 50 anos, o score ecocardiográfico de 8, e a não realização de uma cirurgia mitral no segmento pós-procedimento. E os fatores independentes para a sobrevida livre de eventos foi não ter uma comissurotomia mitral cirúrgica prévia e a área valvar mitral pós-procedimento de 1,50.
No sé si la doctora se encuentra, pues la veo ahí abajo que está, pero no. Bueno. ¿Algún comentario? ¿Alguien tiene experiencia en valvuloplastia con balón Balt que no sea con Mitral?
¿Qué dijo?
Yo estoy en un hospital público y la verdad que lo hemos hecho con balón de Inoue.
We always used Inoue balloon. I believe one time we used multi-track single balloon. I think is an interesting alternative. It's amazing to see the vast experience they have in Brazil on mitral surgery. Sana, are you there?
I'm here.
So I have a question. Congratulations, first of all, on your work. Very interesting. Regarding the presentation, I would like to make a suggestion. There is a slide that has a lot of text. It's really hard to follow. And I have two questions. First of all, if you consider that other kinds of aortic balloons that have a so-called waist that look like Inoue, B8, I mean, there are several on the market. If you believe it will be the same or is more similar to an Inoue, and then the multi-variety, if you use the balloon, because that would be an indicator that the balloon that had been selected would actually have an impact on the results.
We just studied in a public hospital here in Brazil, and the because of the cost. As we did, we saw that the Salón is more similar to the INGLÉS, and it costs less for.
No se entendió bien.
No se escuchó.
No se escuchó bien. Bien.
I think we're having some issues with your audio, Sarah. Yeah, your connection, I think, is not good, so we were not able to listen to you.
Sarah, we can hear what you said. ¿Você está ouvindo?
Evidentemente está con internet. Está con un problema de.
So we believe you're having some connection issues.
Ahí respondió por el chat, sí. Respondió por el chat que utilizan los nombres. Era lo que decía Marcos también.
So she just answered that this is a public hospital and this balloon is not expensive, less expensive than Inouye. It's a public hospital. This is what she's answering via chat. And also the case you have, history you have in Brazil.
Ah, claro.
Está escribiendo, perdón.
Sí.
Ah, está bien.
So she's making a comparison with Inouye, and the results were similar, right? Yeah, the results were similar, and the number of cases in Argentina, we don't have as many of these surgeries. Incredible numbers. Okay, we're about to conclude. Any final remarks you'd like to make on the previous case or any other previous case? Okay. So thank you very much. Thank you for your participation. I'd like to thank the speakers for your presentations. We'll meet next year, I hope, in person. Thank you very much, and let's continue with the next session.
Buenas tardes para todos.
Good afternoon, everybody. I'm Ricardo Hueras. I have the honor to be in the oral presentation, Coronary Cases 3. I'm with me, Germán Calfalo, Amalo Descalzo, Juan Tobeas, Suilber Rodríguez Blanco, Raúl Solarno, and Javier Wolkoboynek. So we're going to start with the presentation. The first one is going to be given by Luis Augusto Palma Dacham from Brazil. Go ahead, please.
For manuscript of the role of endovascular laser coronary atherectomy in stent expansion revealed by OCT, imaging in CCTO due to interstent stenosis. So my name is Luis Augusto Palma, and I'm from the University Hospital Cleveland Medical Center. And on behalf of the other authors, I'm going to present this. And I have no financial interest regarding this presentation. So we describe here a case of a 70-year-old white male patient with multiple comorbidities, including hypertension, morbid obesity, dyslipidemia, former smoker, hypothyroidism, and ischemic cardiomyopathy. He had already been submitted 2 years ago for treatment of a severe ischemic mitral insufficiency with MitraClip device associated with angioplasty of the distal third of the left coronary artery, the left main artery, and the proximal third of the anterior descending aorta, the LAD, with rotational atherectomy, rotablator, and implantation of drug-eluting stents. And then he was hospitalized for treatment of coronary lesion due to stable CCS class 3 angina 6 months ago, read with optimized medication, and the cardiac resonance was evidencing the absence of lateral wall viability, but viability in the anterior wall. Therefore, we went to understand what was going on with the LAD and to treat this vessel. So the angiography, patient was submitted to angiography electively, and it showed that the left main and the LAD had a major restenosis lesion of 95%. It was an ISR, interstate restenosis. There was a chronic circumflex artery occlusion in the ostium, and exactly the same as it was 2 years ago, but already with a well-developed collateral circulation for that region. And the right coronary had no significant obstructive lesions. So here we can see the ISR of the left main to the LAD, very severe lesion here. And then the case was discussed in the heart team, and because of the patient had a high surgical risk, he was chosen for elective percutaneous treatment of the lesion, and the procedure was performed via the right femoral artery. So we implanted a ProGlide so that we could close the vessel at the end of the procedure. The left main catheterization was performed using an EBU 3.58 French catheter. Then we used a run-through guide wire to the LAD. So the OCT was performed without the need for predilation of the lesion, with clear images of the for acquisition, and despite the severity of the lesion, and that could hamper this performance, and the presence of a large amount of intrastent fibrotic tissue was observed in the LAD, left main, with a mean stent diameter of 2.75 regarding the mean distal reference diameter of 2.73 and a mean proximal reference diameter of 3.65. So here it's a pullback that we performed so that we could acquire these images showing a very severe lesion in the proximal left main. So here in the pullback, we can see the distal part of the lesion, very good lumen. This is the lesion that we can see inside the stent. So you can see the stent here, a very severe lesion, very stenotic lesion. And then in the proximal part of the stent, we can see that a very, very good lumen. So we did a laser atherectomy using a catheter 2.0 device with a frequency of 60 and a fluence of 40, with significant photoablation of the new intimal hyperplasia and significant increase of the lumen area that we conquered. So from the satisfactory result of the laser atherectomy, a Zion Sierra stent was deployed at 10 ATM, and a non-compliant balloon stent was used for post-dilation successfully, with a mean stent diameter final of 3.47 in relation to the mean reference diameter of 3.42 and a proximal reference of 3.63. Thus, with excellent expansion and satisfactory result. So here we can see the stent being placed, and then here we can see the stent being deployed, and then the final result here performing the OCT pullback with a great angiographic result. So here we can see the final result, like this top part of the stent, medium part of the stent, and the proximal part of the stent, all of them very well expanded. So the OCT here was especially important for the determination of the restenosis mechanism, the lesion anatomy, and the procedure planning We observed an extensive neointimal hyperplasia associated with intense and extensive coronary calcification, with the possibility of failure in the attempt of compactation of this intense proliferation of intrastent fibrotic tissue with the use of predilation with only balloon catheter. So that was why it was really important to perform a good atherectomy using the laser. And with that said, we plan to perform an appropriate neointimal resection, ablation, debulking of the lesion of the plaque through laser atherectomy. So in summary, a significant luminal gain was observed through the three different mechanisms in this case. First one, the ablation of neointimal hyperplasia with a luminal iron area gain of 3.08, and then an expansion of the previous stent resulting in a luminal area gain of 4.99, and finally a compression of the residual neointimal hyperplasia with a luminal area gain of 1.71. All this together turned our procedure into a great success. So we perform a final repair of the femoral artery with the pre-implanted ProGlide device, and the patient was discharged home on the next day. And this is the final slide showing the sequence of events here. First one, the neointimal hyperplasia inside the stent, so a lot of fibrous tissue here. And then the debulking, great debulking just after laser. So after laser, you can see here a great debulking of the vessel. And finally, here, after the stent deployment, the second stent, right? So we can see 2 layers of stents here, and the final result here with a great stent expansion. Thank you very much for your attention.
Vamos al final de las presentaciones.
At the end of the presentations, we're going to have time for questions. So let's go to the second presentation now, in charge of Dr. Cesar Lopardo. He's going to talk about coronary angioplasty, when to say no.
My name is Cesar Lopardo from Dr. Julio Mendez Healthcare Center. My case is coronary angioplasty. When to say no. This is a male patient, 43 years old, risk factors, hypertension, smoker, drug abuse, cardiovascular history, several hospitalizations, normal electrocardiogram, diagnosis without a T elevation, and positive cardiac enzymes. During hospitalization, the next 48 hours, the patient evolves, so we decide to perform IFR. In the LAD, the FIR values are 0.99 and pullback 1. After that, we move on to the first ventricular lateral side, 0.99, and is the register. Then the circumflex artery, first of all, from the left ventricle to the main left, the pullback is 0.97. We continue working on the lesion towards the left main. The value, the IFR value is 0.90, normal IFR value, which is 0.98. Then the pullback is performed. This is when the wire is pulled back to the takeoff, and this is 0.89. It is, so the record is 0.90, which is normal, and this is 0.88. This is a borderline. There is a 0.02 difference, which is acceptable. So the coronary IVUS is performed. This lesion is assessed. The minimal luminal area is 3, and the proximal and distal markers greater than 4 millimeters square millimeters. This lesion has a 0.98 IFR, minimal luminal area of 3, significant burden, plaque burden, and so we decide to perform then angioplasty of the circumflex artery. The side branch is protected, and a DS is implanted. Then there is a post-dilation. We perform post-dilation. After angioplasty, then the IFR is performed, 0.96. Regarding IFR values, there's no final target value. We do know the higher the IFR value is, and as a cutoff value, which is above 0.98, so this is an acceptable value. The patient then, 27 days later, goes to another healthcare center for having negative enzymes, and at this center they identify this lesion and they require angioplasty in that vein. No IFR is performed because everything was based on an angiography, the assessment. After that, 3 months follow-up, the patient also again presents an atypical angle. The patient does not have new lesions and the stent is patent. 9 months later, with a typical angle present, the patient presented with, and so the angiography shows occlusive restenosis of the side branch, and then an anostial lesion of the circumflex artery. This restenosis compromised the circumflex and also the LAD ostium. Because of the characteristics of this lesion, a decision was made to revascularize the patient. 6 months after the surgery, the patient presents or shows typical anger. The catheter surgery is performed again. The patient continues with the restenosis, the bypass to the LAD, which is patent, and here a muscular bridge is identified. The patient also has the result is that an angioplasty of the left main to the side branch is performed, which is related to an ischemia. This was a protective angioplasty because the bypass, the mammal bypass was present. Follow-up. 7 months after the surgery, the patient presents herself with anger again, variable class. The angiography is performed again, patent bridges, a new lesion, and the stent without restenosis. What is present is a greater involvement in the muscular bridge. Angiographically, we see more involvement. The patient still has anger variable class, no acute events. This is a year ago approximately. Summarizing, This is a 43-year-old patient. Prior to surgeries, he had multiple hospitalizations. On the right side, a functional assessment was performed, and after that, the marginal side is treated, is addressed, which leads to a revascularization because of the lesion. In the sixth surgery, we treated the restenosis from the left main to the ventricular side. The patient has a variable functional class anger. As regards this lesion in the ventricular side within normal ranges, if the patient had not undergone an angioplasty, then the patient wouldn't have been able to continue with these kind of symptoms. As regards the clinical case, and this is related to the title of the talk, coronary angioplasty, when to decide no, we could say no when the IFR is normal. Thank you.
Muchas gracias, doctor, por su presentación.
Thank you for your presentation. I believe we have some minutes for questions and answers or comments about the presentation. So we have then more time to continue with the presentation. So anybody from the panel would like to make a comment or question regarding the two presentations so far? Any comments? As regards the laser, the case presented by the Brazilian colleague, it's a technology we don't have in Argentina. Not many centers have it, and it's really accurate. And if we could actually have that technology to deobstruct arteries, I think it could be really useful. Unfortunately, we cannot address these cases where the wire actually moves forward but not the balloon, or intrastent stenosis, where this technology would be very useful. We'll see that a lot of these technologies, we cannot use them on a daily basis, and even though we have very positive results, and Dr. Torresani will show that, it's important to highlight they could be better. It would be better to have these technologies available on a routine basis. Any other comments? Thank you. This is Raul. I agree with Javier. Without a doubt, a complexity of cases being treated increases daily, and probably these technologies will have a niche, like the laser, for example. It's been used, we've been using it for several years, but initially the complications with these technology was quite high, and this has been reduced over time, and this is related to a better patient selection and so on. So I would like to hear from Dr. Palma the right patient and the right, but if the doctor is not here, we could discuss this later. Dr. Palma is not online.
Sí, vale.
Siguiendo la línea de anteriores compañeros y hablando del caso en particular.
Along with OCT and the case presented by Cesar, which looks very interesting. One angioplasty, why not? This was an acute coronary syndrome without ST, right? because with ST it would be different. So ruling out the artery that you treated, I think we would have treated it in the same way. I think that in the acute coronary syndrome without ST, I think that we could I think we should look for new evidence in these new syndromes that would indicate how invasive they are or not. So there's the OCT images, the mechanism, and if it were an erosion, we could continue with a more exhaustive medical treatment and future biomarkers that and probably then we wouldn't have continued with the rest of the arteries, when it's considering that the IFR is normal. And as regards the first stage of the patient, the right coronary artery, which was acute, we treated the circumflex artery, the patient was discharged, and as an outpatient, the patient was stable. The patient did not have, we decided to perform angioplasty because he had anger. So we knew that the IFR was absolutely standard. Probably the images were not that clear. Angiographically, that looked severe. Angiographically, it was okay, it was right to address that branch. With this new background or history, which was normal, and then this is where we hesitated about it when the IFR is totally normal. One of the issues with these values are the extreme values. So when it's absolutely standard or absolutely pathological, then this is where changes take place. This was the first patient we had with a standard IFR where we performed an angioplasty. Thank you. Any other comments? I believe that it was proceeded appropriately. I don't know whether there was an ischemia that appeared on an electrocardiogram or to revascularize the right coronary.
Adelante, doctor. Siga, después le damos la participación del doctor Chihuahua.
So I was saying,
quería preguntarle.
So my question, if there was ischemia in the RCA, and I think that you follow routine protocols guided by FFR or IFR. The questionable thing, or the thing I would question, is with standard IFR, circumflex angioplasty, I'm afraid that's not appropriate. I mean, I wouldn't have done it myself.
No se te escucha, César, estás muteado.
You're on mute. You're muted. So there were some days in the and angiographically, and it couldn't be seen clearly. There was a thrombotic, it was an acute plaque, and we treated that. The patient improved, and the patient was angiographed. I mean, and as regards the other, we expected, I mean, we performed the angioplasty, and if we had been very objective and the evidence, when the evidence in the angiography is severe, and the evidence is in FFR and IFR is low, there's not much evidence, and this is the reason why angioplasty was performed. And that was our first step as well. Today, we'll probably perform the angioplasty, but we may, I think we would at least discuss it. There are tandem lesions, in tandem lesions, then this was IFR that discriminates tandem lesions. We use IFR directly, and we can specifically individualize or identify different segments, diffuse lesions or tandem lesions with the IFR, not the FFR. Good afternoon. It's an honor to share this afternoon with you this talk. First, congratulations on your presentations. I have a question for Mr. Palma. I work in a healthcare centers. 90% of the techniques we do, we access them radially. We don't have these technology. This is a technology that is not really available.
No sé si se logra escuchar. No se escucha, no sé si se logra escuchar la duda.
Sí, yo escuché.
No está el doctor Palma.
Me parece que no está el doctor.
No, el doctor Palma no está en este momento.
Si te referís al láser, en el caso que presentó el doctor Palma, utilizan láser.
They use a 2mm laser in the main left. Regularly, a 0.09 laser is used, which is compatible with 7 French. And if the patient could be accessed radially with that 7 French, the thing is that here, complex cases with bifurcation and double stent, 2-stent techniques, we use RIS, 7 French, catheter guides. That's why I was wondering whether these devices could be used in this approach. Continue with the presentations so that we have enough time to finish. Let me introduce Marcelo Torresani, who will be talking about the Argentine registry of coronary angioplasty.
I would like to remember Dr. Angela Lamelas, who died this year after battling chronic disease. She was expert in statistics, epidemiology, and cardiology, and she worked very hard to put this registry together. I'd like to express our recognition and our gratitude. The topic today is the intra-hospital, the initial intra-hospital results. To begin, I'd like to say that we have done a couple of years, up until May 2020, since February 2012, 67 centers participated, 3,602 patients. We published several papers with the objective to represent the current data. We presented this study, and the general goals are expressed in that slide. It's a prospective, multi-center registry with a one-year follow-up, and we've included all the patients that had a coronary angioplasty in those centers that participated. In the middle of 2019, we invited all the centers to participate in this registry, the hemodynamic centers, and they completed data in a prospective way and consecutively, and also a consent and some other elements for these type of studies. Finally, in September 2019, we started recruiting patients, and we completed the information. They were able to complete the information online, designed for these purposes. I have to mention that the protocol was previously approved by the Ethics Committee in Research by the Cardiology, Argentine Society of Cardiology. Even though at the beginning more than 60 centers participated, finally 38 centers from 15 provinces in Argentina were selected. This presentation was sent for SOLACI 2020. In that sense, we included patients between September 2019 and July 2020, where there were 1,775 patients from 38 centers, and we excluded from this analysis 151 patients from 8 centers, since they had not completed their paperwork. Most of them were men, mean age 65, dyslipidemic 60%, smokers or former smokers 33%, prior infarction 30%, angioplasty 34%, kidney disease 26%, half of them on dialysis, cardiovascular from other territory, about 10%. We observe valvulopathy in 86%, aortic, and in the rest mitral, myocardiopathy 55%. All of them had dilated myocardiopathy. It was mainly in unstable events. In the analysis of the coronary circulations, the dominance is the usual one, as well as the distribution of the obstructions, with one vessel disease in 58% and proximal 41%. The success was pretty high, 92%. Most cases were solved in just one procedure, with a very low incidence of the use of different diagnostic methods such as IVUS, OCT, FFR, IFR. And 1/4 of the patients, we used systems to optimize the stents. We used different types of stents, like the conventional balloons, 1.5%. Most of them used DES. global mortality was low, 1.84%, with other complications such as branch occlusion, slow flow, coronary perforation, coronary dissection, reaction to contrast, transitory blockage. In terms of excesses, we had femoral hematomas 2 points and radial hematomas 4%. None of the patients had to be revascularized. So the conclusions are that the characteristics of the population that was included in this registry shows the type of patients treated every day in the centers where it was performed, which probably reflects what happens in general. The clinical instability decided the indications in most cases. The proportions of the coronary dominance and obstruction distribution reflect the percentage that we now know. The goal is to know the global success rate with low complications and low mortality. There is a low utilization of devices to prepare the plate, the plaque, and diagnosis methods complementary distinctive to the radiological ones. And the access pathway was the radial one, which is the one that was mostly used. Thank you very much. Thank you, Marcela, for the presentation. Now we're going to ask you to go to the next presentation, and then we'll discuss all the global results. Okay, so now we're going to present a trial that compares RADAC1 and RADAC2. The initiative of the hemodynamic department of cardiology, CACI, with collaboration of the hemodynamic of FUNDAC between May and 2010 and February 2012, we did a multi-center study that included all the patients that had angioplasty performed in those centers. The idea was to do it for 1 year, but then it was extended for 9 more months. The goal was to know how we were revascularizing our patients and how we were doing in that regard. The idea was to include all patients, all possible patients, to the ones that had coronary angioplasty, so much so that we invited at the time to participate to all the centers that had interventionist cardiology departments in the country. This is the list of all the centers that participated of the first registry, which is the RADAC1. At that time, we put together a database that we were able to complete it confidentially online. And with a similar methodology, we did RADAC2 in September 2019. And we had the participation of 38 centers from 15 different provinces in Argentina. It's worth noting that both protocols were previously approved by the Ethics Committee in Research by the Argentine Society of Cardiology. In order to compare RADAC1 and RADAC2, the data from RADAC1 were obtained from these 2 publications, the Argentine Interventionist Surgery magazine and the Argentine Interventionist Cardiology and Surgery magazine of both years. So we had intervals of 10 years. It's worth noting that 57.89% of the centers that participating in RADAC2 had also participated in RADAC1. In RADAC1, we included 147 patients per month, and in RADAC2, 168. We didn't have any differences in terms of the age, body mass index, dyslipidemia, or revascularization, myocardial surgery prior to that. In RADAC2, the proportions of hypertense, diabetic, smokers without prior events was greater. Also, the association the association with vascular events in other areas, and the LAD. There were no differences in the clinical scenarios or the restenosis. In terms of the tactical procedures, there was a tendency to use the femoral access more than radial due to the use of DES, with a very low trend to use devices of the plaque preparation, the contraposition balloons. The primary success, global primary success, was pretty high in both registries. Low mortality, no differences between both of them. And there was no difference either in the need to do revascularization surgery as an emergency. In fact, in RADAC2, there was no case that had to be referred for an emergency surgery, no stroke, post-ACT. And as a conclusion, even though the centers that participated in RADAC2 were almost half of those that participated in RADAC1, the number of patients increased. Those included monthly, expressed in an increase in the angioplasty practice. In RADAC2, there is a bigger prevalence of severe factors such as female cases, diabetic, etc. There is a clear difference in the approach, in the access approach and the type of stent chosen. Thank you very much. Thank you for the presentations, Ernesto. Very interesting. You show the reality. There are so many provinces in Argentina, right? I mean, I'd like to ask the panel if you have any comments, any opinions about these two presentations by Dr. Torresani. They show a reality that is a reality in our countries.
I would like to say something. My name is Germán Cafaro. Excellent presentation, Dr. Torresani. It's really great. In these two presentations, you could show, all of the effort made in your teams. I had the opportunity to participate in both groups, and the kind of strategy, the stenting strategy, the approach strategy, we have been using femoral approach mainly in the last 10 years, and in the center, in 90% of the cases, we use radial approach. And DES is what we mostly use. It's, again, as I said, it's great to hear, to be able to listen to these two presentations and to be able to participate. Thank you, Germán, and thank you for participating. This has been great effort on behalf of everyone, especially you. Ernesto, how are you? First, congratulations and all of the participants, your group, together with yourself, Alejandro. We were the pioneers back then, and seeing, this has become a reality, and I think that we should all participate in this registry because it is our reality, is real life, is what we do, which is different from guidelines, papers, and trials. And what we do, we see what we do, how we do it, and it's great for us because we find ways to improve ourselves. These registries should not be closed. There should be open platforms So we should all have them in CACI, or because these are very important for us. I mean, having our results, our numbers, that could differ from other countries because of different issues, either because we don't have the material, because of our patients. I mean, vascular speaking, our patients are different. So I'm very proud. I feel very proud about your presentations. It's very important for us. I mean, these kinds of registries, they provide us with our data, and this is really wonderful. Thank you, Amalia. I love registries, and mainly because of what you said, and basically because they show reality. So, as cardiologists, for many years now, even though evidence-based medicine is important, sometimes there are different kinds of bias because the investigators have their own interests, but registries, their added value is they're really valuable, and this shouldn't stop. I mean, we should continue enrolling. Good afternoon. Congratulations, Dr. Odesana. Very interesting register. I agree. Register results actually talk about how serious and committed we are to our work. This continuous work of a group of researchers in real life of patients and patients they see. You said you're doing more than 90% or so radial approach. And we've also developed a sub-study because there was a high number of patients that were approached radially, and also a lot of patients that were approached femorally, and 65% of the cases were approached femorally, and 6 out of the 38 centers, that is 16%, defined or selected the femoral approach, and a smaller percentage, 11 out of 38, that is 26%, went for a more balanced approach. We did this analysis, and this is linked with the complications, since the radial approach today has become more popular because they say that the femoral approach had some complications. One of the things that arise from that analysis is that complications are very low in both. There's no significant differences. Complications were due to other reasons, but in general, people performing these approaches, I mean, there's no significant difference between one or the other approach. These registers are interesting because with a high number of patients, you can actually see some details or some information that you didn't see before, and this is one of them. Dr. Bocconi, congratulations, Ernesto, and everybody who took part in the registry. Did you make any comparisons with some other region? I mean, comparing similar registries? because I think it would be interesting to see where we're at and the different practices, as Amalia just said, from the material point of view and from the point of view that our patients could be different, or patient referral could also be different. We just included in September 2020, September 19, 2019, September 2020, and we are at a time where we actually working on inclusion, because one of the issues that these registries have is that oftentimes colleagues that include patients, then there's some inconsistencies. So we are just analyzing things, considering different aspects, but to do what you're saying, which I think is very interesting and will do in the future, but we haven't done it, is that we should work a little more on the registry. Maybe we should do this with some statistics expert. With one of the persons in the group has written a book, and I mean, she's really an expert on statistics, so we could probably work on that in order to sort of improve or work on the inclusion criteria. This is something that we have to do, and I'm sure we're going to do it. Congratulations, Ernesto. I believe that this registry gives the community of cardiologists and interventionists what to do with patients. Oftentimes, you know, whether we have to send a patient to surgery or angioplasty, the decision is made on trials that are carried out in other countries, and we should have our own results. And in this sense, this is a strength, and we should have results, you know, of surgeries in our context. And a question about the results, which were very good, but I have the feeling that increasingly complex procedures are being performed. So was that measured? Just to measure whether we're performing more complex cases? Yes. Yes, and one of the reasons is that we have more patients, and if you compare the numbers of admissions a month, so the difference in centers is 67 and 38. A monthly inclusion is markedly lower. 10 years ago, we sent more patients to surgery, probably. This was an item that was included in the registry, but a lot of the colleagues did not follow it. Syntax, for example, registered, and we'll have fewer patients that have actually complied with this item. Probably we'll have a look at it in a sub-study, but the feeling is that patients are more complex. Over 80% are unstable with the infarction with or without ST, unstable angina, almost 80% of unstable patients. And then regarding risk factors, more women, more diabetic patients, I mean, more diseased patients. And as regards syntax, even though the proportion, one single vessel or multiple vessels, I think that a vessel doesn't go to surgery these days unless, there's a heavy obstruction. Otherwise, nobody would attempt surgery. But angioplasties, yes, a lot of single vessels or of multiple vessels. Dr. Rodriguez, what do you think about? I couldn't see whether there was a significant difference. I saw an increase in thromboaspiration. But what do you have to say about that? Thromboaspiration in RADAC 1 was in 2%, 62 patients, and in the other study in 2.61, 63 patients. And the P is 0.006, so there was a trend. It was not significant, but there was a trend to a greater use of thromboaspiration. Personally, and this is just a personal opinion, I like thromboaspiration a lot. We've been working on infarctions for many years now, and we have a lot of experience with acute infarction. There was a time we used stat balloons or balloons. We were there, treating for an hour and a half, and then the stems came in, and many things happened to us this year because we often use the inhibitors, and in Argentina in 2019 we ran out of 2B3A inhibitors. I've used oxicimab, and then after that we didn't have oxicimab or aberstab, and most of this registry was involved September and December 2019. There was no 2B3A inhibitor. So when that happens, then you have to become resourceful. And this is where thromboaspiration comes in as a possible alternative. As you say, thromboaspiration is, in my opinion, if it's well used, it's useful. We shouldn't use them in every patient, such as some studies proposed. Status study proposed that, and that actually damaged the evidence, and thermoaspiration was thought to lead to more thrombus. And this is not so, because a trocar study showed that the greater number of strokes was after that, not during the procedure. So if you look at it very attentively, and if you use the thromboaspiration appropriately, And to my understanding, it's a very useful tool. These days, we're treating a lot of patients with more evolved infarctions. So if you see a patient later than that, you can use thromboaspiration in that particular case. So the situation in such cases is not the same. Have we answered your question? Of course, thank you.
Loveras, una pregunta corta o un comentario.
Very quick comment so that we can move on.
Te oye, Loveras.
You, Loveras.
Ahora sí.
Quería felicitarte, Ernesto, por
Wanted to congratulate you, Ernesto, for the registry. The usefulness of the registries really help us in our daily practice to know where we're standing and to know that we have evolved so much over the last 10 years in the right direction. So congratulations. That's all I wanted to say. Thank you so much. Well, now we're going to go to the last presentation of Dr. De Brady. Thank you. I don't know if you can see my presentation. Yes, we can see perfectly well. I'm Juan Pablo De Brady. I work in the Mitre, Sanatorio de Trinidad Mitre. I coordinate the cardiology department. I'm going to talk about the evaluation of a minimum invasive strategy for angiotensin computerized angiotomography, CT. So we know that TAVI revolutionized treatment of patients with severe aortic stenosis, and however, we know very little about the coronary disease management related to TAVI. Its prevalence changes and goes from 20 to 70% according to the different series. And the prevalence of coronary disease is associated to the worst results in the post-intervention results in the long and the midterm. So it's key to know the coronary anatomy pre-TAVI, but we know that in minimally invasive strategies, we have to think about the diagnosis. Even the CCG is the gold standard. We wonder how efficient is the angio-CT in this population, and if not using the ECG is worse. So far, we know that the angio-CT has a very important role when it comes to defining the size of the annulus. So it's a test that we do in all the TAVI cases. So we also know that ECG is not risk-free. For instance, access lesions, stroke, nephrotoxicity. And we also know from multiple studies from Italian groups that show that there are good levels for sensitivity and specificity to exclude coronary disease in patients that are TAVI candidates. And that's very important because those TAVI candidates do not only have a lot of calcium in the aortic annulus, but also in the coronary accesses. They also have arrhythmia, which makes the specificity of the angioplasty could be wrong. However, they reached between 85 and 90%, both in sensitivity as in specificity. So our study was a prospective cohort studies in 2 private healthcare centers in Buenos Aires, and we included consecutively all those patients that were that had TAVI performed between March 2018 and January 2021. According to our minimally invasive strategy, they had only an angio-CT when we found a significant coronary disease. And what that meant was to have a lesion bigger than 50% only in the proximal and medium segments, or when the angiography was not enough due to the impossibility to define the obstruction percentage. All the angio-CT were done in CTs, multi-detectors with more than 64 rows, and the results were analyzed by our team: systolic phase 25 to 40%, and the diastolic phase 70 to 85%, to assess the coronary anatomy. Of course, all the TAVI procedures were done with the prostheses that are available in Argentina, and the valve division was considered by the anatomy of the patients. So the primary goal was to see the MACE incidence more than 30 days, 1 year post-TAVI, and we define that as the occurrence of cardiovascular death, myocardial infarction, and revascularization, whatever happened first. That's how we reached the results, the outcomes. 82 patients submitted to TAVI in this cohort. Mean average age 80 years old. 80% were fragile, and most of them had moderate or high risk scores. And if we see the first slides, the previous angioplasty or coronary disease was about 30% of incidence, prevalence of coronary disease, 18% with the previous angioplasty, and 11% treated with a prior revascularization. From these patients, all of them, we did the angio-CT to assess the annulus and the presence of coronary disease. And out of those 54 patients, 65%, we excluded the presence of coronary disease through the angiotomography. So we could do it without the CCG, prior ECG. In all the other cases, we had to do an ECG before implanting the valve. The primary incidence accumulated to MACE 30 to 365 days in those patients was about 4.8% and 9.7% respectively. But what does that mean? For discussion, with the revolution of TAVI, we know that the evolution of these devices came from the evolution of, so the revolution of TAVI came with the evolution of devices, and it also came from the optimization of the technique. Here we see two implantations, one at the beginning of the experience, and then one more advanced. The technique has improved quite a lot. But we also have to think about the method, the diagnosis methods might need to be better. In this case, we try to assess and show that the screening strategy, minimally invasive screening, promises to be, or allows us to be efficient, and 2/3 of the patients continue to TAVI without having an ECG. This is a limitation of the trial, because we didn't have a group to compare. But if we find the incidence of infarction that we had, after 1 year, the incidence was 2.9%. Very similar to the ones found in the international records and trials, when the evaluation of ECG was the method of choice. The limitations were that, well, it was an observational study, it did not have any group to compare, and with a reduced number of patients. So the conclusions is assessing with a minimally invasive technique, screening coronary with angio-CT is efficient, is safe, it tries to reduce the health costs, and it could also reduce morbid mortality. Of course, we need randomized, multi-centered works to validate these results. Thank you very much. Thank you, Juan Pablo, for the presentation. Very interesting. Any comments by the panel?
No más que felicitar.
I want to congratulate the authors, because I think it's very interesting. It's a problem that we always have with the patients with TAVI, or that we're preparing for TAVI. And I think it's an important thing to say. The results are very important. So there is not much that has been published about it. So I just think it's great. And if you can make it, have a larger scope and publish it internationally, that would be great. Something to clear out is that this data, the work was done before the activation work was done, the PCR trial was. So perhaps treating the coronary disease before TAVI is not associated to better or worse outcomes. And maybe we don't have to treat the coronary disease, and yes, to treat the aortic artery, and maybe we don't have to be so accurate in some patients, of course, not in all of them. Any other question from the panel? Yes, I wanted to congratulate you for this idea of having these minimally invasive procedures. Really, it's very interesting. And my question is with regards to patients that did CCG. You found obstruction more than 50%, and what happened with the CCG and what were the results? Yeah, that is not expressed in the slides. We do have the information from all the patients that had CCG. 75% had lesions that we had to treat. 25% of patients were false positive, to put it somehow. That 25% was due to calcification or bad quality in the CT. Excellent presentation, Juan Pablo. Very interesting topic. My question is, the time that elapsed between the angio-CT and the procedure itself, did you take that into account in terms of doing CCG or not? Yes. Since I work in a private institution, the delay is very little, no more than 3-4 months. But we do have patients that are in a very small cohort from PAMI, why didn't we send the CCG to those patients, those PAMI patients? And in that case, it was a little longer, maybe 6-8 months, and we didn't have any worse outcomes with those patients. Dr. Rodriguez, you wanted to say something? We can't hear you. Can you hear me? Yes. Okay. No, I just wanted to congratulate the doctor the physician for his presentation. All non-invasive or minimally invasive procedures are very nice. And no questions, actually. It was just to congratulate him. Thank you. I have a couple of questions for you, Juan Pablo. First one, I just want to have a better understanding. For me, when I ask for a pre-TAVI test, I say, why don't they send the coronary too? Checking the coronary in CT, does it require a specific protocol? Do I have to put it specifically? In general, if the CT is required as triggered, they have to send you the diastolic and the systolic. In the systolic, 20 to 40%, we assess the aortic annulus, and in diastolic, between 70 and 85%, the coronary phase. So, again, since we are a private institution, 90% go to the same diagnosis center, so we never had any issues. But if you asked for it as triggered, they should send it both. The analysis was ours. We did the curve NPR to see if we had obstructions or not, even though the images, we had a report from the images. The second question, for me, the number of coronary without significant lesions, 65%, 64%, that's pretty high. Did you relate that to the age of the population you selected? Yes, our population is, remember the average age was 81, was pretty old, and the prevalence was 30% of coronary disease. Maybe because we are in a cohort of a population that is a private sector, and maybe the patients that we get at that age have not had coronary events before. So I don't have a clear explanation. Why do we have such a prevalence of normal coronaries? All right. Any Wasco Boynek? Doctor? Yes, I wanted to ask Ernesto about the RADAC2 that if it ended in July 2020, if you have thought about doing an analysis of the months that were covered during the pandemic, because all of us have had a very significant change since the beginning of the pandemic, and I think it would be interesting to see how the population changed, those patients that went into the hemodynamic area until July 2020. So if we take the last 3 months compared to the previous ones, we could compare to the practice within the pandemic and prior or pre-pandemic. Between September 2019, it started and it ends in September 2020. That's when recruiting ends. However, some colleagues continued, including patients even a couple of months after that. And one of the things that we came up with was to see, okay, what happens with the number of patients that were included? And that's what we've all lived. Our work dropped considerably everywhere. What we haven't done, and it's something that maybe that's what you mean, is maybe to see what the behavior was. Something that really caught our attention. Infarctions were different. They were not exactly the same. The behavior of the thrombos was not the same. You know, it was a very subjective impression. One of the items that I would have liked to assess, I don't know if we're going to be able to, is what I told you about the use of the inhibitors, which for me was crucial in terms of infarction and management of a thrombus. But the problem we have with that, I followed that up closely, is that we don't have in those type of inhibitors in September 2000 2B3A inhibitors. We didn't have any. I never knew why, but we didn't have any in the country. And then it started coming in again. And one of the things that I think it was interesting, and it's one of the items that we found in the registry, if it's ARA status or the 2B3A could be related to envelope infusion, what was the difference? And there is a complete item to analyze the thrombos that at some point we're going to analyze them in detail. So to answer to what you're saying, the difference of the work we had, we find it reflected in the number of patients that were included. Other than that, the other item, and this is very subjective, it's not something that comes from RADAC. There is a behavior in some patients in the mid thrombus very different from the one we usually saw in the past. What I want, we've all seen differences in the practices. Those who do vascular, not only cardiologically, but also peripheral, I found that the peripheral pathology, acute or semi-acute, has increased. I don't know whether there is a little mobility by people are not moving so much over this time, or if there is any other reason related or not with the virus itself, or with the changes in the lifestyles. But it's incredible the number of patients that have had acute or semi-acute peripheral disease, very different from the practice that we had before the pandemic. When we are not the parameter, because we don't see a high percentage of patients with COVID, but if you talk to cardiologists or clinical physicians or therapists, that have handled a high percentage of COVID, they have seen more percentages of pulmonary thromboembolism, but the lung thromboembolism is not something that occurs so much. It happened in the peripheral patients. They have maybe one of the limbs that the pulses are perfect, the other one is ischemic, and all of a sudden one has a thrombotic episode more than an embolic episode, and that apparently would have to do with the way and the behavior of COVID in these patients. Clearly, the phenomenons linked to thrombosis infarction, for instance. I don't know how to express it, but it's not the same as the type of infarctions that we usually saw. There is something different about the thrombose management. For me, it's surprising. We manage it with the elements you have. Sometimes, as we said before, the thromboaspiration, we don't use it so much, and now we use it maybe a little bit more. Or the 2B3A inhibitors, that we didn't use them so much and now we are using them more. And in that context, I think that there are different things that are going on, and we should see how we compare with the two situations before COVID, during COVID. In the same, on that same note, we had the same thing happening. Infarctions were not the same, especially last year and part of this year. I don't know how to explain it very well, but it's not the same type of thrombosis, and it's not solved the way we solved it before, in an easy way. And more so, we've had thrombosis when everything was perfect and we thought that we had finished that angioplasty. We said, okay, let's take a look at and then the artery was blocked. And no event happened to say that, okay, we have a no flow. And that's happened in several cases. And with regards to the peripheral, yeah, also, it's the same. And and Raul would remember, but because I told him, we had thrombotic events in patients who had no peripheral vascular pathologies. I can tell you about a patient who he was discharged with COVID, and then he comes back with a thrombosis in the lower left limb after 2 days of being discharged, and we could do nothing. We do thromboaspiration, balloon, strings. We put 2 beta-3A inhibitors after 2 or 3 hours, and finally they ended in the worst way. This patient ended in the worst way. The surgeon himself did 4RT, and he didn't respond to any of the treatment, neither endovascular nor vascular, by the surgeon. So once again, he had to have the limb amputated. So I think it is different. The thromboembolic events are different, and we all agree on that. I wanted to add something about that, about these differences that we find in patients with infarction. There is a report of a series of cases, it's very short, from Singapore, where they found patients without risk factors, really healthy, who had COVID several months before, and in the angiography, they did IVUS with virtual histology, and what they found as significant findings are fibrous plaques, but not necrotic. So the plaques that you normally see, that you think are the most stable, are the ones that break the least, and these ones had a great thrombotic load, and then they had all lab results that were also very highly thrombotic. So the main manifestation is not only thrombosis, but also the plaque accident. Just 2 more comments and then we'll have to close. I agree with Dr. Javier in the presentation of these patients is really new. The experience with I have seen patients with STEMI and with a very high thrombotic load. But I have a question. I wanted to know if in this registry or in the experience of the other colleagues, they have had infarctions in patients that are getting out of COVID and how that happens. How is the thrombotic load in patients that are coming out of COVID? Not in the acute part of the infection, but patients who have had the infection. Here in our team, we haven't had those cases, but I wanted to know if any of my colleagues have had that issue and how they managed it. In the RADAC2 registry that we have submitted, it was not something that we considered. We haven't seen it, so it's not registered. But I think it's something that we still need to do. It's an outstanding topic that we need to analyze. These patients, as we said, they're all very different, and as a consequence, we should do a deeper analysis of the situation. As Amalia said, that peripheral patient and everything she said is a common experience in those type of patients. But of course, we should think about approaching them differently and treating them differently. What RADAC registry, we don't register those cases. We did not foresee, because we did not foresee COVID coming, but when it started, we did not predict that from happening. But it would have been important to we have only 1 minute left. I just wanted to tell you about my experience. I agree with you. I see the same experience with the same thrombosis and the thrombosis load of those lesions. And I've even had post-vaccination, which is something very weird, a completely abnormal behavior. And that's something that we need to take into account. We have to think about it. There is a post-vaccination syndrome. There is an immunity against the platelets, the coagulation, that we know the potential consequences or what path this is going to take. We have to be alert. Thanks, everybody. I'm sorry, I have to finish. It's 7 o'clock, it's 5 o'clock, and I have to end. I want to thank you all for dedicated this time and for the great quality. Thanks to Solace. It was a pleasure to be with you. Thank you very much. Thanks, everybody.
Perfecto.
Bárbaro. ¿Pueden ver ahí la presentación? Muchas gracias por la invitación. Vamos a tratar en los próximos minutos este tema que habla de lo que es el tratamiento médico óptimo en pacientes con insuficiencia cardíaca e insuficiencia.
Medical treatment in cardiac failure. We know that heart failure is a chronic progressive disease. We have different interventions along the different stages. Despite that, even though survival has progressed in the last few years, its mortality is still important. This impact on mortality could even be better than other pathologies involving both genders, and the impact is also significant in terms of life quality. It's even worse than in other pathologies such as EPOC and diabetes. Functional mitral regurgitation can be found across all of the cardiac diseases, and we can see that this functional mitral regurgitation is not only a risk prediction, it plays a key role regarding physiopathology, which has an impact on the functions. As we look at prevalence and prognosis in this patient population, about 30% of the patients with heart failure will have functional mitral regurgitation that could either be severe, intermediate, or moderate, or low. This has an impact, a significant impact in the quality of life and mortality. Functional mitral regurgitation, this patient population can reach a mortality up to 60% in 6 years, and its presence has an impact in the survival of these patients. This is why an early intervention is important. Early intervention means that functional mitral regurgitation is the first treatment option we have is pharmacological treatments or medical treatments. On this timeline, we can see the main clinical trials that have proved benefits with functional mitral regurgitation. We can see that in the last 6 years, we've had great scientific breakthroughs to treat this pathology. Due to time restrictions, we'll not go into detail, but I like to say that these would be the most important trials and large studies that have had an impact on mortality in these kind of patients, these groups of patients. And the neurohormonal model has shifted to modulation, hormonal modulation, together with lymphocytes that have shown benefits in the myocardial metabolism. This is how these 5 different medications we can actually address the treatment of functional mitral regurgitation. There are other drugs as well that have made beneficial contributions, but they can be used in different populations based on their own characteristics. These drugs can be administered through these 4 different pathological approaches, among them other interventions to be performed in other specific patient populations. The way as to how to approach the medications or the administration of medications has also changed. The benefit of a treatment with simultaneous, administering them, the 4 drugs simultaneously, has had a benefit on patients after 30 days with a relative reduction of up to 60%. This is why it's important to start them simultaneously. When we see this evidence at the guidelines level, the American, Canadian guidelines and the guidelines that will be submitted before the European Cardiology Congress, these 4 drugs have been adopted as treatment options. Currently, we have papers stating that these drugs, considering also lifocin, have proved to have had a beneficial impact on the patient's population. This is why a key strategy to start this medication on patients based on a clinical stratification so as to have a specific regime per each patient. Now, if we look at the guidelines more in detail regarding functional mitral regurgitation, we can also see that in the algorithm, the most important thing is the optimization of the medical treatment, considering also the possibility of whether these patients can could undergo surgical treatments, or whether the patient requires another kind of therapy. And those patients that remain symptomatic, to think of more advanced strategies such as PCI and others. And this algorithm, which is more complex, more detailed, functional mitral regurgitation, we need to optimize them initially with a pharmacological treatment to assess whether the patient complies with certain requirements. And in those patients that have gone through these options that remain symptomatic, we need to consider CPI or valve replacement or heart transplantation. A recently published paper by the European Cardiology Association, they published a very similar algorithm with an optimized medical treatment with a heart team to assess the need for treatment, and then which patients would be cardiac patients or valve replacement, such as Siganos and heart transplantation. Another algorithm that seems to be simple to treat this functional mitral regurgitation is to evaluate the etiology and to see whether we are facing a severe failure and whether this is proportionate or not, and based on this define the possible strategies for the patient based on their characteristics, such as, for example, pharmacological medical treatments or other kinds of therapies. And then moving on to a possible percutaneous mitral replacement. So this is the sequence we need to consider when thinking about the optimal treatment for secondary MI in functional mitral regurgitation. So we need to assess which patients could actually benefit from a percutaneous therapy, or which patients could actually benefit from more advanced therapies. For complex patients, multidisciplinary treatment is required, such as physiologists, surgeons, physicians that specialized in imaging, to come up with the best option for the patient. To summarize, when we think of an optimal medical treatment in patients with functional mitral regurgitation, we need to think of these four main drugs as pillars to provide these patients with the appropriate treatment, so we can optimize them simultaneously, progressively based on the patient features, comorbidities, financial resources, lifestyle. And the main challenge, I believe, is to detect which patients could actually benefit from more advanced therapies aside the pharmacological or medical treatment. The failure route, I mean, we have a long way to go, and the key thing is to adapt the latest evidence to the patients individually. Thank you. Thank you, Florencia, for the presentation. We'll now move on to the next presentation. We already have the clinical approach summarized by Florencia. Now we'll deal with the ultrasonography screening of patients for endovascular therapy. Dr. Walter Garcia, he is a staff medical doctor from the Instituto de Cardiología from Corrientes.
Bueno, buenas tardes, muchas gracias.
Good afternoon. Thanks for the invitation. I have to talk about the ultrasonographic screening of patients for endovascular therapy. So IMF is an illness from the left ventricle and not of the leaflets. And this prevalence in the left ventricle could be divided in ischemic or non-ischemic. 1/3 of patients that have heart ischemia, they have a progression in this ischemia and adverse results if they have a moderate IMF. In a normal myocardium, the walls in general are normal. There are no alterations, and the closing forces and the tethering forces are different. They're out of balance. So there is an increase of the tethering forces increase when there is a left ventricle dilation or there is a sphericity, and there is a decrease in the closing forces. They reduce the contractility, the sphincter of the mitral annulus, it contracts, and they start having this restrictive valve movement. As we can see, this is a high prevalence prognosis, more mitral insufficiency with few. So the first mitral clip is the first percutaneous procedure. In this regards, we're going to have to select very strictly all the patients, and that's why we're going to need the echocardiogram, and we're going to have to characterize the mitral valve, whether it's functional, organic, or mixed, the severity of the mitral insufficiency to see the treatment, and here we're going to need the transesophageal echocardiograph and parameters, additional feasibility parameters. We need to do all this in optimal hemodynamic conditions. This increases the severity of the insufficiency if we do the study with general anesthetics. In general, the severity decreases. So as we said, we have to characterize the severity, and this is where the first problem begins. When we read the European guidelines and the American guidelines, their criteria, the semi-quantitative criteria, they both agree. Pulmonary vein systolic flow reversal, but when we talk about FMR, primary or secondary, then it's very different. The European is less strict than the American one. It has fewer values in terms of the EROA diameter. In the case of the American guidelines, they ask for a bigger diameter. And the other problem is when we actually identify the orifice, this talks about the proximal isovelocity surface area before the valve. And in general, the formula to calculate this proximal isovelocity surface area assumes that this is a sphere, and in fact, in the FMR, this happens very randomly, very occasionally. There are multiple citations, and this was reflected in both studies, both trials that evaluated the FMR, which was the European test, MITRA-FR, and the American one, which was COAPT. The European had no results, and COAPT, as Dr. Fonseca will show, it had excellent results. And when you see the inclusion characteristics, it was an inclusion more than over 20, while the American is more strict, and they want an orifice more than 30. And that's where we say, okay, there is a disproportionately severe MR. This table shows that in this axis, the EROA are larger with volumes that are larger, and here is where the co-opt patients are, and patients with a smaller EROA are right here. So we understand that in co-opt we included patients that are more valvular, and in the Mitral FR they were more treated patients, and that's why they didn't obtain any results. But the important thing is this value in order to select patients, which is the ORE in millimeters, mercury millimeters, square millimeters, sorry, over VFD above 0.14 with patients more similar to ACAPT. And if it's smaller than 0.14, it's going to be more similar to Mitral FR. As an example, if we look at this patient, a patient with 41 square millimeters over 200 milliliters, this is above 0.14. So if we have one that is 31 millimeters and 250 milliliters, the result is lower than 0.14, and then he would not benefit from the procedure. To select the patient, we also have to see the anatomic morphology of the valve, and these are the ones that they have assessed the first generation of mitral clips. We have recommendation or general criteria like a valve area above 4 centimeters, not a lot of calcification in the valves, no perforation of the valve, no calcification in the grasping area, that there is not a lot of regurgitant jets, and they have to have a coaptation length that goes up to where it ends the union of the leaflets, and a coaptation depth of less than 11 millimeters, so that this depth is taken from the mitral annulus until the union begins. In this morphology, with this morphologic description and technology, the intervention of more complex valves, one can classify the valve morphology as optimal, an area more than 4, and this is recommended for teams that are starting treatment, endovascular treatment. Then we have the intermediate morphology, which is the possible valvular morphology, when there's mild calcifications, smaller mitral valve area. This is for more experienced teams. And the third level of complexity, the difficult or impossible valve morphology, such as the Barlow pathology or discard patients with perforated valve. And also, as we saw, we have nowadays an improvement in the technology. In Latin America, we have the third generation mitral clip with an improved release mechanism. One has a longer arm, so we're going to have to select the mitral clip for the patients. And in Europe and in America, they're using the fourth generation of mitral clip, which has, apart from longer arms, they're thicker in order to intervene patients with a longer, with bigger lengths. So as we said, we're going to start with the 0 degree. In this patient, we're going to start seeing the 4 chambers view. We are looking at the A2 and P2 of the mitral valve. If we go higher, we're going to find the aortic or the 5 chambers. Here we'll analyze A1 and P1. And if we go back and if you go deeper, we see the tricuspid valve and the A3 and P3 segments. That's what we're going to analyze. So here is for you to see the example, the upper part, when the aortic valve appears, the aortic artery. Then we go to the midsection. If you see it, there is a proximal convergence flow. If we turn around and we go to the commissural view, we are going to analyze segments P1, A2, and P3, but we can clearly see that we are in the presence of a main flow, central flow, and this allows us to also approach the treatment, and then we turn around and we see the LVOT. Here we do a cross-section, as more specifically with segments A2 and P2 of the mitral valve. If we have the possibility to have 3D, this one has an X-plane that is going to show us micromesural view, lateral and posterior, and the 3-chamber or outlet tract to analyze where it is and to start attacking the FMR. We will also see from the right atrium to the left atrium to articulate the mitral clip and to go to the mitral valve. And this is something we'll have to do more specifically in part of the intra-atrium septum. Here, this is the bicave vein, and posterior to the aortic to go to the mitral valve. Walter, 1 minute. So we saw an optimal patient. No. So we'd like to thank Dr. Marian Salvo. This patient, he had this is a complex patient. All the leaflets are, this is a Barlow disease, a very complex, high complexity patient. And last but not least, this patient that we did during the pandemic in our institution, it was a patient that was quite dilated, a big orifice, and we decided to do surgery to intervene, and this was the final result with a reduction, a significant reduction of the mitral insufficiency. If you see the 3D, we have 3 clips, 3 mitral clips, and we normalize the flow in the pulmonary veins. And she's already dancing and doing exercise. So we have to remember that FMR is prevalent. It's a pathology that is high in prevalence and with an adverse prognosis. The treatment is controversial, and it's been difficult due to several factors. Mitral clip widens the axis of the treatment, and echo is key for a quite selection of cases. Thank you very much. Very nice and very clear presentation, very interesting. And now that we've already assessed our patient that was previously selected by the clinical group of heart failure, we want to know the next point of view, which is mitral valve percutaneous repair evidence, an interventional cardiologist perspective. And for that, we have the honor of having Jaime Fonseca, interventional cardiologist in angiography Occidense Cali from Colombia. Go ahead, Dr. Fonseca. Thank you for being here.
Good afternoon, and thank you for the invitation. We will discuss the ideal patient for this treatment. As an introduction, let me show you that MEDTRONIC has a lot of experience around the globe. We've been here in Latin America since 2003, Colombia, Argentina, 2015. There are over 1,000 patients treated. So the first thing we need to consider is this study, as opposed to degenerative pathology. FMR was more surgically, but the group of patients with FMR is really reduced. This is why we have the hypothesis that MEDTRONIC could be a similar therapy to surgical therapy, and based on this, we have observational studies, mainly access trials performed in Mexico, in Europe and the United States, and we can see how in selected patients, MitraClip could actually improve patients and reduce rehospitalization and mortality rates due to cardiac diseases, heart diseases. COAP trial, despite patients have heart failure, patients were included in two arms, MitraClip plus GDMT, and in the 2-3 years, we can see a reduction of rehospitalization and mortality. But cardiac patients are dynamic since the clinical course begins. There is a decline over time, and so probably Mitra FR is for this specific patient. This is why Mitra F results can be controversial. To emphasize this concept, it's important to look at the functional sub-study. This is a relatively recent study published last year in TBT Congress and recently published in JACC Intervention March this year. Patient in functional class 2, if there is a persistence, is the kind of patient that would actually benefit most from the percutaneous therapy. So American guidelines of 2021 changed the concept, because if you look at guidelines 2017, you see that the description or the definition was different, and now they already include patients with class 2 functional classification. If you look at the subgroups, it is necessary to treat these patients in functional class 2. This is just to show you the current guidelines published in 2021 that will be presented in December 2020, where patients are classified in functional class 2. So the patient having endovascular repair indication are patients with heart failure, FMR, despite an optimal medical management. In the heart failure group, and the patient is in functional class 2, 3, 4, a depressed ventricular function. The diastolic level is lower than 70 millimeters, and systolic pressure of the pulmonary artery should be greater than 70 millimeters mercury. If the patient meet this criteria, so a transesophageal electrocardiogram is performed. So what did we need to ask a physician when facing a patient with FMR? Well, an early diagnosis in the first place, with a physical examination and a transthoracic assessment. So the first thing we need to define by Carpenter definition whether the MR is secondary or primary. When the valve and subvalve has a normal morphology. Secondly, that severity is classified. As you saw it with Dr. Walter, there is disagreement between FMR, between the American and the European groups. This is why at least 4 qualitative or semi-quantitative criteria must be met, and the 3 qualitative parameters. And if we can also consider the regurgitation function. This is a paper that discusses the harmonization of all of these classifications. And if the patient meets any of these criteria, then the regurgitation function should be greater than 50%. So this patient meets the high-risk criteria. The third thing that has to be requested is that disproportion of the mitral function. There are basically two patients with heart failure with depressed systolic function. In the patient, in the first patient, there is a very wide regurgitation orifice, and the ventricle is not so dilated. And in the patient below, we have a mitral failure that is in agreement with the type of classification we're looking at. So if we have these two patients on this chart, we can see how the first patient is the regurgitation function is too high. So we say that MR is dominant, while the second patient, the LV is really dilated and MR is just a secondary finding or non-dominant based on this clinical scenario. As Dr. Walter said, we can relate the two and easily get to the index, and in this case the patient is in a disproportionate value. Now once the patient is identified, in the next 2 minutes I would like to discuss which are the patients who are the patients that could benefit from this. The first thing we need to do is what happens with patients with pulmonary hypertension. There are some patients that meet with all of the clinical and anatomical conditions, and they do not meet with the pulmonary hypertension criteria. In the co-op trial, they define what happened with these patients' PSAP greater than 50. And the result of this is that patients with HR higher or lower than 50 benefit from endovascular therapy, but as PM increases, then they're no longer beneficial. But now what happens with pulmonary pressure post-implant? There is a study performed by the Israelis that evaluates the function of, or the pressure artery pulmonary and the outcomes. And you can see how MitraClip is able to significantly reduce pulmonary hypertension. These are the baseline parameters, and you can see the significant reduction of pulmonary hypertension. This is for severe, mild, and low. In this chart, to summarize, you can see how patients that benefit from this have a severe PHT. So the controversy is why these patients are rejected. This is an observational study anyways, so further evaluation is required. This is the clinical evolution of patients. The pulmonary pressure was not the biggest predictor of rehospitalization or reduction in the quality of. So what I would like to say is that patients should improve with the treatment. Finally, the Spanish are publishing the fact that not only, pulmonary pressure, the relationship with the left ventricle and pulmonary pressure. So they have this rate or this index, and they found that with this ratio is lower than 75, the patient has a good prognosis. Otherwise, it's a poor prognosis. I don't mean that patients should not be treated, but this has an impact on patient selection. for the last 10 years, the group of Olaf Franzen from Germany and the group from Canada, they're looking at transcatheter mitral valve repair and in the fact that it may increase eligibility for heart transplant. So this is a relatively recent registry, and MitraClip is capable of improving pulmonary resistance and reduce systolic pressure. In a selected group of patients, it may have a possible therapy. So the mitral endovascular repair is an excellent treatment option for patients with severe MR. You can see this here. Almost 4% of patients with heart failure comply with this criteria, so they should be taken to a center to be treated. And also consider what Florencia said, optimal medical management must be monitored in via formal program. Thank you for your attention. Any questions or comments? Thank you, Dr. Fonseca. Again, we've enjoyed wonderful presentations. These presentations have been so practical because we tried to convey clear messages, and in this session, we want to also have a multidisciplinary approach for the discussion. This is why we have clinicians, we have echocardiographers, so we can have different views. We have also people from Corrientes, Santa Fe, Tucumán, Rosario, Mendoza, Córdoba. So we'll now have some time for discussion, questions and answers so that we can all take part. Dr. Agüero from Corrientes, thank you for the invitation. I would like to ask Jaime a question. We're working with the third generation of devices, but most of us have been using the second generation. We treated functional failure with the second generation. You have been working with this third generation for a long time. Have you been able to reduce procedure time? I mean, what is your experience like?
Generation is more for degenerative patients than for functional patients. Functional patients, they don't have a difference between the treatment with the small clip and the big clip. Let me tell you that next month we'll start in Colombia with fourth generation, and for the next 3 months we will have fourth generation for Argentina. I think those are the news I wanted to give you. So I think it's great, especially because fourth generation has thicker, wider clips that is going to allow you to put just one instead of two. The functional one has a bigger flow, and that's why it's important to place two clips. And there is a recent study that is not published yet. I didn't want to show it, where they define that two clips is better than one, but worse. It's better to have two than one, but three is worse than two. I still don't have the complete data. That's why I didn't want to announce it. But this is a study that in the next 2 weeks is going to come out. It's a very big European study that is in functional patients. And now what we're trying to do is to decrease the insufficiency at the minimum. So that thing that, okay, some people say, okay, if it's moderate, let's leave it at moderate. But the spandex fourth generation didn't want to show because they were primary and secondary pathologies, non-functional. It shows how they impact in generation 3. The rate goes up to 85%. In fourth generation, it goes all the way up to 92%. So we are trying to find right now excellence in therapy, and of course, without compromising stenosis. Thank you, Dr. Fonseca. Next question. Dr. Cursac from Santa Fe, Guillermo. Hello, good afternoon, everybody. Congratulations to the speakers. A very nice roundtable. There are so many questions that I want to ask you. One to Florencia, one to Jaime. Florencia, you somehow show the advances of the 2021 guidelines for heart failure, and they put all the medication in the same line. And the question we have to ask ourselves, what is optimum medical treatment? Do we have to follow a line? Which one do we start with? In the DAPA, only 6% of the patients took ARNI, and if the patients would take all the medication, would they remain with the symptoms that we see in clinical trials of invasive treatments like the COAP? And regarding Jaime, the question for you, we clinicians, we feel it's a weird feeling for us about the simultaneous presentation of two counter arguments, Mitra, FR, and COAPT. So my question is, do you think, or is there a need to have a larger study, multi-center in Europe and in the US, that would define maybe more clearly and in an easy way those patients, and that would give us an idea that they really work, it really works for those patients? Thank you. Florencia, you go first. Hi, Guillermo. Excellent question. I think it's something that we will be able to evaluate from now on, because as you correctly said, in COAP and in mitral FR, we had a very low rate of patients with inclusion of acne and lymphosines. We did not introduce them. And we talk about these four pillars of the treatment. We don't have populations that we have studied other than the recent publications. So now we will be able to see the actual benefit. And if what we see in the evidence and in these publications, we can extrapolate that and make it evident in our population, in the daily clinical practice. Because I think from now on, we will see it as long as we can introduce these four drugs. It has been proven, though, that the benefit is clear when we introduce the four of them quickly, simultaneously. The reality is, as I said in one of the slides, the clinical profiles, not all patients will have four drugs. Some of them, like lymphosines, don't need labeling, and they have a null impact in the heart frequency, but the other drugs will have to do a lot with the patient profile. And even more so, and it goes on a second plane, the accessibility to the medication and how affordable they are. So from now on, we will have to evaluate in our population to extrapolate what the evidence has shown us in order to see the actual impact that these four drugs together have in the population other than in the clinical trials. Excellent, thank you. Dr. Jaime, can you answer the second question, please? Yes, thank you for the question. I think that right now, we have already defined patients with functional mitral insufficiency that needs endovascular treatment. I don't think we need an additional study, multi-centered or a clinical experiment, comparing it versus CLIP. We now have records phase 4 post-marketing where they clearly show that CLIP is still beneficial in selected patients. They have the SPANs 3 and 4, the ones that are coming out, the Euro SMR registry that I don't know, that Florencia did not check that, because in that trial, 90% of the patients with the 4 drugs that she shows have done the therapy, and they're still benefiting from that therapy. So what I can tell you is the Japanese, Indian, Asian trials in secondary pathologies are coming, but I don't think there will be a multi-center study, once again, Europe, US. I think the same researchers of the Mitral FR studies say that they know that they did their studies with their learning curve. They had a complication rate of about 17%. After 1 year, the success rate was not even 80%. So it had to do with the third and fourth generation. If you cannot guarantee an optimal outcome, then you will not have a reliable outcome in the long run. And it's not just about placing a clip, it's knowing how to place it. And it's not just implanting one, it's implanting 2 or 3 so that the insufficiency, so that the failure is as small as possible. So I think that what we can learn from all this is that we need to do the therapy in very well selected patients and in centers that have a lot of experience in order to have few complications and the best outcomes, of course, with the best technology also. Thank you, Dr. Fonseca. We have a few minutes. We have 4 panelists. Quick question, quick answer, please. Good afternoon. Great presentations. In patients with functional mitral, with FMR, the clinical and the functional test and the ECG, we have seen that mitral FR, the results have not shown benefits versus the clinical treatment. But yes, in the quote, perhaps mitral FR because the treatment comes late. But the question is, when is the right moment, starting right moment to start with mitral clip? Are we thinking that we are treating late and the results are not the ones we expect? Maybe treating patients in C2 stage where they are asymptomatic, but there is a left ventricle dysfunction, we could perhaps get a better benefit. What do you think of a treatment, maybe an early treatment with an optimal medical treatment, but C2? Maybe Daniel Larribot can answer because they want to start with the next one. Dr. Larribot, could you answer that very quickly? You're on mute, doctor. Yes, I apologize because I did not, I do not listen to the question. If not, okay. I could answer that. What we're trying to look for is to try to bring the patients as early as possible in that order of things. We ask the doctors that treat heart failures that 2 or 3 months later, they do the optimal treatment management as soon as possible. In our patients, they are doing follow-ups every week. They go to the heart failure control follow-up. They do it very quickly so that in 1 month, they can take them to the best available therapy. And if they need a synchronizer, then they place it after 2 months and they repeat the ECG. But the heart failure is dynamic. 60% of the patients can improve with the right medical management, but it's the functional class is not the same as the FMR and the left ventricle and the right ventricle. That's why it's so important for the patient to have the best possible treatment and repeat the ECG. So that's going to prove if the patient requires the option or if they continue with an optimal medical treatment. If that's the case, if they continue with the optimal medical management, they need to have follow-ups every month so that they don't have the first situation again because they go back in time and then. So the recommendation is in 3 to 6 months, the patient has to have defined what we're going to do with him. I agree with Dr. Fonseca's comment. Unfortunately, we are out of time. I apologize, Pablo Garofalo and Dr. Arribo and Vigo, but we are out of time. We need to continue with the next panel. They're very important aspects what we have discussed today, and we have really enjoyed it. We thank all of you for your participation, and now we give the floor to the next part of the table, Alejandro. Okay, thank you very much, Eduardo. Very interesting panel. Now we're going to start the second part of this session with SAC FAC SOLACI-CACI. We're going to talk about medical treatment in patients with severe coronary disease. And very quickly, we'll give the floor to the first speaker, Dr. Juan Montaner, Chief of the Cardiology Department of the Tucumán Center of Cardiology. He's going to talk about optimal medical treatment.
Thank you. First, I'd like to thank the organizing committee of SOLACI-CACI and the Argentine Federation of Cardiology for this invitation in this joint meeting, SAC FAC. We'll have a look at the optimal medical treatment, where we're at, and what we have ahead of us as regards the chronic coronary syndrome. This syndrome has several clinical presentations, and each clinical presentation has an appropriate treatment for the patient. But basically, an optimal treatment is the one that improves the life quality of the patient and will produce some sign of improvement on the plaque and reduce the capacity, the vulnerability of these plaques, and also reduce mortality. The appropriate treatment in a chronic coronary syndrome is a mix between a revascularization strategy and a medical treatment. Based on this, the treatment is divided into two parts, an anti-ischemic and an ischemic medical treatment. The anti-ischemic medical treatment in the last guidelines, even though it's discussed, the first treatment line is the beta blocker, and if the patient can tolerate the beta blocker, then blockers, classical blockers, depending on the patient characteristics, are the ones that are recommended. If not, a combination of beta blockers and classical blockers. Otherwise, there is a third and four steps with other drugs such as BB, DHP, and so on. So patient stability remains asymptomatic is very important. Beta blockers in this registry with over 30,000 patients have proved to be very good to reduce ischemic events, but there are some issues with mortalities. There has been some reduction in terms of mortality rates. In this study called Clarify, only, as I was saying, patients having infarction, there was a reduction. This was not seen with antagonists, and this was recently published in Circulation, speaks about the importance of angina, chest angina. In these 32,000 patients, most of them could be controlled with the therapies, but those patients that could not be controlled after 6 years or a month, a year, 6 months or a year, had a revascularization, a high revascularization rate. And at the same time, there was a large number of patients that were symptomatic, and if they became symptomatic with the years, there was a high rate of hospitalization due to angina. This clear states how important it is to manage chest pain in these groups of patients with chronic coronary disease. So besides symptoms, as we said, these are our anti-ischemic drugs that have a very low impact, except for beta blockers in some groups with dysfunction of LVD or previous infarction. Otherwise, they're good. And plaque stabilization with statins and anti aggregation therapies is fine. So cardiovascular protection is very important in these kinds of patients. The change, exercising, healthy diet, exercising, as I said, medical therapies to stabilize the plaque, such as statins, which are more increasingly aggressive, hypertension control and diabetes control, and antithrombotic therapy. So this concept, and this was just published, this is the SYNCAC study, how important it is, an aggressive and optimal medical treatment after revascularization. Patients that were well treated with antiplatelet drugs, such as converted enzyme drugs or beta blockers, have a much better prognosis in 10 years compared to patients that do not receive an adequate treatment. So optical medical treatment in patients, we need to be aggressive in patients that have been revascularized. However, as we know, despite this stabilization, plaque stabilization and atherosclerosis, changes of P2Y2, and in some groups of patients, there is a component called residual risk. It could be lipid residual risk, inflammatory, or thrombotic. So based on this, we've seen that in all studies since CAS, we can see an increase in the approach, how aggressive the approach has become in terms of medical treatment. And all of these studies have emphasized medical treatments to prevent ischemic events in the long term. For example, ischemia, the reduction of LDL was 68. This means that the aggressivity component to address the plaque is something we need to consider. And based on new drugs that have also proved to reduce the plaque on an aggressive monotherapy with statin, in the Fourier study, we've seen a reduction of events both in the primary and secondary endpoints. So there is a correlation between the burden of vulnerable plaques with clinical events from the physiopathological point of view. The other standpoint is inflammation management. This is a trial published in Circulation with anti-inflammatories, and they proved a reduction in hospitalizations and percutaneous intervention at 90 days. It's a small group, but they and definitely Cantus as inhibitors of interleukin 1 with 150 milligrams and 300 milligrams, and this was regardless of the cholesterol levels. And this is how a system can be, coronary events can be reduced. Recently, another study with colchicine was published where we can also see significant reduction of events both from the primary and secondary endpoints of approximately 30%. So we can reduce even more LVL, and this can be beneficial. We can reduce inflammatory burden, and this could be regardless of LVL, and this is beneficial. And recently published this other trial, how the thrombotic burden is important and how the hypothesis to create thrombines and the dose of anticoagulants can be beneficial in the groups of patients with chronic coronary syndrome. The greater the risk, the greater the benefit that these patients can have. This was recently published as well, stating that this is a Danish registry that observed that patients that were treated due to infarction or a chronic coronary syndrome, most of them were eligible for new treatments to stabilize the plaque. This is important because we can have a wide view on our patients, and for the future, triglyceride management, lipoprotein A, and the new drugs for diabetic patients. Conclusions. Optimal medical treatment is mandatory in chronic coronary syndromes and is cross-sectional in patients with medical management patients that would undergo coronary intervention. New pharmacological strategies improve the prognosis and in the future we must learn the right combination of drugs for each patient. Thank you. Thank you. Very thorough presentation, and the improvement in the prognosis of patients is partly due to medical treatment improvement, and the second cause is improvement regarding non-invasive diagnosis modalities. Roxana Campisi will now discuss non-invasive diagnostic methods. You're on mute.
Thank you for the invitation. Can you see my presentation? Yes. All right. When it comes to choosing coronary images for stable patients, I always ask myself, well, what do I choose? How do I study him anatomically, functionally, or combining in some selected patients both outlooks? But once again, how do I choose it is something that I'm going to try to develop in my presentation. One way to think about this choice is, without a doubt, the capacity of an X test to predict risks. And we know for a fact that in an anatomic view and in a functional view, we can identify this patient that is now here in this quadrant, white, and in this one in black that has high risk, and that we know that for years we can identify through imaging. But I'm not only interested in knowing whether I can predict risks through a test, but to know of being, and it's linked with Dr. Montaner's presentation, in that decision of choosing a test, then me in the office, I have to choose the therapy. What we do in the clinical practice is to use the European guidelines to choose the test, but by always thinking in patients that have high probability of obstructive CAD, and this patient this is the patient I'm going to dedicate the presentation to. Sometimes we can do no test, which is also valid, but in general we think about multi-cut CTA. Usually the ones that we choose are those. So next, we'll see two clinical cases. This is a patient with a normal echocardiogram and look at this multi-cut CT, the test that we chose is normal, no plaque, so a high negative predictive value, and this patient does not need further tests. However, I'm going to show this case, this 65-year-old man with precordial pain background, several risk factors, including diabetes. We decided to start with an anatomic test, and this is what we get. Mixed plaques with significant stenosis in the right coronary artery, calcium, low-density plaques, mixed plaque with a moderate stenosis in another area, in this case in the anterior wall, and we say, okay, will this have a functional impact? Will these stenosis have functional impact in the plaques? We have diffuse and focal disease. What is the most important thing here? Now we know that angio CT is not talking about the anatomy, but it also, there is a plaque characterization, and this patient has plaques with calcium, low attenuation. So in this case, due to technical availability and the experience of the operator, we ask for SPECT resting and in stress in the irrigation of the right coronary artery, and the stress test is very important. Excellent test, no pain, and the systolic is preserved. The systolic rhythm is preserved. So how would I link this with the anatomy? So moderate ischemia. The ischemia trial tells me that with the follow-up of 3 to 4 years, the conservative branch versus the revascularization branch in patients with moderate severe ischemia preserved. There is no significant difference between the conservative or the invasive approach. So apart from the stress test that is excellent, that patient, we decide to do an optimal medical treatment. So we are now in an honest discussion of this type of patients. So ischemia trial makes me think that all coronary patients are unequal. I don't have to think about revascularization, just on enteric treatment. So there are some considerations. I chose 4 due to times. Ischemia trial compares treatments, not tests. So we don't know which CT is better, stress test, ergometry. We're comparing new optimal medical treatment versus revascularization. Another important thing is to talk to our patients and to tell them, okay, the optimal medical treatment works, and not like years before when we talked about ischemia and we went immediately to the hemodynamic room. We have to tell our patients that medical treatment is important, and of course, patients who were not included in the ischemia trial. So we cannot generalize all coronary stable patients can fit into this study with FEVI, with severe ischemia, with parameters of very high risk. They were probably enrolled in this trial. That's something that we should discuss later. Dr. Muntaner also highlighted the probability to improve their angina in patients, and the ischemia trial shows us, as it is clearly seen here in red, those who were in the invasive branch, they have more probability to have angina in the long run after 2 or 3 months compared to the ones with the optimal medical treatment. So in this consensus of choosing between one therapy or the other one, with preserved systolic rhythm, the fact that we improve the quality of life and angina is not a small issue. It's not a small thing. However, in the ischemia trial, it's not the first study or trial that questions revascularizations versus clinical treatment, medical treatment in stable patients. This starts in Courage in the year 2007. So one can wonder, thinking from 2007 onwards, but perhaps more nowadays, the ischemic amount, if the ischemic amount is more than 10%, is now the magic number for revascularization. Another thing we can think of, maybe we have a more sensitive marker. Do we need a more sensitive marker, ischemia marker? And then we have the coronary reserve. And another thing that Dr. Mutaner asked about is the plaques, not the plaque burden, not the stenosis, which is the biggest cardiovascular predictor. We need to evaluate the plaques in these type of patients to predict the risk. And last but not least, maybe not for everybody, the big question is, which patient do I have to revascularize with stable coronary disease? The last three slides, I'm going to try to answer those questions from the observational studies point of view. The first one is the ischemic amount. So this is a Murphy scheme from Harvard that shows, look at this, these bars on the left. They have ischemic amount more than 10%. However, the yearly mortality is more 8.5% that have combined a reserve of flow under 2. So not with the amount, the ischemic amount at 10 is the same with a coronary reserve preserve of 1 vessel and here 3 vessels. Most recently, Patel showed us here on the left that those patients with ischemia of more than 10%, but with MBFR below 2, will benefit from revascularization rather than with clinical treatment. Whereas those that are reserved, they wouldn't have revascularization, will have no benefit. So maybe more sensitive markers to unmask the risk in patients with stable coronary disease. And then the other thing were the plaques. We showed already the vulnerable plaques, but we all know that infarction, most patients have plaques that are lower than 50%. So what do we do today? If the patient has a daily or weekly angina that is unacceptable, he's going to go to the echo, and we're going to use revascularization technique according to the anatomy. But if the patient has an infrequent or acceptable angina, of course, the first step is to change the lifestyle with medical treatment, optimum medical treatment. If once this patient enters the ischemia trial, well, the revascularization will depend on the patient. Thank you very much. Thank you, Roxana, for your presentation. Excellent as usual. And now we'll ask Dr. Daniel Berrocal, Chief of Hemodynamic and Interventional Cardiology in the Italian hospital. He's going to talk to us about endovascular revascularization.
Thank you, Alejandro. I am really happy to be here with you. You'll know how, it's such an important thing that we are working together, SAC and FAC. The topic is endovascular. I will deal with revascularization in a general way, not to say whether angioplasty is better than surgery, not even in this context. Ischemia trial, I will not go into the history of it because we all know what has been said about ischemia or the CASP trial. So ischemia is a trial that we all respect, is well defined, large number of volume of patients, randomized, so the patient is stable. if the patient is stable, there are no left main lesions. It doesn't matter if the ischemia is severe or moderate. Revascularization is not needed. Why? Because over here we have events in the first year, and events are in the revascularization procedure. So the evolution of the disease can actually, in fact, it does create an overlapping or a crossing. So such as, for example, death due to a cardiovascular disease. So here there's more infection with angioplasty, but here we're saving some events. So the trial was creative, and they state that systematic treatment is not recommended. So we look at meta-analysis, which are important, and they have thousands and thousands of patients, over 19,000 patients. So when we put all of this together, I mean, ischemia in chronic kidney disease, the meta-analysis favors revascularization and ischemia. And then there are many other meta-analyses. There are meta-analyses that I'm not an expert on statistics, but and I don't mean to say that ischemia is wrong, because meta-analyses have their own defects. But then we can say, okay, this in ischemia is such a solid study, but I think that the truth must be somewhere in between. And there's also the evolution factor, because we've had syntax, and we still have it as a reference point. Both angioplasty and surgeries have evolved a lot. For example, when we replace stents, and Macha, I'm sorry, when we use the worst stents in the history of DES, which should have been forbidden, with acute and subacute thrombosis in the first year, when thrombosis at that time was below 1%. But then I need to gather some evidence. But when stents evolved, then you can see the the changes in mortality, let alone a function and revascularization procedures. Now look at surgeries. In more recent studies, 90,000 patients, you can see the huge difference in medical treatment. So from my perspective, and Williams is a serious author, this means that we're putting everything in the same basket, and we're just focused on ischemia. The patients with a lot of angina were excluded, as Roxana said, regardless of the medical treatment. LV disease and other factors such as left main, unprotected left main, defined by CT slice. There's a large population that was excluded, and maybe that population is not discussed on a daily basis. We're discussing about patients that don't have all of these, so probably we don't have to do anything to do these patients. But for a long time now, 2002, we already knew that severity of angina had a lot to do with prognosis, and there were patients that had severe angina, and they had three more possibilities of mortality. And this is a study that was very important, the Courage study, that we can see that death or infarction in patients having over 10% of ventricular mass involvement was tremendously significant. Numbers are probably not that accurate, but and then things begin to add up, for example, you can see in the lower left panel if there's less than 50% of myomotor ischemia, and so or mark ischemia, and then factors begin to 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 add up. Juan discussed this already, so I will not go into detail, but I think it's important as that sometimes we administer a lot of medication, but extended at 10 years. See how how important it is, as Juan explained, the impact of an optimal medical treatment, the difference it makes. And it's not an excluding treatment. This is why other trials were criticized, where the patients that were revascularized, no other treatments were given. So there's anti-platelets and statins played a very important role. So we all know if it's patients with the chronic coronary disease are these two medications that have a significant impact, particularly statins as anti-inflammatories of the vascular walls. And as Juan said, and I'd like to highlight that the effect of revascularization, both via angioplasty or surgery, this is a patient that was not revascularized and that does not have antiplatelet therapy. And the impact it has, not only 10 years, but we can already see it at an early stage. So, to conclude, we are over here with a stable chronic angina, patient that is stable. As Roxana said, the plaque could be vulnerable, the fiber cap could be thin. So, so what is it? What can the future give us? Rosana said this, we need to look for several things. The prospect trial was very interesting because it analyzed the plaque burden, and with the virtual histology analyzed, besides of the culprit vessel, the other vessels that had nothing to do. And when the plaque burden was over 70%, when there were how factors begin to add up, and with the fibrous cap was thin, you see how events multiply, but not related to the initial event, but related to the plaques evaluated that were not responsible for the acute event. So plaques that are not involved in the acute event are probably not significant from the stenosis point of view, but create events during follow-up, and this is very important. What are we going to do for this? Well, to administer statins, we all agree with that. Let's place stents or whatever, but statins. And with surgical approach that can protect, the plaques. This new concept that, which is surgical collateral approach, or the surgical collateralization. So Roxana, together with imaging doctors, they would tell us, okay, this patient has a vulnerable plaque, and then we place a stent, bioabsorbable, which are not working these days, so we can actually improve the conditions. So this is the whole evidence we have. What do we do? Well, if the patient is asymptomatic, there's low risk, I think that nobody can argue that nothing should be done. We shouldn't touch the patient. But what we do if the patient is symptomatic and if it has a high risk, even though this ischemia says a different thing, but we're concerned, then definitely then we will shift to revascularization, angioplasty, or surgery. Thank you. I'd like to thank all of the speakers.
Muchos panelistas.
A lot of panelists, so let's be brief. Carlos Tajer.
Alejandro, excellent presentation. Since there are so many people, I'm going to ask just one question. Within the new treatment, have you used the oral anticoagulant for chronic coronary disease? I'm sorry, Carlos, I couldn't. Are you using rivaroxaban in chronic coronary patients in a specific context? Yes, I'm using it in patients have multiple stents, they have undergone surgery, and even patients that have already been discarded from invasive procedures and they still have angina, and also if they have other areas that are compromised, like the periphery, the vascular periphery. Of course, it's not a treatment that fits everybody. We have to select, as all medication, even with the new cipolipimients, but we are learning to use them, and we have good results. And honestly, the bleeding rate is pretty low. Pablo Perez, would you like to continue with one question? You're on mute, Pablo. We can't hear you.
Oh, tenés el volumen bajo, quizá.
Maybe the volume is too low. We can't hear you. We can't hear your question. Now? Yes, now we can hear you. So I'd like to thank you for the invitation. Thanks to the speaker for the wonderful presentations. Several things. This is a very controversial topic for many, many years, but Roxana and Daniel, I wanted to ask you if you think that perhaps to differentiate those patients that benefit the most, what is the role of the flow reserve, invasive and non-invasive? They're doing it, the studies of flow reserves are being non-invasive, despite the fact that you revascularize those who have more symptoms and more risks. I'll start. Good question. Look, what I showed today are the first trials where they're showing that perhaps the most sensitive indicators as the coronaries are, I think it transcends the technique. I talked about CT, but let's talk about the concept. With their flow reserve, you're measuring the impact of what's happening in the epicardium, in the epicardial lesions, in the microvascular system. It's a combination of everything, but microvascular and the impact in the diffuse disease, because patients are not pure. It's not focally. It's not purely focal. It's a mix. But the first nice outcomes, when we think about the physiopathology more than the functional, not all patients with moderate ischemia or severe ischemia will have the same behavior. We'll see that in our daily practice. So to be able to add some information like the coronary reserve, and I'm talking only about people with have obstructive coronary disease and not other populations, maybe we can understand in the future that with studies that we still don't have, and that would have a practical clinical application in patients with obstructive coronary disease. Daniel, would you like to add something? Yeah, something very short. Pablo, this is the $1 million question, as Roxana said. We have to write all the medicine again. Now it's clear that we have to focus on the revascularization. So we clearly have to focus on that, whether we have to revascularize only the number of arteries, which ones we have to revascularize. Maybe in the future we will have to do image integration, which is already happening. We could put multi-lays, and the behavior of the flow is going to help us to aim more accurately. But we have to wait until we write everything again. Very clear. Edith Moreira, would you like to ask a small, quick question? I think it's a very interesting topic, functional anatomic tests to choose. And in those conferences where you try to prove that one test is better than the other, I think it makes no sense. I think each patient fits in a different test according to the features, the characteristics of the test. In particular, you showed this gamma and with the magnetic MRI with perfusion, it can be used much more now. What is the role that camera gamma can have when today the price in Cordoba of a perfusion MRI is cheaper than camera gamma, and it gives you much more information, anatomic information, infarction regions and fibrosis. Its capacity and specificity, instead of being 80-75%, it goes all the way up to 95%. It's easier to do. It's 45 minutes instead of having the patient to come back. And apart from that, it doesn't radiate in the patient. So I think, what role will the MRI have? Do you think camera gamma will disappear? What do you think? I'd say that the test choice is related not only to the pre-test, but also to the availability of the expertise. If in your center, MRI with perfusion is excellent quality, is cheaper, and is available, great. We're not going to compete, as you say, in which one which one is better, what radiates, what doesn't, or maybe it's much easier than perfusion, then no problem. I think if something is going to disappear or not is futurology. It's a little complex. But if in your center you have an MRI service that is available and that works correctly, then great. There is no guideline that tells you this test is better than other. It's the right test for the right patient. Yeah, but we should see the cost too. Claudio Viga, what would you like to say? You're on mute, Claudio. You can't hear you. Can you hear me? Yes. Congratulations to the three speakers. Roxana, the European Society in Chronic Coronary Disease, they have a mortality more than 3% in ischemia, a yearly mortality rate of 1%. Even though high-risk patients were excluded, using the functional test to select patients of high risk to see if there were differences with the strategies between the conservative and invasive, apart from the fact that there were no differences, the population was not the one with high risk. And you started talking about it. In the imaging specialist, is there a reconsideration of the cut values to define high-risk patients? Yes, there is a point in which we insist a lot, and more often than not, the functional test studies, we eliminate the imaging. For me, it's much more important. The ischemia trial, we know that we can have a stress test, less 5 megs per year, and they have main. So it's a balanced ischemia, for example. So I think the impact of the ischemic amount burden is going to be what happens in the image plus what happens in the test. And the same thing happens with stress test, any functional test. It's key with what happens with the rush of the patient. Sometimes these studies are only for the result of that image, whatever it is, but I never see the link between the image and the result of the rush. Sandra, would you like another comment really quickly? Sure, thank you. I wanted to ask Dr. Berrocal, in hemodynamics, when they study a chronic coronary patient, when do you call the surgeon? Only when you see that technically you're not going to be able to do anything? Or do you consider other clinical aspects like the bad ventricular activity? Sandra, we always call the clinicians because they will kill us if we don't call them. No. Unless, of course, it's a one vessel or a syntax that is very, very low, single lesion with a culprit lesion. If there are multiple vessels, syntax, a high syntax, we know that the patient is going to go to surgery and it's not going to have an angioplasty. But all kidding aside, we try discipline of sharing with the clinicians because we cannot prevent. They see everything with the surgical eye, and we sit with the angioplasty eye. And clinicians, they always contribute something to me. They give me that outlook to be able to weigh everything, to understand the functional tests, the risk factors. So I'm not playing a good cop. I'm just telling you what I think. We have to respect the patient, and we have to make sure that someone breaks the tie. Danny, do you want to say something? Alejandro, good afternoon, everybody. Thank you for the invitation. Excellent presentations. I'd like to just say that there are things that come to add. I think that we have to consider that we're clearly in a change of paradigms in the ischemic disease. Now we're focusing on the chronic part, but to understand that a patient may have no epicardial obstruction or an angiographic obstruction and is not the responsible factor for the ischemia. Roxana said something like that, but I think we have to highlight that. This possibility of, in the change of paradigms, the apical imaging, which has a good prognosis, but then we have the diffuse illness in the epicardium and the microcirculation. The integration of all that component, of all that burden, perhaps through the studies, we are going to have an approach to having a much more sustainable behavior. And the last thing I want to highlight is that a long time ago, we talked about chronic stable disease, and I think that word, if we're talking about a chronic disease, risk for us in the medical team, as Daniel Berrocal says, in between trying to find a balance, the interventionists and the physician, each patient, we have to recognize the absolute risk, and from then on to opt for the best option. And what's last thing? Sometimes we get confused about the ischemic burden, and we put it as ischemic risk. And in fact, that has not changed significantly, because when we talk about what Roxana said, if I have an ischemic threshold that is very low, a patient that has a heart pump, dilation of the right ventricle, I don't care about the amount of ischemia that he can present. The prognosis implication is that, well, we will all see the anatomy and revascularize with the best strategy that we decide as a team. Thanks, Danny. We have to finish, unfortunately, but we have a lot of questions that are still in the air. Excellent presentations, and I want to thank everybody for having participating. We are giving back the floor to the SOLACI-CACI staff, so thank you.
Buenas tardes a todos.
My name is Aníbal Damonte, and I'll be moderating this evening symposium. First of all, I'd like to thank MEDTRONIC that is supporting SOLACI and CACI year-round, and that is sponsoring this symposium. We'll be addressing two important issues to my view, and I hope you can enjoy them. Will be as interactive as possible. So the agenda of the symposium, first of all, we're going to look at a controversial issue, which is the best strategy to address a coronary bifurcation. First, presentation, case presentation, discussion, and finally, we'll have an update on, for this symposium, the speakers with us, Ricardo Costa is the president of the Brazilian Society of Hemodynamics and Interventional Cardiology. Dr. Uribe, who is an interventionist cardiologist from Medellin. Dr. Taiko from Sao Paulo, Brazil. And for the discussion with us today, Dr. Daniela Coria from Santillana Hospital, and Martín Valdebenito from Chile. Let's enjoy this symposium and have a fruitful discussion. Let's begin with the first part. So first, I'll ask Dr. Carlos Uribe to discuss the DK crush is the technique of choice for coronary bifurcations. Thank you. It is an honor to be here with you. This is a very interesting issue, and I think it'll generate a lot of discussion. And this is about the DK crush, which is the strategy if stents are planned from the start. And I'd like to first ask the panelists a question. What is the criteria that you have to decide whether to go a single or two-stent strategy? The Medina classification, which is your criteria? And these are the criteria we've been accustomed to: true bifurcation, SB lesion length less or more than 5 or 10, high risk of losing the SB angle greater than 45 and smaller than 70 degrees. What do you think? Daniela, you may want to start. In our daily practice, we mostly also look at where that is located, the characteristics of the SB, whether it's the left main or an LDA or diagonal artery, the extension of the territory it's irrigating, and also the characteristics that are mentioned here, the access, how difficult is it to access the angle, the angulation, and the lesion greater than 10 millimeters. Any other comment? To support what was said, we do something which is quite similar. First, the location, and for that we use the Medina score classification, and we also consider the side branch. The side branch is an important thing for the patient. The length of the lesion, the stenosis if it's over 70%, and the axis, the re-axis. And so based on this, we consider the two stent. We may start with the provisional stent, but if there are some complexity issues, then we'll see. But the side branch is really the most important. In this lesion, for example, that I'm showing you, which is Medina 111, it's a true bifurcation. Would you begin with a two-stent strategy, or would you rather begin with a provisional strategy, stent? Personally, a provisional strategy, stent strategy. Any other opinion? A provisional stent strategy, because of the localization of the lesion, despite its classification Medina 111. The provisional stent is a philosophy, it's a strategy. If the provisional stent fails, then another stent can be used. So provisional, and then I will just check on the result. This is what we have been traditionally, what we have learned, basically, and this is what we see in textbooks. Medina 111 is defined as a true bifurcation, and the strategy should be two-stent. But this concept has been changing, and I'll try to prove why this has changed with the evidence. And so, as I said, this concept has been changing because Medina's classification, even though it's very appropriate for classification, treatment-wise is not the best. This classification does not consider the lesion characteristics, which is very important in this case. For example, length, the calcification length, the angulation. The classification is good because it's easy to name, to remember, to standardize in studies. And definitely the concept of true bifurcation shouldn't be used any longer. What is being used now, if the lesion is simple or the bifurcation is simple or complex, this is based on the following studies I'll be showing you, which is changing all of this overview. to actually know when to start with the two-stent strategy or one stent, I mean the provisional stent strategy. So all of the criteria, I mean the most important one is the length. And traditionally, when we read the EBC consensus, and when we followed these consensus, we saw that they stated that 5 millimeters was the magical number to make the right decision. I mean, to use a two-stent strategy or a provisional stent strategy. However, this number has changed over time, and this is based on this study that began to shift things by Dr. Chen in 2014. This is the definition study with criteria to define when we have, I mean, it gives us a score. So the interesting thing about definition study is that it shows that the length of over 10 millimeters is definitely the most important marker. As you can see, HR is the highest, 66 points, and then 80. This is in terms of sensitivity. As you know, this was also checked by this other study by Dr. Chen, the DK crush, that showed that the length of 10 millimeters is probably the most important marker, not 5, as we had learned from the EBC. And also the true bifurcation, which is different as in the Medina 111 classification. This is to show you, this is Professor Chen's study 2017, that DK crush shows the length 10 millimeters, which favors, as you can see, the two-stent strategy. This was also supported by or checked by Marcus and Marino's study based on the PB registry, and that stated that the 10 millimeter length is the most important marker to define the involvement of the side branch and breast stenosis, and so 10 millimeters is the one that adapted best. However, it is important to know that bifurcation is not left main, and so I mean the difference is between left main and non-left main bifurcations are not the same. And this has to do with the patient safety. And as you can see in this flow chart, this is the risk of losing the side branch when a stent is implanted in the main branch. This is important to be considered. It's not so much, it is the 10 millimeters, but probably the most important criteria is the risk of losing the branch, because if the branch is lost, I mean, the main branch, then there's a risk of catastrophe, and then losing a branch could actually lead to catastrophic consequences when performing the procedure. So this is an important criteria when deciding on a two-stent strategy, as opposed to non-left main bifurcations. This if we believe that the SB, I mean, this is not as important, because if it goes to the SB, then there's more time to wait until all of the strategies are put together. And in addition to the previous one, there's strategies that that actually can help us. This is Francesco Bussora's study and Emmanuel Pan that showed that pre-kissing with small balloons, I mean smaller than the marker diameter or reference diameter, so placing the stent in the MB. So this is very important. That is, if you see that there's no risk that it goes to the SP to prepare it and do what they call a pre-kissing is an alternative. So as a result, we could say that you can have Medina 111 true bifurcations, or have a true bifurcation, and that being a true stenosis or a complex stenosis. So probably we should focus on a simple or complex bifurcations, because they are both 111. But on the right, you could see that you could actually use provisional stent strategy. And here on the right, since this is over 10 millimeters, a 2-stent strategy is better. Conclusions. In this first part, using 2-stent strategy up front is the indication, and this is mainly based on the length. True bifurcation, this term should not be used, rather simple and complex bifurcation, because it's more specific than the ostium involvement. And I will try to persuade you. I don't know if you're going to have a discussion here, or shall I go on? The idea is in this, the criteria that you have set. The idea is the initial strategy and systematic strategy of a 2-stent strategy. That is very clear. So this would be the time to listen to the opinion of the panelists. For example, Ricardo. And so we can have probably a conclusion with the panel later on. Perfect.
After expressing his opinion, Carlos telling about using 2 stents as the approach, and in which cases, I'd like for Ricardo to present all the arguments of a provisional stent. Ricardo, whenever you're ready. You're on mute. Can you hear me? Yes, we clearly hear you. First of all, thank you very much for the opportunity of being here with my friends, participating in this session with the interesting controversies. I have here a great friend, Dr. Festaisco. I learned to do bifurcations with Rodolfo, so if there is any problems, talk to him. Can you hear me? Yes, we can hear you. Loud and clear. After listening to Carlos' explanation, now we're gonna see a different perspective of the techniques that we should be using for treating bifurcation. you see my screen? Yes, we can see your screen, Ricardo. Sorry that you saw that T-shirt. Sometimes the controversies, we have to, we have to talk to friends and we have to see, okay, Carlos and I don't have a problem, but we do have different teams. We love different yellow teams, as we can see here. We all know that what was happened with the bifurcation and how complex it is what happens in the side branch. And what type of compromise are we talking about? Whether it's a dissection, an impaired flow, we have an important residual stenosis, or a late stenosis. If we take a look at this, the evolution of the side branch stenosis, the implantation of the stent in the SB gives us indexes that are prohibited. And with the DES, the evolution of the techniques, we see that the best results are given when we don't have an implantation of a stent in the side branch. Here, we have studies with resolute stents that show after 4 years, after 3 years, sorry, very interesting results, very good results with a primary strategy, simple strategies, with a stent implantation in 30% of the cases. This is the safety of treating ourselves in the centers here, the bifurcations with this. We should not confuse single stenting with provisional stenting. Single stenting means that it's just one stent. It's not a strategy, it's a result, it's an outcome. Here, we have a bifurcation, a true bifurcation, but not non-complex, that could work with a single stent. The great question is when to treat the side branch. What criteria should we use? And here it's pretty clear that we don't have a consensus. The angiographic context, whether there is reduced flow, occlusion risk, stenosis more than 75, 50, all those criteria have been already used in clinical trials. Any dissection, type A, B, C, the use of invasive image such as ultrasound, or in an area a bit larger than 2.4 square millimeters. The physiology, FFR more than 0.80. There are many criteria that are being used. The provisional technique considers the implantation of a stent on the side branch if necessary. And here we have a typical example. This would require a provisional technique, a stent in the left main. And here, after the implantation, a provisional technique stent. Technically, which is the strategy that if you have an occlusion of the side branch, you can use a provisional. It's not it could be a culotte. But if you don't use a culotte, you can use a provisional stent or technique. The meta-analysis show that it was not proven before the crash, no benefit in favors of the more complex strategies. And the same thing happened with the myocardial infarction, more simplified provisional technique. Some trials like Nordic 1, we need to see the percentage of stenosis in the side branch is lower than 50%. So in these type of cases, there is no benefit in favor of a complex strategy. So we should use the technique to benefit, for instance, shorter periods of time, better contrast, and less use of material. We don't know the type of complexity that we have in BBC 1. This is the BBC 1 trial with actual bifurcations. and the results are more favorable than simple techniques. There are 2 more studies with bifurcations that are called true bifurcations. It favors the simple strategy. This is another trial, the Cactus trial, with stenosis that are more severe. We find that there is no difference between the 2 groups, but 30% of the cases in the side branch use the strategy in the more simple one. In the actual cases, 36% of the cases may receive 2-stent technique. Clearly, the strategy, provisional strategy, does not apply to all cases. And here we have an example of an experience, a great lateral side branch, a diffuse main, and we have a wire. We couldn't do it with the wire, so the outcome was not favorable. When we have great anatomic variability, it's clear that complexity is similar when we think of a strategy to treat or to approach the bifurcation technique. Carlos said Medina classification, when we define the true bifurcation lesions, they don't have ways to validate completely the real complexity of the bifurcation lesion. Here we have an example, same location, proximal side branch, and we can see the extension of the lesion and the severity. There are some predictors that we need to consider: the degree of stenosis, the large plaque burden and the eccentric distribution, the significant calcification and the tortuosity, the angle, more angle, lower chances to have occlusion, but more difficult to access. When the angle is smaller, then there is more chances of occlusion, the impaired flow at baseline, and also the vessel size corresponding to myocardial territory. Some studies, some trials confirmed this information, such as COBIS-2 registry, the presence of stenosis in the left main, and the extension of occlusion. The definition criteria, as it was already discussed here for bifurcation in the left main, criteria that are pretty extreme: more than 70, lower than 45, calcification, significant calcification, and the type of situations in which the strategy, the provisional strategy, could be not that favorable. So what is the best provisional technique that we have to consider? And the last consensus and these important trials show us that there is an important aspect that we need to consider: the need that we have to have a rewired attempt without pot, to have a complete position. Here it's difficult to move forward, to advance with the wire. Here, another example. We had to switch technique for the side branch rewiring attempt because it's difficult to access. But if we do a pot in the right way, with the position of the distal mark right where the proper balloon should be placed, it's going to be very easy with the technique to access with the wire and to re-access the lateral, the side branch with an opened distal cell after pot. Step by step of this strategy, provisional strategy, includes SB balloon dilation, a kissing balloon, something interesting to do with a kissing balloon. And if we want to continue with a crossover strategy, we can facilitate the position within the provisional strategy, we need to optimize the expansion, kissing balloon, and this is the final result. This is the provisional strategy technique that we recommend. Same situation in more complex situations, you can offer great results. Definition 2 results showed more favorable technique results with this technique, but there are some questions whether the provisional technique was applied in the best way possible. Two aspects that we need to take into account: the predilation of the side branch. We have randomized trials that show that if we predilate the true bifurcations, we have more patency at the end of the procedure. We have this trial that tried to approach the true bifurcations, the extension of the lesion more than 5 millimeters in the side branch, the complexity, and we compare this provisional technique, double stenting, guided by ultrasound, and the crossover rate was almost 20%, very similar to the randomized trials. And that makes us think that when we implant 2 stents, we have different results in the late follow-up. The results were not different in the side branch with after 9 months, but there is a trend to have more stenosis in the late follow-up. And some predictors of a side branch restenosis, when we have a high complexity, the double stenting could be maybe the solution in this situation. So how do we evaluate a real true bifurcation lesion? Well, I would pay attention to this. We have pseudostenosis at the side branch ostium location, negative remodeling, and these studies show that as we approach the ostium in the bifurcation, it gets worse. So studies with FFR show that in a severe lesion, after treating the left main, there is a higher stenosis, 79% after, more than 35%, more than 85%. And to end, the EBC main trial, it was published and presented. We compare Resolute Onyx stents with simple stents, the single stent strategy versus dual stent strategy, 2-stent strategy, with a capacity of overdilation that is pretty interesting, 4.5 millimeters and 5.0 millimeters. The technique was the step-by-step layer technique. We already showed pod mandatory, and we also saw that with the provisional strategy minus stents, it means more duration. And here we have the procedural flow, 22%. It was necessary, very similar to the previous studies, previous trials. And the primary endpoint, it shows advantages for the more complex strategies in situations such as the left, the TLR, and the complexity here was included. And to end, the strongest evidence for the provisional strategy technique, when we have a small side branch, less than 2.5, a small myocardial territory at risk, a short ostial lesion, a stenosis less than 70%, an angulation less than 70 degrees, non-calcified anatomy, absence of significant proximal tortuosity, and easy to re-access. So the considerations, the final considerations, the provisional stenting is safe and supported by long-term data across different patient and lesion subsets. And it is widely accepted in the world, around the world. However, more extreme complexity is rare to see and should be avoided by this technique. Thus, it should be the default strategy whenever possible. Thank you for your attention.
Thank you, Ricardo. Thank you, Carlos. Before moving on to the two last minutes, very important to, based on these two standpoints that actually agreed a lot, I would like to hear from the panel Dr. Daniela Martín, Rodolfo Taico, Juan Gaspar. So from your point of view, when we use the two-stent strategy, so the two-stent strategy, which technique or techniques would you choose in the daily practice? And the second question is, when you use a provisional stent strategy, what technique would you use when you actually, when you have the need for a second stent? Rodolfo, Martín. When I go for a two-stent strategy, my choice is always DK crush. I feel comfortable. There are randomized trials supporting it. I feel that there's very little metal in the DK crush. The results have been very categoric, saying that DK crush is better than culotte. I use the culotte technique as a bailout technique. So generally, DK crush as a technique with a small protrusion of metal to the side branch and the main branch. So I use it. My default technique is the provisional stent strategy in complex lesions defined by definition. I usually go for the two-stent strategy, and then the technique is take a crush. And when the provisional stent doesn't work, then I use take a crush, reverse TK crush, but then it's a lot of metal is left in and if a mini culotte is possible, then it's kind of shared. It depends on the anatomical characteristics. So tap for the provisional stent strategy. Doctor, do you agree with this strategy, or do you have another strategy in your daily practice? I agree with Martin. I believe that we always, consider the benefit for the patient, and with this two-stent strategy is reserved for the distal main left when there is a myocardial involvement, and also as a first choice or most times is the provisional stent strategy that can actually address most of the bifurcations and the distal branch. And as Martin said at the beginning, and Dr. Costa, it's rather a philosophy. It's a philosophy rather than a technique. So and probably concluding with a DK crush, I would leave it for specific cases. Sometimes we don't have IVUS available. So these are complex techniques that require imaging modalities for their proper optimization. And they have these stent layers, even though it's a mini crush, where we need to implant two stents to be able to resolve that bifurcation. Rodolfo is here, and I would like to listen to his opinion in terms of his strategy. It is a pleasure. My strategy is my two-stent strategy. When there's a significant side branch, just 2 millimeters or 3 millimeters from the ostium, it must be treated first, the side branch, and I use the crush technique. Mini crush, nano crush, very, very small protrusion. So you don't need to recross the wire because you do the first kissing and then the main stent. And in the provisional stent strategy, SB is the most important. 30, 40, 50% is okay. But we have to be careful so as not to worsen. It has to be perfect. So low pressure balloon to open the stent because it's a very important branch.
Recruzar e fazer o balão com baixa pressão, relação 0,9, no máximo 1:1 com baixa pressão para não haver dissecção. Se houver dissecção, a técnica mais fácil é o TAP, mas dependendo da angulação, se for 45 graus, se for 90, ótimo, 70, ok, mas se for muito fechado, às vezes não vai conseguir fazer o TAP, vai ficar muito protruído para o ramo principal. Aí talvez tenha que puxar mais para trás e fazer um culote, recruzando o mais distal possível para deixar menos metal na carina. É isso. Obrigado.
Muchas gracias por estos comentarios.
Thank you for these comments and contributions. I believe that this sets the need. These strategies are not the same in Europe, where they probably, as Ricardo showed, in the IBC main, with a collode in most of the cases where they need to perform the crossover. The strategies in China will be DK crush, and we need to identify in Latin America. That's why I would like to, before I give the floor to Carlos and Ricardo, so as to summarize their presentations. Ricardo and Carlos are part of the executive LATAM BIF association, and that is partnered with SOLACI, and they're developing registries. So everyone who is in Latin America, I urge you to participate, so we will have our own bifurcation management. Before moving on to the next talk, Carlos, Ricardo, could you please summarize?
Ya me oyen bien, ¿cierto? ¿Me oyen
sí,
bien?
Carlos. Perfecto.
Yo tenía una presentación montada.
Toda la evidencia de esto, pero creo que no hay tiempo, entonces voy a tratar de hacerles un resumen de por qué DK Crush, y yo creo...
Try to summarize why DK Crush and the two strategies. It's not to actually, say which one is the best. We would rather, supplement them. If so it would all depend on the patient, probably a provisional stent, and then try to if Collard. So I would have liked, I was quite disappointed by the IBC main. I don't know what Dr. Costa thinks about it, but I was quite disappointed because I expected to have more patients with DK crush, but DK crush use was really, really small percentage, and I would have liked to see, and this is my concern as an interventionist, what to do with complex lesion, provisional, and then a tap or collode compare with a DK crush. I would have liked to that we were able to define which of these two strategies would have been the better, I mean, in patients with complex bifurcations. So the final remarks is that we definitely need to use to really fight for it when it's necessary, and then when, you know, it would all depend on the situation. So we'll use the right tool for the right thing. So DK crush is not good for simple lesions. So I think that each tool should be, for each right purpose or each right scenario. Thank you for your summary, Carlos. I'll give the floor to Ricardo. With slides or without slides, also summarizes the strategies of provisional stent strategy. I think you have to remove your presentation. I'd like to show a case very quickly that shows the complexity and the strategy step by step. As regards EBC, the main difference, I don't think they're different. As we discussed with Dr. Chen this morning, I think that the degree of complexity is different, that in the real world, the use, two-stent strategy has to do with complexity, particularly. This case is a STEMI that we saw some time ago, trifurcation. Over here, we can see the patient had a cardiogenic shock. There is thrombus here. The intermediate branch is not that important, so we cross the wire in the three branches. There is the patient stabilized. Then we implanted a stent, a provisional stent in the LAD. And then there was an ostium involvement of the two branches. First, we wanted to optimize the main vessel and the distal vessel with a larger balloon, larger than the one used in the LAD. And this is the final result in the LAD. The circumflex involvement and the intermediate branch ostium involvement. You see that there's an improvement. We're using 6 French here. And then we recrossed, and we did the first, the kissing balloon. and a second kissing in the LED, and this is the final result, favorable with a provisional strategy, single stent in a very complex anatomy, but we don't have all the criteria set by definition, such as the lesion extension and so on. Anyway, a complex case, and over here you can see a preserved ventricular function. Aníbal, just to summarize, this strategy can be very well used in a high complexity scenario in a very satisfactory, with satisfactory results. Thank you, Ricardo. I think the case was a conclusion, standing up for single stent. Thank you for these contributions. We could talk about this topic for 2 days. I'm sure Latambi will organize in the future.
En todo caso, luego de la presentación de
the presentation, but I would like to stick to the times, so we can leave it for the end. Let's move on to the next topic, which is very challenging and controversial because many years ago, everybody felt very enthusiastic, but then there were some data and people, lost enthusiasm. How are we doing in terms of how can we identify the patients that can actually benefit from this treatment? Rodolfo, welcome back. We're eager to listen to you.
Uma vez, estão vendo minha tela?
Muy bien.
Ok. Agradeço inicialmente a todo o time da MEDTRONIC.
We apologize, the speaker is speaking Portuguese. There is no interpretation into English, from Portuguese into English.
Estão com esse desafio, né, de demonstrar que essa terapia ela é válida, né? Quando bem feita, quando o paciente bem selecionado, ela tem bons resultados. Muito bem. A redução da pressão arterial por meio da denervação renal tem sido demonstrado em vários estudos randomizados, controlados com procedimentos simulados, como exemplos o Spiral of Med piloto, Spiral of Med pivotal, o Spiral on Med e também o Radiance Solo, que usa, ao invés da radiofrequência, ondas de ultrassom para promover a denervação renal. Até 2014, quando foi, todos nós sabemos, publicado o HTN3, Simplice HTN3, a evidência era pequena, né? Poucos estudos e registros não randomizados, poucos estudos e registros controlados, até que veio um registro, né, o Simplice, um estudo clínico randomizado com placebo, com procedimento simulado, que foi negativo no desfecho de eficiência, de eficácia. O desfecho de segurança foi alcançado, mas de eficiência não, e por muito pouco. Lembrando, senhores, que a meta objetiva era reduzir 2 milímetros de mercúrio na mapa e atingiu 1,96. Então, foi muito próximo. E hoje eu vejo isso até do lado positivo. Tem que tentar ver o lado positivo desse resultado negativo e muito mais se conhece, né, sobre denervação renal, sobre a anatomia das artérias renais, então ganhamos muito nesse quesito. E hoje os resultados são diferentes, principalmente porque os pacientes são melhor selecionados e o procedimento é melhor realizado. Há várias críticas em relação ao Simplice HTN3, mas principalmente essas duas, né? A seleção de pacientes não foi adequada e o procedimento não foi bem feito. Não foi feita a ablação nos 4 quadrantes de ambos nas artérias renais, e foram feitos poucos pontos de ablação. Então, aprendemos a fazer, hoje fazemos diferentemente do que foi feito na HTN3, que sabíamos que as artérias, temos que fazer ablação também nos ramos secundários, desde que eles tenham um calibre adequado, porque os nervos renais estão mais próximos da luz do vaso, nesses segmentos mais distais, e mais suscetíveis à ação na radiofrequência. Por outro lado, a seleção de paciente ainda é indicada para pacientes, né, hipertensão resistente, mas será que isso é suficiente? Não. Os refratários, tomando 5 ou mais classes de medicamentos, também não, porque alguns pacientes, mesmo refratários à terapia antihipertensiva clássica, eles não são bons respondedores ao procedimento de denervação renal. Portanto, devido a essa variabilidade na resposta à denervação renal, um preditor prático, não invasivo e pré-procedimento se faz necessário para tentar identificar aqueles candidatos ótimos para a terapia de denervação renal. Sabemos que o sistema renina-angiotensina-aldosterona exerce um papel fundamental na regulação da pressão arterial e também é alvo de vários medicamentos antihipertensivos. Lembrando aos senhores que os rins, eles são fontes de estímulos simpáticos que atingem o cérebro pelas vias aferentes, de núcleos hipotalâmicos atingem os diversos órgãos, causando vasoconstrição, aumento da frequência e contratilidade cardíacas, redução do fluxo renal, redução do ritmo de filtração glomerular, aumento da renina e retenção de sódio e água. A renina, ela é mensurável e, em certos modelos animais, ela se reduz significativamente após a denervação renal, assim como a norepinefrina tecidual. Vemos aqui, nesse trabalho pré-clínico, nesse estudo pré-clínico, a redução significativa dos níveis de norepinefrina renal, principalmente quando a ablação é feita no ramo principal e nos ramos secundários, com redução de 92% da norepinefrina, representado aqui nesse gráfico pela terceira coluna, redução mais significativa da norepinefrina. Aqui a quarta coluna é quando foi feita 2 ciclos de ablação na artéria principal, que não reduziu mais a norepinefrina. Então, hoje o que fazemos é a aplicação de radiofrequência no ramo principal e nos ramos secundários, aquém do parâmetro renal, e desde que eles tenham 3 ou mais milímetros de diâmetro. Porém, os efeitos da denervação renal no sistema renina-angiotensina-aldosterona humano, em particular a atividade da renina plasmática, ela é enganosa, porque os pacientes estão em uso de medicamentos que alteram os níveis de renina e de aldosterona e confundem os resultados. Primeira questão, então, como é possível avaliar essas mudanças da atividade da renina plasmática e aldosterona após a denervação renal? Isso é possível? Teria que tirar todos os medicamentos, né? Dosar, então, a aldosterona e a renina sem medicamentos. Isso é feito também já é feito de rotina para descartar a hipertensão secundária. Então, são exames que são feitos de rotina para se indicar o procedimento, né? Mas o paciente teria que não estar usando medicamentos que interfiram nessa mensuração. E nós temos, lembrando, senhores, o spiral of med, ou seja, pacientes sem medicamentos ou usando poucos medicamentos, 1, 2, 3, que pudessem retirar esses medicamentos, que mantivessem a pressão entre 150 e 180 milímetros de mercúrio, foram submetidos, incluídos no estudo, e submetidos ao procedimento de denervação ou ao grupo procedimento simulado. Segunda questão, a atividade de renina plasmática basal prediz a resposta à denervação renal? Para responder essa pergunta, eu trago, senhores, essa publicação recente, do dia 15 de junho agora, né, do Félix Mafu, um grande entusiasta e conhecedor profundo do tema. Foram 331 pacientes do Spiral of Med, né? Vejo, 166 para o grupo de denervação Vejam, senhores, que 40 pacientes foram excluídos, quase um quarto, né? Quase 25%, porque foram detectados medicamentos antihipertensivos na inicial ou aos 3 meses. Mesmo falando que não podia tomar medicamento, os pacientes tomam. E, às vezes, quando é para tomar, não tomam. Isso também foi um fator bem confundidor no HTN3. Até 40% dos pacientes tiveram mudança na prescrição durante o segmento. Isso também pode ter confundido os resultados. Aqui divididos em 2 grupos, aqueles com atividade renoplasmática abaixo de 0,65 e aqueles maior ou igual a 0,65. A pressão mensurada em consultório 2 semanas e aos 3 meses mapa e pressão de consultório. Aqueles pacientes com atividade renoplasmática acima de 0,65 nanogramas por mililitro por hora eram mais jovens, tinham frequência cardíaca mais elevada, isso também é fácil de entender, se eles estão sem uso de medicamento, não usam beta-bloqueador, têm atividade simpática elevada, frequência cardíaca aumentada. Por outro lado, os níveis tensionais, é importante salientar aqui, que foram semelhantes, né, entre os 2 grupos. Isso também é bastante importante, porque sabemos que aqueles pacientes com níveis tensionais mais elevados respondem melhor ao procedimento de denervação renal. As mudanças da pressão da mapa em 24 horas nos pacientes com atividade renina plasmática acima de 0,65, a redução foi significativa, o que não aconteceu com aqueles pacientes com atividade renina plasmática menor que 0,65. Tanto a pressão sistólica, quanto aqui à direita, a pressão diastólica. A pressão diastólica em pacientes com atividade renina plasmática menor que 0,65, sem significância, aqueles com atividade renina plasmática mais elevada, redução significativa. Em relação aos quartis, analisamos os quartis, 4 quartis, né? Aqui o terceiro e quarto que responderam melhor, ou seja, aqueles com atividade renina plasmática maior que 0,67, tanto para mapa quanto para pressão de consultório sistólica, né? Os quartis com níveis abaixo de 0,67 não responderam ao procedimento de denervação renal. Vejam que na coluna de baixo são os controles, né? Independente se é controle, não fez procedimento de denervação. Então, em azul, a pressão basal, em vermelho, 3 meses de segmento, sem alteração, tanto para níveis de renina baixos, com níveis de renina mais elevados, e já nos procedimentos aqui acima de denervação renal, aqueles com renina mais baixa, sem resposta adequada, e aqui, aos 3 meses de segmento, a linha vermelha, mostrando uma redução significativa da pressão em todas as horas, praticamente, aqueles pacientes com atividade renina plasmática acima de 0,65. Assim como a renina, atividade renina plasmática reduziu também os níveis de aldosterona, significativamente naqueles pacientes submetidos à denervação renal. E essas mudanças foram observadas já com duas semanas de segmento. Vejam aqui aos senhores, com 2 semanas de segmento. Renina baixa, sem significância. Renina mais elevada, acima de 0,65, redução significativa da pressão sistólica em consultório, já às 2 semanas, que manteve o resultado aos 3 meses de segmento. A mesma coisa em relação à pressão diastólica, aqui no gráfico abaixo. Com 2 semanas, já uma redução significativa dos níveis tensionais, mantidos aos 3 meses de segmento. Essa observação precoce da redução em 2 semanas não me trouxe surpresa quando eu li esse artigo, porque no cenário de denervação renal para hipertensão, a gente já vivencia isso. Os pacientes, após o procedimento, devem ir para a unidade de terapia intensiva, ficar sob observação restrita, porque a pressão, no mesmo dia, já é uma queda acentuada. Esses pacientes não podem ficar com pressão muito baixa, porque estão acostumados com o regime pressórico mais elevado. 150, 180, 200, às vezes 220. Se você abaixa para 100 milímetros de mercúrio, vai fazer hipoperfusão renal, vai fazer insuficiência renal, né? Pode fazer até isquemia cerebral. E esses pacientes têm, infrequentemente, já tive 2 casos que precisaram ligar droga vasoativa durante 1 ou 2 dias para manter níveis pressóricos em 130, 140 milímetros de mercúrio, que é adequado nessa situação, nesses primeiros dias, até o organismo se readaptar. Em cenário da denervação renal para arritmia ventricular refratária, já em 2012, essa publicação de Okina mostrou que com 2 semanas já uma redução significativa da taquicardia ventricular e também, já na primeira semana, nenhuma ausência de fibrilações ventriculares. Então, a gente vê que não precisa esperar tanto para ter uma resposta do procedimento de denervação renal. Observamos também aqui nessa nossa publicação, nesse caso, após já o primeiro dia de denervação, uma redução significativa das taquicardias ventriculares, das terapias antitaquicardíacas ou dos choques, né? E que se manteve ao longo do tempo. E todos os outros 9 pacientes também, são 10 nessa série publicada em 2015, todos, né, a publicação mostra aqui com 1 mês, mas já no primeiro dia há uma redução intensa das arritmias cardíacas. Então, a resposta é bem imediata mesmo. Arritmias, terapias antitaquicardíacas e também dos choques. Resumindo esse trabalho do Félix Mafu, então eu diria aos senhores que pacientes com hipertensos resistentes, né, sem uso de medicamentos, né, foram submetidos à denervação renal por meio do cateter spiral da MEDTRONIC, desconectando, né, o cérebro dos rins. Dosagem de aldosterona e atividade renal plasmática pré-procedimento e no segmento aos 3 meses. Vejam aqui aos senhores uma redução significativa dos níveis plasmáticos da atividade de renina e da aldosterona. E também os níveis pressóricos, eles reduziram apenas naqueles pacientes com atividade de renina plasmática basal acima de 0,65. Aqueles pacientes com atividade de renina plasmática menor que 0,65, não houve diferença na redução dos níveis pressóricos. Gracias.
Muchas gracias, Rodolfo.
Thank you. Very clear presentation and an update of the current status of the state-of-the-art in terms of renal devastation. And I'd like to take to use the last minutes of this symposium to ask Dr. Daniela Coria and Dr. Martín Valdebenito, what is the current situation in your centers in terms of, are you receiving patients for renal denervation? Are you doing renal denervation? And these variables that allow identifying patients that will benefit the most, as Rodolfo showed, do you think they will make, they will improve the practice? Yeah, the truth is that in Chile, it's a little difficult because we have problems with the reimbursement for renal denervation, but we're working on it. We are now trying to develop renal denervation programs, and the social securities, the healthcare system is paying attention to it. We're fighting politically because we need to consider the professional fees. So, but we have reimbursement problems, as I said. I think that's going to happen it's going to pass too, and we're all pushing towards getting that. I think that will change with the new evidence that is coming out. So we are creating new programs, and I hope that in the next months or years, we have more volume and people is more interested in this technique. Doctora Coria? No, we don't have a lot of patients that required a renal denervation. At the beginning, yes, but now the number has gone down, and the same clinical cardiologists are not referring them. It's not that it's being rejected due to a financial issue. It's just that the clinical cardiologists are not sending these type of patients, are not referring them to us for these cases. Juan, since you're here in this webinar supporting us, how do you see that from the point of view of facilitation, facilitating access to renal denervation? Thank you, Aníbal. I am the director of the medical. I don't have a disclaimer, but I do say that I think Rodolfo's presentation is the possible key to this, to be able to discriminate which patients get benefits and which ones do not benefit so much, and when do we start having that benefit is the main indicator. As Dr. Coria said, they don't send patients because they are in that gray area where they don't know when they will have the results, what happens with the denervation. And those results that he showed, I think are the key to open that therapy. And I think that the private payers around the world will start to accept the treatment, perhaps for the most complex patients at the beginning, maybe not so much later, but I think in November, we will free that data. It's a key study for the United States, and that data will be published, and then ongoing papers will be published so that the procedure starts being indicated in general in Latin America and around the world. Thank you, Juan, for your comments. We are 15 minutes past the time for this symposium. As I said before, we could have maybe a specific bifurcation activity and another one to develop the program of renal denervation, but now we have to close because the scientific committee has allocated to each one of these activities. So for me as a moderator, it was very enriching to listen to all of you. I want to thank the speakers. I want to thank the interaction of the panelists. And once again, we have to respect the times. That's the reason why we want to still continue. We still want to continue discussing and asking questions. I'd like to also thank to all the attendees in great parts of Latin America. It's almost 9 o'clock. It's very late, and I know that there is a huge number of colleagues that are enjoying this symposium. So I want to thank you all, and we'll see each other tomorrow in the 4th day of the SOLACI-CACI 2021 Congress. Thanks, everybody, and good night.
Gracias. Buenas noches.
Buenas noches. Thank you.
Gracias. Gracias a todos.